Very good morning. It's my proud privilege to introduce our R. Jalapa Institute of Oncology Director and well-known oncosurgeon, good teacher, academician, and who's keen in doing a lot of research work in the field of oncology, none other than Dr. K.S. Gopinath, who is completed his FRCS from Royal College of Surgeons, Edinburgh, UK, a visiting fellow at the Memorial Sloan Kettering Cancer Center, New York, and MD Anderson Tumor Institute, Austin, Texas. His special area of interest, breast cancer and head and neck cancer, oral oncology, and cervical cancers. To name only 2 achievements or awards received by Dr. K.S. Gopinath, instead of reading that 112 awards, that is a recipient of the Padma Shri awardee for his excellent work in the field of cancer from the government of India. And he is a B.C. Roy awardee, which is exclusively given for the medical professionals in their healthcare delivery field for their exemplary work. Dr. Gopinath has received Dr. B.C. Roy Award in the year 2010. He is visiting our institution since 1995. Sir has completed 2.5 decades service in our academy. Initially, he is just providing only the patient care. Because of his commitment and insistence on converting this service providing department into teaching department, that came to reality in the year 2020, where R.L. Jalapa Institute of Oncology has been created, and Sir being the first director for that particular R.L. Jalapa Institute of Oncology, I request Dr. Gopinath to come and take over the further proceedings. Thank you, sir.
Good morning to all of you. Thanks, Dr. Sri Ramalo, for the kind words. Dr. Pradeep Kumar, our Vice Chancellor, is going to join us. Meeting was organized by the Department of Pathology. When the Vice Chancellor was discussing with me, he said, when people who are dedicated their lives to the development of the specialties, we should make use of them to the greater extent academic institution. Otherwise, some of the younger generations of the students and the faculty may not know who is who in their own specialty. Keeping that in mind, when, as I always believe, as is our pathology, so is our practice. William Osler said, many centuries ago. Today, when Dr. Kalyani K was organizing this, I said we'll get involved through the R.L. Jalapa Institute and make this program very useful to one and all. With this in background, I bring the greetings from the and our special pranams. You all know that this morning I was surprised to see that you are not doing very well. He is a great human being, founder, chairman. He has converted the barren land of Kolar into an educational hub. Today, all of us have seen in the last 40 years how the campus of the Devaraja Medical College. Personally, I knew him very well. He is a good administrator, good human being, and he wanted to do something more to the society than the usual politicians. So he named his institution on one of his mentors in politics, Mr. Devaraj Aras, who was the former chief minister. And whenever you meet him, he always listens to you what he wants to do to this institution. And he was a cabinet minister. We met him in Delhi. He took us to the parliament, shows the proceeding, how we do it. And he is a very good host. He accommodated us and others. He is such a great man. When he has come out with this concept, he is a great visionary. He may not be very highly educated intellectual, but he is a great visionary who thought of coming away from Bangalore, establishing in a place like this 70 kilometers. It is a very difficult task. He has done it. We pray special pranam. We pray God Almighty so that he should recover and still survive for a few more years. We know that he has also had a problem of oncological diseases. And today we all salute him for the work and we pray God that he should recover soon and will be back with us at the earliest. And I have to really thank our Vice Chancellor, Dr. Pradeep Kumar. In one of the Board of Management meeting, they have decided to start an Institute of Oncology. Because I always used to advise whenever I was invited for a meeting to various deemed universities, don't stop your education activities only at that level. There is a need to establish the super specialty department. Then only the universities will be complete. Now I'm seeing the completeness of the university, establishing the super specialty, and with the starting of and giving me a chance for another 2 to 3 years to establish both the academic. No more are the gone are the days where Gopinath used to say, I will treat like this. This is what I'm interested. I want patients to survive. No. Today it's an academic institution. We have to follow some of the scientific protocol, have an evidence base. Today, every student will ask me, where is the evidence for the treatment when I'm offering it? This is how the purpose of establishing this, convert this into an academic hub and see that the student who comes to undergo a training should go back and serve the society, and he should be a good ethical practicing value-based oncology. He should do it. That is the whole philosophy of establishing this institution. Yes. Which one? Yeah, you all know about this. Go back. Yeah, this is a beautiful picture taken by drone and still one of the lovely, majestic look of the building where it is there. And when the R.L. before even starting the R.L. Jalapa Institute, when we are having the Department of Oncology, we became the member institution of National Cancer Grid. It's a collaborating project of the Tata Memorial Hospital and Tata Trust. We all know the Tata Trust interest in contributing anything to the public at large. And the purpose of the National Cancer Grid is today we have 170 institutions or member institution of this. They provide us the various kinds of help to establish a good department academically, socially, financially, even to buy the drugs they negotiated, buy the instrument they negotiated. With this in background, we became the member of the National Cancer Grid, and also we are a member of the ICMR National Cancer Informatic, where we give the data of the cancer patients to us. Manjunath is actively involved in giving the information to NCDIR. And we are already into some steam. Now we have to develop it to an academic institution, which I was trying to talk to you. And it is an amalgamation of the oncology services. It is a constituent body. As I told you, I have to thank the trustees and the board of management and the vice chancellor who took an initiative to establish the various super specialty department with his broad vision. And today we can see a very super specialty over the years can become autonomous by themselves. And at present, we want to start off with the surgical oncology, medical oncology, radiation oncology. We have not forgotten all our colleagues in the various departments. They are all the collaborative partners of the whole of the Jalapa Institute. As we believe in oncology, it is not the one man. Gone are the days that Gopinath is the man or somebody else is the man. Today it is the development of the team. This is the collaborative network. We have also not included in the Indian Institute of Science and Jawaharlal Nehru Institute, where we are doing collaborative research work with them. This is our aim to take it forward, make it a good comprehensive cancer center. Every Friday, you all know that we are doing a multidisciplinary tumor board. All patients are discussing the multidisciplinary tumor board and treatment are followed. And majority of our patients we are catering today is low income group, including the Arogya Karnataka scheme and BPL patients. Now I request Sri Ramalu, you should get the Andhra Pradesh Rajiv Gandhi Arogya scheme, because border town people coming to Bangalore to take the treatment without the scheme. If you get the scheme approved, we will treat a good number of patients. It will benefit a lot of people in the border district. I humbly request you to get it organized and see how we can get the affiliation of the Rajiv Gandhi Arogya scheme of Andhra Pradesh. And surgical oncology, as I told you, at present we are more interested in patient care and education. We have to have a thrust on research. We already have the molecular lab headed by Suresh and others. We will utilize them to do a lot of molecular work, and we want to have some discussion with Dr. Das and Sharath also, how we involve that team into do the thing. First, our main basic aim is to give a good conventional treatment, evidence-based treatment, economy-based treatment, so that we should outcome results should be good. Then you take it to higher up. Last year, between the various surgical procedure in 220, in spite of the COVID, we had the 226 cases. This year, we already have the 260 cases. And I really thank surgical oncology and head and neck led by Dr. Azim, who got involved in doing various countries in spite of the COVID. And I forgot to mention in the National Cancer Grid, we had a donation received from the National Cancer Grid, oxygen concentrators and BiPAP machines. And really we thank the Dr. Pramesh, who heads the National Cancer Grid, who provided these things. It was very handy during the crisis of the COVID. And radiation oncology, you all know Manjunath is the king of the Kolar, I call him always. And we have a cobalt and brachytherapy services. We have a radiation physics with RSO involving in the better treatment planning and execution. And at present, concurrent CTRT protocols and neoadjuvant CTRT protocols are going on. He has also a radiation oncology department along with the allied sciences in helping them to get involved in some of the certification courses and training of the nurses in chemotherapy administration. As it's already the part of the ICMR data collection center. Next, we have to improvise on the medical oncology services. At present, we are giving conventional neoadjuvant, concurrent, adjuvant chemotherapy protocols, palliative, and in selected cases, metronomical therapy. And we have to increase on the certification of the nurses in chemotherapy administration or create nurse oncology courses, those who have undergone in general nursing, so that train them in radiation, medicine, surgical oncology. That is, and also as we know that we are lacking in the pediatric oncology, hemato-oncology, geriatric oncology protocols, we have to establish it. With Varsha being with us, she has to help us even the palliative care for all these patients, which they are all involved in day-to-day care. And these are the few of the publications we have done in a short time. Dr. Abhay and their team have publications in few of the things. Recently, there is a nice book on breast cancer comprehensive treatment written by one of my good friend, Dr. Bose from Chandigarh, PGI, and we have contributed a chapter, Comprehensive Management, Hereditary Breast Cancer. Dr. Abhay and me were the authors of the chapter. And ongoing research projects, I already told you, Dr. Azim is involved with this from last 3 years. DBT project, Virtual National Oral Cancer Institute collaborative project with Jawaharlal Nehru in Cancer Research. and SDUMC as a regional center. And these are few of the initiatives that the young oncology group has started doing it. And our future is establishment of multidisciplinary cancer center, educational initiatives of MCH surgical oncology, DM medical oncology, establishment of preventive and palliative care services, integrating the allied health sciences and involvement with the allied health sciences, and give more importance to CAMP program, where without much of the cost-effective thing, we can give a good either a palliative supportive therapy or urgent treatment to the suffering cancer patient. Ladies and gentlemen, I'm going to give a small talk on pediatric solid tumors, which we used to practice. Once the specialty has come up, we have slowed down and referred all the patients to pediatric surgical oncologists. There is a need for reforms for cancer care in pediatric malignancies. Gone are the days of understanding of the cancer as only the purposeless proliferation of the cells, which Vinay Kumar book used to highlight as for the basic undergraduate student. Today, cancer is a complex heterogeneous disease from tissue of origin to cancer cell, stem cell, and circulating tumor cells, and a genotype centric which changes cancer genome to select patients for every treatment. As I used to tell you in the past, we used to have one modality of treatment for Wilms tumor. We used to give 60%, addition of radiation has brought in change, addition of chemotherapy. What we used to call as tragedies in the past has become trophies in pediatric malignancies, especially the Wilms tumor, rhabdomyosarcoma, osteosarcomas of the bone, lymphomas, leukemia. Today, we used to call them that what tragedies has become trophies in oncology because of the concept of multidisciplinary team involvement. And dilemmas in oncology still continue. As a clinician, we think in one direction, but patients think in the other direction. Still, we have to fight to get a predictive markers and prognostic markers. And today is the day for personalized medicine. Even in a pediatric population of the oncology patient, we have to think of how we can use personalized medicine and precision therapy. And there is a need to start tissue repositories. Dr. Suresh is here and Dr. Kalyani is here. If we can think of establishing a tissue repositories so that we can take up various kinds of innovative thinking, development of the markers and other things, because every human being in India is different. If you take, for example, mucous membrane behaves differently in different parts of Indian subcontinent. If we have our own biorepositories, we can do some studies, really study why particular disease or particular cancer is more common, prevalent, what preventive programs we can do, identifying the genetic markers for diagnosis as well as for therapeutic purposes. And facts of the solid tumors, as I told you, 6 to 8% of all tumors, we still see them in locally advanced diseases. Many years ago, we were not using the concept of neoadjuvant. Today, neoadjuvant chemotherapy has come into big solid tumors. And we all know that pediatric tumor, when the, the neonatology is advanced so much, even in the neonatal period, the specialty of imaging has brought in a revolution in identifying the various types of abnormalities. Even we can study the various types of tumors which is detected, and oncofetal oncogenicity is one of the important factors in development. It differentiates from adult tumors where the pediatric cells more faster, oncofetal oncogenicity, the duplication will be more. Even during that phase, when they do the routine scan, we can pick up Wilms tumors and other types of malignancies, even in that period when they undergo neonatal ultrasound during the follow-up period. Combined modalities of treatments have brought in a big revolution. These are the common pediatric tumors we see in our country. You can see that these are the common tumors. These are the youngsters. This is on some of my old slides, which I preserved in my archives, selected for this presentation. And Indian Council of Medical Research and formed a big group. Consensus document has been prepared by them in the management of pediatric lymphomas and solid tumor. This is one of the things where we use it to practice evidence-based treatment for pediatric cancers. There is a changing phase and phase of surgery in oncology. and also in the treatment in various solid tumors. We know that earlier we were depending on clinical TNM staging system. Then there is advances in technology, and we have seen the various kinds of monitoring of the patient, assessment of the child, even from the birth, even in the neonatal period, preoperative evaluation, how to manage intraoperatively, postoperatively because of the technological advances. Even before the patient taken up for treatment, we all knew the advances in imaging, starting from conventional X-rays, digitalization of the X-rays, ultrasound, modification, 4D to the PET-CT today, and 3D printing is coming in a big way. We can utilize. This is how we have seen that how the improvement in technical development help us to stage the disease properly, plan the treatment. And you know that human biology is the king, development of technology is the prince and princess, and treatment of cancer lies in our own genes. And MDT in oncology, what we used to call as bigger and biggest of the operation, like amputation and hip disarticulations come down to limb preserving procedure. That is one of the advances because we are able to study through the images where we can really do the organ preserving procedure. And of course, the quality of life. From conventional surgeries, we have gone into the minimally invasive surgery, and people have started using robotics even in a pediatric surgical population in selected individuals. Wilms tumor is the commonest tumor. As I was telling, when we were in Kidwa, we used to see very locally advanced diseases. Many times polycystic disease and multicystic diseases have received chemotherapy. To avoid that, against everybody's wishes, we started. Those were the days. Even our teachers used to say, don't palpate the Wilms tumor clinically, it will spread. In spite of that concept, imaging of the ultrasound was not too good. When the new ultrasound came, we thought, let us do the needle biopsies. Against everybody's, people used to fight with me. You have done a wrong thing by doing FNAC. But afterwards, we proved that we were right. Do an FNAC, obtained a tissue diagnosis. People, our pathologists used to differentiate blastomal type, non-blastomal type, where it carries a good prognosis. We started giving neoadjuvant chemotherapy. This is where we had this publication. Many times we have to think to the local surroundings. Everything we cannot go by evidence-based medicine. What is good to the present, innovations has to come like that. It may be a failure. One day it may become a success. That is how one should look at it. This is where we are able to do the utility of fine needle aspiration cytology and published it in various journals. And also our molecular pathologists got into those sporadic Wilms tumor, and we have seen the cytogenetic profiles in some of these places. And those days, mesoblastic nephroma was one of the important condition. It is a pre-malignant condition, not a cancer. You are able to detect it and plan the treatment. And this is one of the classical examples. He was a deaf and dumb. As our Vice Chancellor was telling, it needs a psychological assessment to the families and the parents that how the child, they should treat it because they have only one child. He has congenital deaf and dumb. They were scared to have a second baby. They were scared to subject the patient. That is why we have started the psycho-oncology department early 93, 94, in 91, 92 in HCG, Bangalore, what we used to call Bangalore Institute of Oncology. He came with the Wilms tumor. We convinced the patient, and then we did the surgery. Today is more than 30 years. He came to me 3 weeks ago that he's working in Amazon. He has become one of the technical expert. Now he has a problem. He has fallen in love with another colleague. She is also a congenital deaf and dumb. Shall I marry? What will be my future happens? This is where these children, when they live long, adult problems will start. We have to handle them till they die. Then I told my psycho-oncologist, you are still practicing with us. Now you counsel these people how you do it. Any of the molecular studies has to be done to answer their questions of how their future generations will be. Can they lead a normal biological life? See, this is how in a pediatric population, we see various kinds of things. It does not end in a treatment. You have to follow him. There's another person operated along with him. He came few months ago with a one kidney and a nephrotic syndrome. And we have sent him to the concerned specialist. Is he a fit for transplant? So many things you have to keep on thinking because the follow-up things in oncology is much more accepted They come to us even in various fag end of their life, even after 30 to 40 years. So follow-up of these patients are very important. Quality of life to these children. Psycho-oncology is still not very well developed in this country. Whenever we are starting the institution, we should development. These are the allied subjects which is more important in a quality care of the patient. And the germ cell tumor, which you are all know, that's a curable tumor. I don't go into the more details. Hepatoblastoma, they are all surgically oriented, operable cases with a good imaging. We can assess the functioning of the liver and plan for hepatectomies. Or nowadays, there are other non-surgical methods come into picture. In selected population, we can use this. And rhabdomyosarcoma, another curable children. We see them in an advanced disease. At such time, we use CTRT combination, and in selected population, we do. This is one of the young child, 1.5 years, came with a sarcoma. Neither it was a rhabdomyosarcoma or the fibrosarcoma. Difficult to differentiate. We gave neoadjuvant chemotherapy. It shrunk. Then we want to do hemimandibulectomy. These are not routinely we do it. For us also, it was a challenging. Then we use our 3D printing. We did a mandibular resection. Use the 3D concept to develop using the fibula. And this is how the surgical knives and the cuts were made, where to make the cut of the mandible, where to make the cut on the fibula. You can create by using the knives. And this is how we created the whole of the mandible and the reconstruction using microvascular technique using fibula. This is how one can use the technological advancement, imaging advancement in the management of even for a pediatric, what we use in adult situation. And another child is my own cousin, and he had a rhabdomyosarcoma of the bladder neck, took the conventional treatment in various centers, came to me at a stage when there is no response. What to do was the question in front of us. And we decided that child tumor was increasing, not respond to third, fourth generations of chemotherapy. We took a chance. We did the surgical procedure. And this is where the management of the pediatric intensive care is very much needed in every institution who treat this thing. Still, we lack the PIUs. Very few centers have got it. Very few training centers and certification courses are available. We took the chance. We did the whole thing, removed the whole team. It came out. And these are the selected group of people we do it, because post-operative, we lost the child on the 5th day because the volume of tumor size was so big and volume of blood loss was so big, there was no compensation. Went into cardiac failure. We lost on the 5th or the 6th day. This is where we have to concentrate on these kind of things. Though they are advanced, many times they are very with the palliative technique. We have to develop the good pediatric intensive care unit to manage these type of cases. Ladies and gentlemen, we are in the era of molecular pathology. Today we can see the whole of the thing. Reason for recurrence, we have to find out. Role of targeted therapies, role of genomic. This is what happens in the rhabdomyosarcoma. I don't go into the details. Experts are going to speak on that. And you have to hear from the better people who have done the original work. And these are the osteosarcomas. In the past, amputation, bigger and biggest of the operation. Today, we do give the neoadjuvant treatment protocol. Osteogenic sarcoma has brought in various changes. I don't go into the details. These are one of the cases which came to us. Patients do not want to undergo. We gave a neoadjuvant chemotherapy, exercise, and use a very high-end processes, which used to cost 4 lakhs at that time. Many of our patients were not able to afford. Then we thought of utilizing what is called as extracorporeal irradiation and reimplantation for a limb salvage procedure. Even with the cobalt treatment, we can do wonders by using these procedures. Even in a campus like this, we want to develop this technology and give it to the people suffering from especially the peripheral limb sarcomas. And this is what we did after the radiation. We put it back, and today patient is 15 years. She has produced 2 children and leading a good life. She is able to stand on the whole leg. The main aim of every human being, stand on their leg and carry out their activities. This is what we given it to these type of patients in a local setting. We have to plan our treatment according to our thing. Many times we cannot go with the NCCN guidelines or ASCO guidelines. Indian problems, Indian solutions we have to find out. And this is what we have achieved over the years. And as I already told you, and today need for establishment of pediatric oncology, multidisciplinary team of surgical oncologists, medical oncologists, radiation. This thought came to my mind. There was one Tapan Hazra, radiation oncologist at Memorial Sloan Kettering. 1984, he established a separate department, including all this type of people. In this country, still we are not able to do it. We should do it because some of the pediatric tumors are curable cancer. They live for a long time. Then still we have to develop the genomics in Indian population, both in adult and pediatric tumors. Our purpose is to educational initiative like what we do for adult. For all the pediatric subspecialty, we should develop it. At the end of the day, whatever we do, economizing the cancer care is more important in our setups because everybody is not in the metropolitan cities, everybody is away from it, so that patients live in any part of this country. We should believe in economizing the care and economy-based treatment, and our teaching should be value-based, good oncologists we have to create. Thank you, ladies and gentlemen, for your patient hearing. Thank you. We hope with all your support, we want to create the value-based treatment policies in R.L. Jalapa Institute of Oncology. Thanks for the management, thanks for the trustees, thanks for the Vice Chancellor and everybody has given me this opportunity. Thank you.
Thank you, sir. Any queries or clarifications required for the senior surgeons and other my fellow colleagues, those who are here? Gopinath sir is here to clarify your doubts. I don't think anybody will have any doubts here, but the take-home message, as sir has given it to all of us, is multimodal treatment. Don't jump to conclusion in taking the and selecting the treatment modality. Completely work up with the recent trends of investigations. Keep the patient family and patient in loop in taking the decision about the treatment, and wherever it is required, palliative care, and preserving the functional status of that particular organ. And if the facilities are not adequate enough in the place where you are treating the case, just tap the facilities which are there in the other centers in consultation with the other colleagues of ours. Ladies and gentlemen, in our institution, excellent surgical oncology unit led by none other than Dr. K.S. Gopinath, medical oncology team, head and neck surgical oncology team, radiation oncology team. We have the excellent genomic lab, very good pathology department, radiology department, all other ancillary department as sir has mentioned. Please take all these departments into consideration before you take a final call on the patient. Whether to successfully treat the patient here or to refer is one. Number two, if we decide to treat the patient here, what is the best multimodal treatment we can extend to that particular patient? I assure our Padma Shri awardee Dr. Gopinath, the oncology related government schemes in Andhra Pradesh and government schemes in Tamil Nadu. Will make it available in our institution, sir, for the patient care. With these few words, I just conclude my remarks, thanking once again our Gopinath sir for accepting to be a director of R.L. Jalappa Institute of Oncology, which is providing a comprehensive oncology care to the needy patients in and around Kolar and Kolar district. Thank you, sir.
Actually, it's a beautiful office. There was a patient who worked for us. A child about 4 to 7 years old. I don't know if it's osteoma. This fellow at age 15 fellow developed
Good morning, Dr. Vinay Kumar. Good morning, Shashi. Dr. Pradeep here.
And hello, Dr. Pradeep.
Hi, Rajwarrior sir. You're muted, Rajwarrior. Sir, great to see you all. So happy to have all of you.
Hi, Vinay.
Rajwarrior, can you please repeat what you said? We couldn't hear.
I said hello and good luck to
Yeah.
the meeting. It's night here, so.
Yes, sir. I know, sir. Thank you for keeping awake late night. And
No, not at all.
I'm very grateful to all of you who are sparing your sleep and being with us.
I'm waiting to learn from Vinay. That's what I'm doing.
We are in the midst of a assessment and accreditation by the National Accreditation Body on Monday. So we are running around from pillar to post in the midst of this webinar.
Oh,
So if I am not all throughout present, I may be excused. Dr. Vinay Kumar, Shashi and Rajwarrior sir. Rajwarrior sir has been my mentor. He was my vice chancellor when I was in KMC Manipal.
proud of you.
Dr. Pradeep, after
Yes, sir.
landing me here, you are going to disappear. That's not acceptable.
No. I'm not going to disappear. In case I walk out for some emergency, kindly
Okay.
excuse me. I'll be
Understood.
here. Yeah.
Understood.
Kalyani, please go on.
Yeah.
Starting with the scientific session 1, we have with us very special and eminent speaker, Dr. Vinay Kumar, to speak on bench to bedside pathway to the discovery of molecular basis of hematophagocytic syndrome. We are very fortunate to have you, sir, with us today. From reading your books as a postgraduate and undergraduate to seeing you and listening to your speech is more than a dream come true, sir. Chairing this session, we have with us Dr. Kalyani R., organizing chairperson and professor and head of the department pathology for this session.
Good morning, sir. I have the immense pleasure and privilege in introducing Dr. Vinay Kumar, then speaker for the next session. Lowell T. Gogesal, Distinguished Service Professor of Pathology at the University of Chicago. He has pursued MBBS from Amritsar and MD Pathology from AIIMS, New Delhi. Sir is a faculty in pathology at Boston University School of Medicine. And Sir is also director for the pathology course at both the Boston University and UT Southwestern at Dallas, and also Associate Dean for the Medical Education. Along with late Dr. Stanley Robbins and Dr. Ramzi S. Kotran, Dr. Kumar has co-authored the Robbins Pathologic Basis of Disease and Basic Pathology for past 42 years. Currently, he is the senior editor and author for both textbooks now in their 10th and 11th edition respectively. Sir, we are very much eager to listen your talk. The title of the talk is Bench to Bedside, Pathway to the Discovery of Molecular Basis of Hemophagocytic Syndrome. Over to Dr. Vinay Kumar.
Sir, you can share the screen, sir.
Okay, this will stop sharing other screen. Okay, that's fine. What's going on here? Okay, I think that looks all right.
Yes, sir.
Okay, well, good morning and good evening, depending on where you are. At my place, it's about 11 p.m. at night, but it's not late for me. I usually don't go to sleep until 2, so it's fine. I must say at the very outset that when Dr. Pradeep Kumar and others invited me to give a talk here, I said I'm neither a pediatric pathologist nor I'm an oncologist. I'm just a basic science researcher, and I'm not quite sure that what I have to say, or that I have to say something that will be in keeping with the theme of this particular symposium. But Dr. Pradeep Kumar has known me for more than 10 years, and he's a very compelling person, and he would not take no for an answer. And so I told him, this is what I think I can speak on. He said, yes, that's fine. So if this seems out of place, then I'm not the person to blame. Dr. Pradeep Kumar is the person to blame. And if you get something out of it, I'll be very delighted. So as the title says, Bench to Bedside, Pathway to the Discovery of Molecular Basis of Hemophagocytic Syndrome. Basically, what I want to do in this is I'll give you sort of a brief overview of natural killer cell biology, something very close to my heart, which I've been working on literally since 1974. And then sort of walk you, it's a journey. And especially, I constructed this journey especially for the younger people in the audience, and to tell them how important, so why this lecture? So this lecture, let me see if I can get this screen thing out of the way. Okay. This lecture is to investigate how investigations of a basic cellular and molecular biology of NK cells in mice led to the discovery of the molecular basis of a fatal human disease. It is pediatric. And the development of a diagnostics test for the disorder, and provided novel insights into the pathogenesis of a related group of disorders. And I often hear people saying, especially in India, that, oh, you know, basic science research, you know, it's not for us, and it's for more countries which can spend more money. It's completely wrong, because basic science is the engine of medicine. In fact, New England Journal of Medicine, as you know, has a feature every couple of weeks, which says, you know, from basic science to clinical medicine. So today, especially these days, the transfer of knowledge from basic science to clinical practice is very rapid. It takes no more than 3 to 4 or 5 years. Okay? So I think I want to emphasize to the younger people in the audience that do undertake basic science research. It is not meaningless. Working on Drosophila flies is not meaningless. Okay, almost all the major signaling pathways in human were found actually in Drosophila, the hedgehog signaling pathway. Okay, and various other pathways. So so that is the purpose of my presentation, and I'm thankful to the organizers for giving me this opportunity. And I must say, I was very, very impressed by Professor Gopinath's presentation about the Ireland Jalapa Institute of Oncology. You people are doing absolutely the right things. Tissue banking, genomics, multimodalities, and having a multimodality conference every Friday before you decide on the treatment of any particular patient. And I think what you call ancillary departments are actually becoming the key departments now. In my department of pathology, we do all the genomics. So without what we do, nothing can go forward. Every single cancer patient has 1,200 genes sequenced. Some for discovery, some for treatment, and some for perhaps future treatments. So it's wonderful. It's great to hear that you're doing all these things, and I'm very thankful for you to have invited me so that I could see what's going on at Kolar. Okay, now, okay, so I left Ames in 1972 and went to Boston and started doing research, and was very fortunate that within 2 years, we were able to we published a paper. We were studying resistance to leukemia in mice. And we discovered that this resistance was caused not by T cells, B cells, or macrophages, but a novel class of lymphocytes. And this was basically unknown at that time. And the paper was published in a very prestigious journal, but nevertheless, most people sort of didn't pay any attention to it. And then came a year later, a paper from Karolinska Institute, where they said there is a new population of cells called NK cells my screen is being, okay. That there are non-B cells that kill retrovirus transformed cells in vitro without prior sensitization. So it was very clear that they had found the same thing in a different system. And also the next year in 1975, the NIH group finds similar cells to those found by Karolinska group. So all this happened in 74 and 75. Okay, but it took quite a bit of time for the general immunology community to accept this. So just briefly, I know you probably know all of this before, but I'm just going to give you a little background here so that you will follow what I did and where I did and where I reached, so to say. So it was in 1986, actually, almost 74 to 86. Okay, you can calculate, okay? Almost, it took 6 to 12 years before the mainstream immunology literature accepted it. And then myself and Dr. Lanier, who works on humans in 1986, were asked to write a definition of these cells and publish in Journal of Immunology. And so NK cells are a distinct population of lymphocytes that can kill tumor cells, virus-infected cells, and some normal cells without prior sensitization, which unlike T and B cells. NK cells, unlike T cells, have no memory and do not require co-recognition of MHC class I molecules for target cell lysis, but MHC molecules regulate their function. It's a bit complicated. I won't go into much more detail. And people often think that NK cells only kill. They actually are a very potent source of cytokines by which they regulate the function of macrophages, for example. NK cells make more gamma interferon on a per cell basis than T cells do. And these cytokines include interferon gamma, TNF alpha, and GM-CSF. So how do NK cells recognize abnormal cells? How do they recognize virus-infected cells? How do they recognize tumor cells? And they do so by a strategy which is completely different from that of those of T cells. And the strategy was elegantly described by Klaus Charest at Karolinska Institute, one of the persons who was in the original paper also. And he said the NK cells have two classes of receptors, inhibitory receptors and activating receptors. The inhibitory receptors recognize something on the normal cells. And this recognition leads to turning off of the NK cells, okay? So that the activating receptor, and even if it recognizes its target cell, there is no lysis. So off signal dominates over the on signal. And this is a normal cell, and this is the NK cell from the same person. This recognizes a normal structure, and these normal structures are MHC class I molecules, which every cell in the body except red cells has. So every cell is protected from being killed by your own NK cells by recognition of the system. Now, what happens when there's a virus infection or the transformation? Very often, the MHC class I molecules that are shown here in the form of this blue circle are extinguished or they're downregulated. So the off signal becomes weak and the on signal becomes strong, and there's killing. This is exactly what you want. You want an abnormal cell to be killed. And as an extension of this, if these are your NK cells and these are my normal cells, for this NK cell receptor, there is no self, okay? Because self for it is this. And so what happens? It looks to this receptor as absence of self. This is why it's called the missing self hypothesis, and it's killed. And this happens in allogeneic bone marrow transplantation, for example. So as I mentioned to you, NK cells have two classes of receptors, inhibitory receptors and activating receptors. And I won't go into, many of these we cloned and identified, but the one that I will talk to you a little bit about now is one which we called 2B4, and now it has an official name of CD244. And this is an unusual receptor that can both turn off the NK cell and turn on the NK cell. But we will focus on this particular aspect of it. Okay, so how did we discover 2B4 or CD244? What we did was we first purified mouse NK cells by flow cytometry and cell sorting. And this is actually the very first picture ever published of highly purified mouse NK cells. It was done in 1985, as you can see. These are tumor cells to which they're attached, and they're going to kill them. Okay? So we purified these cells to homogeneity, and they have granules in them. Sometimes they're also called large granular lymphocytes. And so we took these highly purified mouse NK cells, and we said, we will make antibodies against them. Our hypothesis was that some antibodies that we form will be against inhibitory receptors and some active receptors because they're on the cell surface. So we did this immunization protocol, and we generated dozens of monoclonal antibodies. So after purifying them by cell sorting, we made the antibodies, and then we said, how do we know these antibodies are against a receptor? I mean, there are so many structures on the surface of your cell. How do we know they're against a receptor? Well, we said, if the antibody either activates the NK cell or inhibits it, it must be against either an activating receptor or inhibitory receptor. So our screen was to see what were the functional effects of these antibodies, which we did not know what they were against, in an NK cell assay in vitro. And those which had a functional effect, we said, these are interesting. We will follow them up. Okay. So I want to show you this slide because it will come again and again, and it will be useful for you to sort of see this in mind. So this is the wiring of a killer lymphocyte, any killer, NK cells or CD8 T cells, doesn't matter. It's very simple. They have a receptor outside, okay, and then they have receptor to which the antigen binds. And once the antigen binds, there is a signal that comes from it, which is signaling complex is in the cytoplasmic portion of the receptor. And often there are, phosphate P's there. And depending on the cell, there are a series of other molecules which form a signaling complex. These signaling, after antigen binding and the signaling complex activation, there is biochemical activation of signals, the activation signal, which then eventually lead to the delivery of effector molecules, which is the ammunition. For example, in this case, one of them is perforin, okay? Others are granzymes, and these are the two main effector molecules. So just keep in mind this sequence of receptor, antigen, binding of the antigen, signaling complex, biochemical activation signals, and effector molecules, and killing of cells. Now, something that immunologists use as a trick, which is endocrinologists also know this thing, antibodies against a receptor often mimic its action. Remember, antibodies to TSH receptor mimic the action of TSH to cause Graves' disease. So if you have an antibody against the receptor, then it will often mimic the natural ligand of the receptor, even if you don't know what the ligand is at that time. Okay. Okay, let's go further. So here we had anti-2B4 antibody. We made antibodies, and we said they were. I told you they were against the 2B4 receptor. We found out in a different complicated way. So here we have anti-2B4 antibodies. The antibodies bind to the receptor and mimic as if it's the ligand of the receptor. And what does that do? What that does is it causes the cell to get activated and the target cell gets killed. Okay. So cell killing occurs. Let's go further. Screen is stuck. Okay. Okay, so I was telling you, about the discovery of the 2B4 molecule and its receptor. And as I just gave you this little sort of scheme of how we screened them, we found these 2B4 antibodies activate NK cells killing in vitro. Once we realized that these are antibodies against a potential receptor, we said, to learn much more about it, we will have to clone them. So Matthew, who came actually, Dr. Matthew, who had actually been trained at National Chemical Laboratory near Pune, joined the lab, and he was a very good molecular biologist. And I said, Matthew, your job is to clone TP2B4. So he cloned it. He cloned it, and we found the structure had a very classical, it was a member of the CD2 family. It has two or four loops outside, B domain and C2 domains, a transmembrane portion, and cytoplasmic domain of these. This had a particular tyrosine motif, okay, which was called immunotyrosine switch motif because it can switch on the cells and switch off the cell. Okay, and there are 4 or 5 other members of this family. For some reason, the lower portion of my screen gets cut out, so I can't see underneath, but it doesn't matter. I'm sure you can see it, okay? So we said 2B4 is a member of the C2 subfamily, and then a very, very important thing, okay? And when it binds its own ligand, it recruits a molecule which was called at that time SAP. It was called SAP because it was first discovered as an adapter molecule used by a receptor called SLAB. So it was called SLAB-associated protein, a small protein which had no signaling capacity but recruiting capacity. It could recruit fin tyrosine kinases or phosphatases which activate or inhibit the cell. Okay, so that's an adapter molecule, and because all of these 4 different molecules had the same immunotyrosine switch motif, all of them could recruit SAP, okay, and function through it. Now, here came the big thing as far as that excited us, which is why we went from the bench to the bedside. In 1998, Cox Terhorst in Boston discovered and published in a full-length Nature paper that the human disease called XLP, X-linked lymphoproliferative disease, is caused by a mutation of the SAP molecule. Okay. Suddenly we said, this is very interesting because there's a human disease caused by a mutation SAP, and SAP we know also is used by 2B4. So we got very excited about it. We said, well, let's go a little bit more towards all the time we had been working with mice, let's go into the human now. That's the transfer from bench to bedside. Okay. So XLP is very well known now. XLP is an immunodeficiency disease, specifically immunodeficiency to Epstein-Barr virus infection. And those boys, this is an X-linked disease, so only males suffer from it. The mortality is 85%. And more than half of these die of a condition called fatal infectious mononucleosis. And the hematologists amongst you know what I'm talking about. Okay, and it is a virus-induced hemophagocytic syndrome. And so mutation in SAP causes the XLP. Okay, and this is I'm sure many of you who work on hematology or hematopathology have seen pictures like this. This is hemophagocytosis of red cells and immature myeloid cells by macrophages within the bone marrow. This slide was given to me by my colleague, Dr. Gurbuxani. Okay, so from mouse to man. So we started with the knowledge that SAP mutation causes XLP, which is a hemophagocytic syndrome. So what happens? Okay, what happens is this, that there's a mutation in this SAP gene, so the SAP protein is not functional. There's a failure of activation signals, failure of killing, and failure of killing of EBV infected B cells, X-linked lymphoproliferative disease. So this is the whole pathway by which XLP occurs. We didn't discover this thing. I'm just giving you this as a background. Okay. This was discovered by Cox-Durhurst. So we said, oh, you know, SAP is something which is used by 2B4 also. Okay. We wondered. It was pure curiosity. This is where I'm saying, you know, you're doing basic science. We were really never particularly, we had done no work in human beings. Okay. All our work was in mice. And of course, as you know, mouse is very commonly used for study of the immune system. Okay. And I'm not a clinician. I don't see patients. Okay. So I really I had nothing against human studies, except that I was not equipped for it. I was not trained for it. I was not equipped for it. But then the curiosity came because of the findings that we had with XLP and finding that we had cloned the 2B4 receptor, which bound this molecule called SAP. And we said, if SAP mutation can give rise to XLP, okay, then we wonder if a mutation which is in 2B4, which is proximal to the SAP protein, there might be another syndrome, which is another hemophagocytic syndrome caused by a genetic defect in 2B4. So imagine, you know, if as I told you about the wiring of the killer cell, there's a receptor, there are cytoplasmic portion, which has usually phosphotyrosine motifs, okay, and then there is a signaling complex, and there is effector molecules. So whether the mutation is here or mutation is here, the result should be exactly the same. There should be another hemophagocytic syndrome, like XLP. So we started to, for the first time, we started to study we scoured the literature, okay? And I think pediatricians will know what I'm talking about. We scoured the literature to see what are the other hemophagocytic syndromes, because we were looking for a syndrome which would be caused by mutation in 2B4. Our focus was 2B4, because that was our molecule. We knew a lot about it. And we were interested to see if it might be relevant for human disease. Okay. So the hemophagocytic syndrome are of two types, inherited and acquired. Acquired are far more common than inherited. Acquired syndromes occur with malignancy in transplant recipients and autoimmune diseases. And oh, okay. All right. The host says I disappeared from the screen. Okay. So we started saying, what are the other hemophagocytic syndromes? Okay. Well, Chitti-Kakashi syndrome is neutrophil defect. Criscelli syndrome is also a neutrophil defect. This was an unknown familial hemophagocytic lymphohistiocytosis. Okay. And for a long time, it was believed actually to be a malignancy of macrophages. So I'm going to use the abbreviation FHL because it's too tedious to read out this whole name. Okay. Okay. So we started reading about them. We said, this looks interesting. So at that time, it was well known that it's an autosomal recessive disease. It affects previously healthy infants. The frequency is very low, 1 in 50,000 live births. It's rapidly fatal without treatment. These infants get trivial viral infections and they die. And they die not, they die because they can't control the reaction to the virus. Okay. So, and the only treatment is bone marrow transplant, okay, which of course is not easy in very young babies, although it's done now. It's more difficult than in adults, but it's done. So FHL is characterized by fever, hepatosplenomegaly, pancytopenia. Pancytopenia because the hyperactivated macrophages and they phagocytose. They phagocytose red cells, white cells, platelets, everything. Okay? And there is a massive activation of macrophages and activation of CD8 T cells. And there are inflammatory cytokines pouring out, what is called the cytokine storm. So these children, these babies die actually of inflammatory, of cytokine storm, which is of course well known now in COVID and many other conditions. Okay, and at that time, there were some sort of rudimentary studies showing that in FHL, there's a defect in T cells, defect in NK cell function. But when you study the immune system in a person who's already very sick, as these infants are, you don't know whether the defect is the cause of the disease or the effect of the disease. So, you know, my graduate student, Susan Stepp, comes and says to me, you know, could 2B4 be involved in pathogenesis of FHL? You know, you're looking for a human disease which has hemophagocytic syndrome, which may be caused by a mutation in 2B4. Could it be that? Could it be that? It seemed to be a reasonable candidate, except around that time, a very large group of distinguished investigators in France, led by actually Elaine Fisher, published a linkage map for the FHL, and they studied families, and then they did linkage analysis, and they mapped the FHL gene, or the gene that caused FHL, to chromosome 10q2122. Okay, and they said 2/3 of the FHL patients, their gene can be mapped to 10q2122. Okay, all right, very good, very good. And as we read this paper, we realized our hypothesis was wrong. Susan Stepp comes to me and says, boss, our hypothesis is incorrect. Well, why is it incorrect? It's incorrect because the mapping of the FHL gene was to 10q22. The mapping of 2B4 gene, which we had mapped previously, is on 1q23.3. So they map to different chromosomes. So 2B4 mutation can't be the cause of FHL. There is some other gene there which is the cause of FHL, not 2B4. And then we said, I said to Susan, slides start moving. Okay. Yes. Okay. So I say to Susan, what else maps on 10q22? Okay, it's not our gene. This is not the cause of FHL. But let's see what else maps here. Perforin maps there. Very close to what was called the FHL locus. And we said, Eureka. We said, Eureka. We have found the cause of FHL. How? Well, how? Think about it. We were looking for a mutation in the receptor. Okay. We found a mutation in the perforin gene. In fact, the defect could be anywhere between the receptor and the ammunition, the molecules that are used to kill the target cell. So the FHL gene defect could be anywhere from here to here. And since the FHL locus and the perforin locus map at the identical spot, the likelihood was very, very high that FHL was caused by a mutation in the perforin genes. But so this was our hypothesis. Okay. Now, it's good to have a hypothesis. Okay. But what do you do next? Because you have to do something after this thing. You need patience. Okay. So we had no patience. Okay. So we said the hypothesis is the primary inherited defect in the 10q22 linked FHL is impaired perforin mediated cytolytic function. So what do? You remember that paper I showed you from France? I made a phone call to them and said to the senior author, Genevieve de Saint-Basile, we know what causes FHL. Send us coded genomic DNA from 4 patients and 4 controls. And in 2 weeks, we'll tell you which are the patients with the controls. She said, what are you going to see? I said, well, we can't tell you that. If we are right, you will know we are right. And then we can discuss further. So they were very nice people. We had never met them before. They didn't know who we were. They may have known us from literature, but we had never met at a meeting because they went to immunodeficiency meetings and I went to immunology meetings. Okay. But within 3 days, genomic DNA is very stable. We had a FedEx package with 8 vials in it. And they were numbered 1, 2, 3, 4, 5, 6, 7, 8. So what did we do? We were ready. We were absolutely ready. And we said, we are going to sequence the perforin gene. And wow, voila. We found that in 4 of the genomic DNAs, there were mutations affecting the perforin. Perforin gene actually has only 3 exons, so it was relatively easy to do this thing. Okay. God forbid it had 50 exons. We would have taken a month. We would have taken a year to do this. But this we did within 2 weeks. And we found in 4 DNA samples, there were either frameshift mutation or point mutations that cause premature termination and would be predicted not to form the protein. And so we sent back, we called Paris back and we said, sample number 2, 4, 6, and 8 are patient and 1, 2, 3, etc. are controls. They said, yes, absolutely correct. Okay. So then, of course, they got excited, we got excited, and they sent us I think about 8 or 10 more genomic DNA samples from patients, and every one of them had a frameshift mutation or a mutation that would be predicted to not form the protein. Okay. But well, this was genetic evidence, but we need functional evidence. We need phenotypic evidence. So what we did next was we did confocal microscopy, and these are cells from controls, and these are cells from. So when I say cells, we were working with DNA earlier. Then after we said we want the cells, fortunately, and this is where Dr. Gopinath mentioned the importance of biobanking. They had actually frozen the lymphocytes of these patients who had long since dead. Okay. And they had all of those. What a resource. So they sent us those cells and we stained them for the control, for granzyme as a marker for the granules, perforin, which is what we were looking for. And here's sample from patient number 5. Granzymes are there, perforin is very little. Patient number 21, granzyme is there, there's no perforin. Patient 25, granzymes are there, hardly any perforin. We also showed that the cytolytic ability of these cells against tumor cells was defective. So we had shown by genomic, by functional, and by phenotypic criteria that patients with FHL had defective perforin genes. So, as I said, basic science to bedside, from mice to men. Okay? Hemophagocytic syndromes are of various types. One of them is XLP. Okay. One is XLP, and another is sort of another one at that time. The only two known at that time was our work on perforin mutations and the work of Cox-Terhorst on XLP. And we quickly wrote up this paper and got published in Science. Okay? Science, because it was a completely new way of looking at hemophagocytic syndromes, okay? Which are much more common than the inherited ones or are the acquired ones. And this was, people often think that, when you publish paper in Science, it must have taken years of slogging. This took us actually only 2 months. It was just lucky. It was just lucky. We had the right hypothesis. We had the right collaborators. We collaborated. We sent us the cells. We did the experiments. And we wrote a paper in Science. Okay? And this paper. Okay, so what was the impact of discovery of perforin mutations? Well, genetic defects in perforin are responsible for 10q22 linked FHL disease. The diagnosis of FHL is based on molecular testing of perforin. This is how it is done today. Not by sequencing, but by flow. You can stain for perforin within the cells. Importantly, we predicted that other cases of FHL and other HLH syndromes are also going to be caused by molecular lesions that impair their cytolytic machinery of the lymphocytes. Because we said, we have shown the wiring, we have shown that the mutations occur somewhere along the wiring of the lymphocyte. And the hypothesis turned out to be absolutely correct. There are 5 subgroups of FHL. In 4 of them, the genetic defect is known. This was the one that we discovered. And then others discovered, a mutation in a different molecule, but which regulates cytolytic granule maturation. Another molecule controls cytolytic granule exotizosis. All these other 3, which was discovered afterwards, all result from mutations that affect the cytotoxic ability of the cells. And one of them, subset FHL1, the gene we still don't know, but we predict where it is found. It will be found to be somewhere along that particular pathway. And to our surprise and delight, of course, in 2000, every year, Journal of Immunology selects some papers from the literature, which they call pillars of immunology. And they write a commentary on this. And we were delighted when somebody called to tell us, oh, your paper has been selected as pillar of immunology. So yes, again, this is not something that we submitted to them. They didn't ask us, they didn't tell us. We found out only when it was published that this paper had been selected. This is called the Pillars article with the science reference. And then 2 experts wrote a sort of commentary on it and discussed why this should be considered a pillar of immunology. That paper has been cited more than, today I think this is over 1,300 times by others. Okay? So it clearly made an impact on the field. Okay? Not because FHL is a common disease, but because it unraveled a set of mechanisms which are important in human diseases. I think I'm going to end there. My time is almost up. I have to thank, obviously, my colleagues, in particular, Dr. Matthew, who cloned 2B4, and Beth Ann, who actually did the functional studies, and Megan, who was my MD PhD student. She's in the University of Chicago now. Susan Stepp was a PhD student who did most of the hard work. And Genevieve de Saint-Basile in Paris, who gave us the cells and the DNA, and Cox-Terhorst in Boston, who discovered XLP and gave us the reagents also to study FHL. Thank you very much.
So thank you. Thank you very much.
Sure.
Sir, thank
Sorry,
you.
sorry,
Sir,
sorry.
thank you
Go
very
ahead.
much for enlightening us regarding the molecular pathology and the pathogenesis of hemophagocytic syndrome. And there are 2 questions in the chat box, sir.
Kalyani, Dr. Raj Warrior has already started to ask a question. Can we
Yes, sir.
let him do it?
Yes, sir. And the
Yes.
same question.
I'm sorry.
Yeah, please go on, Raj Warrior, sir. Yeah.
I had 2 questions. One is, what is the role of this in PTLD, EBV-induced PTLD in patient with transplant? Role of NK cells.
Post-transplant lymphomas?
Yeah. What
Yeah,
NK?
yeah. Well, I understand your question. I think that it is likely. I think your question is very, very appropriate, because I think what Dr. Warrior is saying is this: in transplant patients who are grossly immunosuppressed, they get post-transplant lymphomas, right? The PTLD. Okay. And what is involved in that? Okay. Well, clearly, depressed T-cell immunity is involved, because these patients are very heavily immunosuppressed. Okay. But also the cytotoxicity of all cytotoxic lymphocytes is also highly suppressed. So I think it has not been formally shown, but I'd be surprised if it is not a contributing factor. I don't think it's going to be a single factor. It's going to be multiple factors. I think T-cell immunosuppression, as well as the inability of cytotoxic lymphocytes to kill transform cells, both are going to be factors. It's a good topic for somebody to study.
There is one more question in the chat box. Can this mechanism be used for selective killing of the tumor cells as therapy?
Can this mechanism be used for selective killing of tumor cells?
As therapy.
As therapy?
Yeah.
When I'm not sure I understand what the mechanism means. This mechanism means 2b4 and perforin, or the mechanism means how NK cells kill tumor cells?
The clarity of the question is not clear.
Yeah, it's unclear. The question is unclear to me. When the person who's asking the question is this mechanism, I don't know what this means, what this is referring to. If they can clarify the chat box, I'll be more than happy to try to answer.
And while we are waiting, I just want to mention what Dr. Vinay said. We use perforin now to diagnose all our patients with hemophagocytic syndrome. It's such a differential diagnosis based upon perforin. So
Can you please repeat?
I just want to mention that perforin is now used by us in clinical medicine as a diagnosis for HLH. So thank you very much for finding that out. It's a totally different.
Absolutely, absolutely. So as I said, I think, again, I want to sort of emphasize what I said in the beginning, okay? The discovery didn't start with trying to figure out the diagnosis of FHL, okay? We were doing very strict, basic science, okay? And sometimes basic science is called purposeless, okay? It looks purposeless, but many important clinical implications and discoveries result from purposeless basic science. Just like we were doing purposeless basic. We were doing this only because we were just very curious about this new cell type, and we wanted to study its function, signaling receptors, and so on and so forth, okay? And from there, when we saw the right opportunity, we saw the right setting, we rapidly moved from the bench to the bedside and, help in diagnosing a human disease. You're right. This finding is not new. This finding we published in 1999. Okay, but I wanted to share this so that younger people see how these things happen and are encouraged to do something like that.
I think there was a clarification in the chat box, Dr. Kumar.
Yes.
I think if you can read that, I think they said phagocytic property, the person meant.
So the previous question.
Previous question.
The phagocytic property can be used for I mean, is the questioner asking me the phagocytosis of the phagocytic property is of activated macrophages in this case. The macrophages are being activated by the cytokines which are being released, and they are basically phagocytosing red cells, white cells, and platelets and causing pancytopenia. So I don't know what the phagocytic property is meant here. I'm sorry, I'm not trying to avoid answering the question, but I don't understand the question.
So one more question from the audience.
You know, let me just tell the questioner. You have my email address, okay? Write to me, and maybe by some email exchange or a phone call exchange, you can explain your question better to me, and then I will be able to try to answer it to the best of my ability. And I'm not trying to avoid answering you the question, but I want to be able to understand fully what you're asking.
So one more question from the audience here.
Yes.
Can early diagnosis will help for the better recovery of the individual, and does the age factor matter?
Oh, absolutely. Early diagnosis is exceedingly important. It can actually, if you have early diagnosis, then, you know, when people thought that this was a immunoproliferative disease, you know, they want to treat with immunosuppressive drugs, they will kill the person.
Yeah,
They'll kill the person. Okay.
absolutely.
So early diagnosis is very, very important because you have to decide what to do. Okay. You have to distinguish from a lymphoproliferative disease. And this is to be treated with bone marrow transplants, not with immunosuppressive drugs. The early diagnosis is exceedingly important. And furthermore, let me put it this way. Okay. I think that if people start looking carefully at the acquired HLH, which is far more common. Okay, for example, patients with Hodgkin's disease often get HLH. Okay, you sort of have to see under those conditions what cytolytic pathway might be affected, because all HLH is cytolytic pathways. This has been proven beyond any reasonable doubt.
Dr. Vinay, I just want to add, Dr. Vinay, as a clinician, what you said is so true. If you diagnose early with a transplant, as soon as possible.
Yes.
As soon as possible to prevent complications, because otherwise they die. So we do transplant very, very quickly, very soon.
Very, very soon, yes. Yes.
Yes.
And you know, in pediatric patients now, transplants can be done. They were difficult about 10, 15 years ago. They're not easy even now. And hopefully in your institute sometime you will do it also.
I have one more question, Vinay.
Mm-hmm.
Do you call for newborn screening for this at some time in the future? For the porphyrin gene, just like you do for skin?
No. Newborn screening works only when the disease is fairly common.
Okay.
There's no point. I mean, you do newborn screening for phenylketonuria, for galactosemia, for cystic fibrosis. You know, these are diseases with frequency of 1 in 2,000, 1 in 1,800, and so on. So not in 1 in 50,000.
So one more question from the audience here.
Mm-hmm.
When shall we suspect to go ahead with HLH diagnosis?
Well, patients will usually present with pancytopenia. The bone marrow aspirate will show hemophagocytosis. Okay? And if you have a combination of those two, you know, pancytopenia has 50 different causes, okay, as Dr. Warrior will tell you. Okay? Hemophagocytosis is one of the causes. It's probably not even the most common cause. Okay? But if you suspect HLH, then a patient who has pancytopenia, you do the bone marrow, and I showed you the picture. It's very classical. Once you do the bone marrow, it's very easy to see. You need no fancy test.
And one of the clues, ferritin, very high ferritin. So
yes, right. Because the triglycerides are also very high.
Yes, very.
In the past, people used to use ferritin and triglycerides as markers.
Yes.
Okay, and that's all because of liver damage. Because if you look at the livers and spleen of this patient, there's hemophagocytosis going on there. And there's such severe inflammation going on in the body. Ferritin is going to go to the sky.
I think there are no more questions in the chat box. So
Okay.
with this, I immensely thank you, sir, for enlightening us and giving a very elaborate talk regarding the molecular pathogenesis of the hemophagocytic syndrome and its application for the patient care. Thank you very much, sir.
Thank you very
Very
much.
good night.
Thank
I
you.
think I hope Dr. Kumar and Rajwari will have a small nap and catch us early in the morning.
No, I listen to you guys and learn. Thanks, man. I learned a lot. Thank you very much.
Yeah.
Thank you. Thank you. very much.
Rajwari, don't forget to get up in the morning.
No, I won't. I won't. Okay. I'm going to start up
Okay.
with my old friends.
Yeah.
Okay, stop sharing the screen. Okay, I'm done.
Night, Vinay.
And I'm
Shashi, are you in India or Australia, Shashi? You are muted. Can you unmute Shashi?
Post, can you unmute Shashi?
Can I request the host to unmute Dr. Shashidhar? I think Swaroop, can we unmute Shashidhar?
Yeah, I got it now.
Yeah, yeah. Are
Yes.
you in India or Australia, Shashi?
No, I'm in India now.
Okay, fine. Then
Yeah,
no issues
just
of
last
sleeping
week.
now. Yeah. All right. Yeah. Thank you.
Thank you.
So thank you, Dr. Kumar. And Rajwari sir, you want to have a small nap? I leave it to you.
No, I like Apache. I'm his old friend. I listen to him.
Okay, fine. Go ahead then.
Okay.
Please go ahead, team pathology Kolar.
Our next distinguished speaker is Dr. L. Appaji, Professor of Pediatric Oncology, Kidwai Memorial Institute of Oncology, Bangalore, Karnataka, to speak on burden of pediatric cancers. It is a privilege, sir, to have you with us. And for chairing this session, I invite Dr. Bhire Gowda, sir, Professor of Department of Pediatrics, and Dr. Ashwatappa, Associate Professor, Department of Surgical Oncology.
Good morning to everybody. Thank you very much for inviting. So I had an impact. I'm very grateful to introduce Professor L. Appaji. He is a professor of pediatric oncology, Kidwai Memorial Institute of Oncology. He is actually a guru for me. From him, I learned real oncology, what I am today. So he has got 118 publications reputed in journal. He is a life member of Indian Academy of Pediatrics and Bangalore Pediatric Society, and received many awards, including PC Roy Award, Rajyotsava Award, and many more. So he is going to speak on the burden of pediatric cancers. So welcome.
I thank the Department of Pathology for giving me a chance to speak on my legend, Dr. Appaji sir. I think even I was also a student with him. I was posted in Kidwai Institute for a month. I learned a lot from him. Later, I think I'm following a lot of things, whatever I learned from him. Thank you, Appaji sir. I kindly take over the things.
Sir, you can share screen, sir. Appaji, sir. Slideshow, sir.
Sir, Appaji sir, can you share your screen, sir? Sir, are you online? We don't know whether he's online. Sir, I have to share.
Thank you.
Good morning.
Yeah, good morning, sir. I think you can take on, sir.
I thank Vice Chancellor, Professor Kalyani, Professor Gopinath, and Dr. Sulapa, Professor Biragoda, and Dr. Sila, and other members of committee for giving me the opportunity to share my experience on burden of pediatric cancers. Globally, we see more than 3 lakh children diagnosed cancers. In US, about 10,500 children diagnosed annually. However, in India, we see more than 50,000 diagnosed. That Gopinath told, almost 1/4, 1/5 of the world cancer from India. At our institute, we see more than 650 new cases registered annually, and under 15 years of age, 1.6 to 4.8% of all cancer seen in children. Globally, 44% of children's cancer will die before the diagnosis. In high-income countries, more than 80% children with cancer is cured. However, in low-income countries and middle-income countries, estimated survival about 15 to 40%. So the reason for that is a death in low middle-income countries are due to lack of diagnosis, misdiagnosis, delayed diagnosis, obstacles to access for the treatment, and also treatment abandonment and death from toxicities and air losses are the important cause for death in pediatric cancers. The only about 5-10% children will have genetic factors, like example, retinoblastoma, hereditary type of retinoblastoma will have 13 deletion, and certain infections like HIV, EBV, malaria, as well as primary immune disorders due to the cause for the genetic factors. The WHO in 2019 launched global initiative for childhood cancer to provide technical assistance to government to support them in building high quality of childhood cancer program. The goal is to achieve at least 60% survival by year 2030. The WHO and IRC in collaboration with the International Atomic Energy Agency and the UN organization to increase political commitment for childhood cancer diagnosis and treatment, because majority of pediatric cancers are curable. Support government to develop high quality cancer centers and also develop tools for early diagnosis, treatment, and palliative and supportive care. Improve access to affordable essential medicines and technologies. And now WHO listed 36 essential medicines, out of the 26 are chemo, 5 are targeted drugs, and 4 are hormones. If we take about India, that is, it is the 2020 data, that is the both sexes, there are 30,444 registered. Out of that, there is the boys were 18,415 and girls were 12,029. Out of that, if you look at this one, the age adjusted age per million, 86 in both sexes, boys about 99 and girls are 71. If you take about, there is a age adjusted rate, incident rate per million, 14 in boys 114.2, whereas girl 82.7. The child cancer, in India, there are 36 population-based cancer registries and 236 hospital cancer registries are functioning. And if you take age adjusted incidence per million, that is ARPM, shows wide variation. The Delhi is having, that is for all types of cancer in both boys and girls, 235.3 and 152.3 respectively, whereas in Chennai having 156.7 and 85.6 boys and girls respectively, because the There is capacity, there are more centers, there are more people, patients will refer to child. If you take from the 7 registries in India, there is ARP, it is 96.9, which is lower than US, it has got 166.9, Canada 164.9, UK 1.5, Australia 154.9. As per the population-based registry, the leukemia are the commonest, followed by brain tumor, lymphoma, neuroblastoma, lymphoma. Other pediatric cancers are soft tissue sarcoma, like we have epidermal sarcoma, cellular sarcoma, fibrosarcoma. These are all tumors. Bone tumors like we osteosarcoma, Ewing sarcoma, retinoblastoma, germ cell tumor occur both gonad section side, hepatoblastoma, tissue disorders as well as carcinoma. We take about under 15 years, the pattern, the leukemia constitute commonest, or again leukemia, acute leukemia constitute 20%, followed by 20.8%, that is CNS tumor, followed by neuroblastoma 6.8%, and Wills tumor 5.3%, and remaining other constitute. If we take childhood cancer by side at our institute, the 18 and 19, the again leukemia constitute commonest, around 50%, followed by CNS business endocrine tumor 13%, because along CNS tumor, the neuroblastoma also included. There are no warning signals for pediatric cancers, compared to adult, but there are certain warning one can suspect pediatric cancer. One is any aneurysm, example, child has got neck swelling. That is any lymph node which persists 3 to 4 weeks, not responding to any antibiotic, suspect possibility of lymphoma or tuberculosis. The child will have sudden pallor. Again, one of the probably features of warning signal, unexplained fever, and any bleeding, the skin bleed or GA bleed, or suspect possibility of the pediatric cancer. Limping, especially children below 2 years. Acute leukemia can present like limping. The mistake for the fracture, we call it as pseudoparalysis. The child with a frequent headache, often with vomiting, especially early morning, may suggest that is brain tumor, because brain tumor constitutes second commonest cancer next leukemia as per the PBCR. Sudden high vision changes or white triplets, suspect need to evaluate by ophthalmologist. Again, any acquired squint should be ruled out, possibility of retinoblastoma, sudden unexplained loss. These are the few warning signals one can suspect when compared to adults. So management of pediatric cancers is a team approach. That is a pediatric medical oncologist, pediatric surgeon, pediatric radiotherapist. Without pathologists, we cannot treat any cancers. The pathologist plays a very important role in the diagnosis of the pediatric, any cancers in general. Onco nursing, because special nursing is required because IV access is very important. The most drugs are vesicant. Unless you give proper way in intravenously, may result in, that is, the extravasation is causing problem to child. Social workers and psychologists play important, especially adolescent children require psychological support and palliative care, and supportive care in terms of antibiotic, blood component play a very important role in the management of especially hematological malignancies. The management consists of surgery. Surgery is there from the time of this time. The chemotherapy from the last 60 years, radiotherapy under 20 years, and immunotherapy from the last 30 years, and we have targeted therapy that is from the last 20 years. We have the two important types of therapy which are more effective in pediatric cancer. One is tyrosine inhibitor in the treatment of the chronic leukemia. The rituximab, that is those lymphoma CD20 positive, that is the prognosis is better when you treat with chemotherapy. There are certain barriers in childhood cancers. One is late presentations and delay or misdiagnosis, treatment denial, abandonment, and treatment toxicities. Especially children with undernourished children, they are more prone to develop toxicities caused by chemotherapy drugs. Increased of loss, severe care are the few important barriers in childhood cancers. There is a progress in pediatric oncology from the last 3 to 4 decades. One is molecular characterization. Say when we joined the institute as an oncologist before 90, used to diagnose cancer by morphology. Example, acute leukemia or acute leukemia used to diagnose by morphology, then cytochemistry, later karyotype. Now we have all patients of cancer, we do molecular characterization, like example in case of leukemia, we do immunophenotyping, in case of immunochemistry. Other than this molecular, we also go to the molecular test example. In case of chronic leukemia, we look at the B cerebral. In case of AML-M3, look for P. malaria. In case of neuroblastoma, we see NB composition for risk stratification. And again, risk therapy. So now, as per the clinical, as biological factor to take into consideration, need for risk therapy. Those with low risk, current risk, we can treat with less intensive. Those with high risk factor may require aggressive therapy, because low risk patients, because chemotherapy can have certain long-term problems. We have to prevent, especially those with low risk current risk patients, treat with minimal chemotherapy compared to high risk patients. The third important, enroll the patient to protocol-based therapy is very important because to have a success in oncology. And establish a collaborative group contains program. Now we have INPA, Indian Pediatric Oncology Group. Almost we have there is a 21 subcommittee of the formed under the PHU chapter and treating as per the INPA the criteria. And we have national training program for the pediatrician and young oncologist under pediatric hemato-oncology chapter. Adoption of uniform treatment protocol suitable countries is very important. We cannot copy what is there in other countries. What is suitable of our country should be adopted. And again, all trained personnel is very important to have the improve the progress in pediatric oncology. See, there are differences in adult versus pediatric cancers. The 2/3 of pediatric cancers are leukemia, brain tumor, lymphomas. The carcinomas uncommon in pediatric because carcinomas are major bulk in adult. Rarely we see desmoid carcinoma, germ cell tumor. Rarely we see thyroid carcinoma in pediatric colon cancer. Pediatric cancers are biologically aggressive. They will have high growth fraction, start developing, and they are most of pediatric cancer. They are disseminated at diagnosis. They are more chemosensitive, and they are compared to adult cancer. Outcome is better. Causation of the pediatric cancer is not related to lifestyle, or in fact, example, we have physical agent, chemical agent, biological agent may not play important role when compared to adult cancer. And in pediatric, because the child is going therapy-related sequelae is more, hence not only we are treating the patient with a chemotherapy surgery, need to follow them the longer time, look for any sequelae-related therapy, need for timely intervention. The screening is not feasible in pediatric cancer. However, in adult, like example, breast carcinoma, cervical carcinoma, oral cancer, one can pick them under screening to pick up the early disease, early treatment. If you take the presentation and survival in high-income countries versus India, example, acute leukemia, they present later compared to high-income countries, 6 to 10 years. They have more T-cell disease, Say example, Western height will be about 20%, we are a little more than 20%. The more iris genetics as well as mark features. Example, we have more of Ph positive ALL, and those T4 level classifications are more common in India compared to other countries. If you look at the 5 survival, about we have 45 to 80% compared to 90% in high-income countries. Acute myeloid leukemia, more external presentation, like they will have chloroma presentations, and look at the survival around 30-40% in India when compared to 68% high-income countries. Heart disease when compared to high-income countries, the younger age presentation, and again more mixture type compared to what's in high-income countries, not services, and 2/3 present with advanced stage of abnormal, 2/3 will have these symptoms, and survival almost equal to high-income countries. NHL present advanced stage, again will have B symptoms. Survival 61% in India compared to 80% in high-income countries. The serious tumor still lacking diagnosis. Only the compared to high-income countries, we have only 50% incidence, and in India, only 56% received complete treatment. Retinoblastoma, even though 98% occur below 3 years, but here later presentation 29 to 34 months, more extra disease, almost 40% when compared to high-income countries, and we have survival 46% compared to 80%. Neuroblastoma again, above 1 year, majority of blood disease, cerebral, above 1 year, advanced stage, only about 1/3 survive. Brain tumor, plus an advanced stage, still results are good because we treat the stage as well as therapy. Almost results are equal to high income countries. Rhabdomyosarcoma plus advanced stage, stage 4, cerebral about 43 to 57 compared to 20%. Even sarcoma, again the advanced disease, we have 50% survival compared to 16 to 76% high income countries. The progress in last 4 decades in the pediatric oncology in India, one is establish a training program for pediatricians through national training program in practical pediatric oncology under IAP for early diagnosis, referral, shared care. Again, a very important shared care in the pediatric oncology. The peripheral pediatrician bridge between the institute as well as the patients. Because they will ask to be on maintenance therapy or some of chemotherapy, there is a certain problem should be tackled by the peripheral pediatrician before they can refer to oncologist centers. The standardization of treatment protocol, the multi-center collaboration, we have started MCN protocol in 1983. It was first started at the Madras, the Chennai Adyar, later 86, the TMS Mumbai, and 87, we of our institute started the 8th protocol. ICL protocol now is following in most of the centers in India. It started from 2014. In 1987, establishment of pediatric hematology chapter and IAP, and 2018, we are in fact developed roadmap for conducting prospective multi-center clinical trial. It has resulted in the data patients data collection and informed treatment and improved survival. The final support and holistic care also very important, and philanthropy support for nutrition, blood component. The NGOs will play important role in the providing blood component as well as nutrition. National Production Scheme under Ayushman Bharat program, that is by Government India, the launch that now almost 5 lakhs rupees will be given to eligible patients under free of cost treatment. The promotion of health insurance again from the that is insurance companies play important role and help to improve the survival of pediatric cancer, and improving data collection through the population history as well as hospital history. They play very important know the incidence, prevalence, and survival of the patients. The training for pediatric oncology nursing and as well as paramedical discipline like because chemotherapy again pharmacists to be trained for the proper mixing, proper administration of chemo drugs. Palliative care being initiated at the time of diagnosis. Now coming to a few important tumors, leukemia, which is constitute 30% of cell cancer. Among leukemia, acute leukemia constitute 70%. Almost 1/4 of all pediatric cancers constitute ALL, acute constitute 20%, CML constitute 5%. The child with ALL present with fever, pallor, bleeding, adenopathy, hepatomegaly, joint pain, and bony pain. Almost the joint pain, bony pain, mimic like pediatric rheumatic presentations. The child with acute present with fever, pallor, bleeding, proptosis, secondary to chloroma, we call it as myeloblastoma, organosarcoma. Gingival hypertrophy is more common in M5 subtype AML, and DAC is a more common in M3 AML, especially hypergranular variants of AML M3. The child with CML, very rare pediatric, only 5% present with masculine. The child with acute leukemia present with proptosis secondary to myeloblastoma. Evaluation of leukemia, hemogram, complete hemogram, HPTCD plated, periplastmia, look for the blast. Biochemistry slide, LFT, RFT, uric LDH. Here you have to do the LDH uric acid to the suspect to avoid the tumor syndrome, treat in the right time, support care for the tumor syndrome. Serology, bone biopsy, morphology, cytochemistry, karyotype, phenotype, and genotype, chest X-ray, especially TALL media cinemas, ultrasound, look for rhenomagnetic case viral, CS pathology, because we are look for whether at diagnosis CS is positive, negative, because once CS positive is straight away, that is CNS3, ECG cardiology. In ALL, the morphology is very important. Even though FOG started 1972, still there is a, because before 90, we used to diagnose and treat the morphology only. L1, L2, L3, 80% L1, 45 L2, only 1% L3. L3 is called Burkitt leukemia. Then followed by cytochemistry, lymphoblasts are fast positive because of presence of cytoglycogen, and acid phosphatase in case of TLL and L3LL, they are positive for aldehyde. Karyotype, we have chromosome aberration like numerical translation. Numerical like we have diploid, hyperdiploid. Those with hyperdiploid ALL prognosis is good compared to hyperdiploid. Translocation we have T4 level. We see in case of infantile ALL carries poor prognosis. They will have the MLL gene alteration will be there. There was T119 3VLL and T1221 is one subset of ALL will have good prognosis. T814, 822, 58 such L3LL, and we have T1779, 1070, 1019, 1041, 47 TLL. 2 to 5% of pediatric ALL will have PH chromosome. Presence of PH chromosome carries poor prognosis in spite of adding the TCAD, and we have deletion. The immunofetum, we have precursor BLL, pure TLL, and BLL, 80% of BLL, 20% are precursor BLL, only 1% BLL. So when compared to iron countries, we have more incidence of precursor TLL for the monoclonal use for BL, CD19, 20, 21, CD10, including HLDR, CD34 for T cell, CD5, CD7, CD3, CD5, including HLDR as well as the CD34. Genotype, that is the ETV 6 is a subset, good prognosis, that is, they will have 12 allocation, immunoglobulin IgH, mixed suggestion of L3LL, BCR able, that is pH positive ALL. We have to differentiate the de novo pH positive ALL from the CML blast cases, because here we have to the BCR able protein. In case of ALL, it is about 100 kilodaltons. In a case CML, 210 kilodaltons. IMP 121, again, is one of the iris heterogeneous features, TCF PBX1, the pH like ALL. Now, WHO included recently pH like ALL, poor prognosis, they will have they will have the IKZF alteration without BCR able protein, prognosis poor. We have 11 to 21 in case in ALL and came to 28 alteration. In acute myeloid leukemia, morphology we have M1 to M7. M7 is called acute myeloid leukemia, which is more often seen Down syndrome. And cytochemistry we do MPO, sodium block. In case of M4, M5, we do non-specific esterase. Karyotype and immunophenotyping use CD13, 33, 34 into MPO. In case M6, along with the 1333 MPO, we do glycorin. In case of M7AML, along with 13, 30, 34, we also do CD41, CD61. Then we do the further risk stratification genotype, that is, those with FL3 ID mutation carries poor prognosis, those with NPM superpower, good prognosis. In case of M3ML, we look for PML RER transcript. The management of ALL, supportive care. Without supportive care, it's difficult to treat any acute leukemias. The blood component like packed RBCs and platelets. Anti-infective, we have prophylactic, empirical, definitely. Because these children, more prone to allow pneumococci, will put them on cotramazole. Almost we continue throughout the treatment period, cotramazole. Whenever the febrile neutropenia, fever neutropenia, we start empirical antibiotic to take care of gram-negative organism. If the child has got their central line, we also add gram-positive coverage. Whenever the culture is positive, we go for definite antibiotic. That is, anti-infective consists of antibiotic, antifungal, antiviral, antiparasitic, antiprotozoal. So nutrition is very important. The good nourished children tolerate chemotherapy better compared to those with and children. We have the nutritionist to support the nutrition support for the children and improve the nutrition, minimize the toxicity. And we have a psychological department of psychology to give the support for the psychological support to children, pain management. When we take the speech therapy in ALL, as per risk stratification, we follow ICL protocol for the last 3 years, and we have standard risk in high risk. standard is treated with a less intensive compared to high-risk patient. We have 5 phases of therapy: induction, remission, consolidation, intermediate therapy, delayed intervention, maintenance. However, across the world, many protocols, we have BFM protocol, MCF protocol, ICL, POG, many protocols. Our treatment of the pediatric cancer, not only leukemia, is the same. We use about 8 drugs in the treatment of ALL, vincristine, donomycin, elastase, prednisolone, cyclophosphamide, iodose methotrexate, cytomycin, and 6-mercaptan is the drug commonly used. The total duration of therapy as per ICL protocol is at 2.5 years, and 5 years survival in India we expect 45% compared to 90% in 90 countries. The management of AML, except M3AML, we support care like antibiotic, blood component, psych support. The special therapy consists for AML. Non-M3, we have induction, we use 2-drug combination, cytisidermoside, donomycin. Once after the induction, we do the marrow for morphological remission and we do MRD, and carotid remission if there is any abnormality. Once remission, we give option for transplant, feasibility transplant. Not possible, we are going to do one more induction with a 3 donomycin, then followed by iodose consulted with iodose once in 4 weeks for 3 cycles. And total therapy is 66 months. 5 years survival, 40% in India compared to 68% high-income countries. The management of M3AML, acute chronic leukemia, is differ. Here, supportive care very important, especially you do the patient first 1 or 2 weeks of therapy, unless you have appropriate supportive care, which include prevention of DAC. They can present with hypergranular, can present DAC, need for appropriate supportive care, not includes fresh plasma, cryoprecipitate, platelets, packets, etc. The special therapy is risk-directed. We have again the standard risk, high risk. We take consideration of total count less than 10,000. Standard risk more than 10,000 high risk. Required induction phase consists of donomycin, and we have all tranexamic acid. So once you achieve remission, we go for consolidation with a cytomycin, all tranexamic acid along with anthracycline, then put them on maintenance therapy for a period of 2 years, 6-mercaptan and methotrexate tablet once in 3 months, 2 weeks of ATRA. Now we have one more option for the treatment M3. Arsenic trioxide is FDA approved for the treatment, and total risk therapy is 2.5 years. In CML, in a chronic phase, better to go for that is transplant, bone marrow transplantation, because once you start target therapy like TK, transplant not possible. Now best option is the immunotherapy, because here you have to do lifelong. Where a transplant, once you do it, there is no further therapy required unless recurrence is there. However, if you start TK, you have to do lifelong. However, it is one drug, it is a wonder drug, according to me, change the natural history of that is chronic leukemia. We are immunomucilate. The patient develop resistant. We have 2nd, 3rd generation, the TK available. Non-Hodgkin lymphoma, that is the present with peripheral adenopathy, mediastinal adenopathy, abdominal mass, external involvement. The duration of symptoms in non-Hodgkin lymphoma is very short compared to Hodgkin disease, varies from few days to few weeks. In NHL, external presentations are more common, like the bone involvement, the GI tract involvement, spinal cord involvement, thyroid, breast hole involvement, more common and present with tumoralized, because biological very aggressive patient can tumoralized syndrome, mediastinal NHL present with Sjogren's syndrome, or cord compression they can present with the spinal cord NHL, and acute abdomen because of the ileocecal mass, because Burkitt's is more common, are affecting the ileocecum, or they can present with obstetriopathy. Evaluation, that is hemogram, complete hemogram, because it is required. Sometimes NHL can involve the marrow, can present with leukemia. We have the complete hemogram. Biochemistry include liver function, renal function, uric acid, as well as LDH. Serology, chest X-ray like ultrasound, abdomen, CT scan or PET scan, and biopsy for the morphology. Pediatric is aggressive. We see high grade, sometimes intermediate grade. We don't see low grade lymphoma pediatric. The histologically we have common 4 types: we have lymphoblastic NHL, Burkitt type, diffuse large B-cell lymphoma, and anaplastic lymphoma. The lymphoblastic constitute around 30%, Burkitt constitute around 50%, and DLBCL, ALCL constitute 10% respectively. So look at the immunohistochemistry. The 60% are BNHL, 40% TNHL, whereas in adult, 90% of BNHL, only 10% are TNHL. We do karyotype, genotype, and bone marrow aspiration, CSF, ECF. The treatment of NHL, because high grade need for supportive care in terms to prevent hemolysis or treat hemolysis, hydration, allopurinol. In establish the TLS, we go for raspbericase. Okay, that is uric oxidase, convert uric acid to water soluble time, and management of emerge like that superior syndrome, card compression, and acute autonomy. Lymphoblastic NHL treat like AL. Non-blast like Burkitt lymphoma, DLBCL, anaplastic lymphoma, also called Kiva lymphoma, required short intensive course of chemotherapy, which consists of, again, that is the vincristine, anthracycline, cyclophosphamide, hyposamide, etoposide, high-dose methotrexate, and intrathecal methotrexate are given over a period of 4 to 6 months. Whereas ALL, lymphoblastic, we give 2 years. Here, the 4 to 6 month treatment is enough. Along with target therapy, those NHL who are CD20 positive, we include rituximab along with the standard chemotherapy. With this overall survival, 61% in India compared to 80% high income countries. Heart disease, that is present mainly with cervical cardiomyopathy. Almost 80% of the children present with supracardiomyopathy, and they can present with B symptom like, that is fever, loss of weight, night sweating. The pallor, any child with heart disease pallor, we suspect first possibility autoimmunodecanemia. The jaundice can occur because of the immunodecanemia or due to obstructive jaundice or due to liver involvement. And here, the duration symptoms heart disease longer, few months to few years. We have seen 2 years, 3 years. The vaccine waning is known case of heart disease. They don't present because more than 97% of clinical disease is reactive in heart disease. Only less than 3% neoplasm. That's why they can present later, long period. And this heart disease sometimes diagnosed as tuberculosis, and they put them on ATT without any histology and present the advanced stage. And that's why any lymph node mass post 3 to 4 weeks need to do at least FNAC. Not possible, do the biopsy, confirm, exclude the possibility of lymphoma or tuberculosis. When compared to NHL, external involvement is less common in heart disease. Any external involvement like lung, liver, brain, bone involvement carries poor prognosis. Bone marrow involvement rare in heart disease when compared to in non-Hodgkin lymphoma. How to approach? We do the hemogram, biochemistry, serology, chest ultrasound, CT scan or PET scan, biopsy for morphology. There are two classical types. We have nodular lymphoproliferative disease. Under classical, we have lymphocyte predominance, depletion type, mixillarity, not so same. We have India more of mixillarity compared to nodular type of Hodgkin disease, not type of Hodgkin disease. And we have the further confirmed by doing the immunohistochemistry, classical type, that is CD15, CD30 positive, nodular lymphoproliferative disease, CD20, CD45. It is one subtype of non-Hodgkin lymphoma where stage 1 disease, few lymph node, one surgery is alone enough, no need to give any adjuvant chemotherapy in case of early stage, resectable, nodular lymphocytic Hodgkin disease. The bone marrow biopsy, aspiration, and in child who present with anemia jaundice, we do the Coombs test, ECF. The treatment of Hodgkin disease lymphoma, surgery only for the diagnostic biopsy. Before 90, they should do laparotomy. Now we don't, that is say, adopt any laparotomy. That is only biopsy for the diagnosis, radiotherapy, involved radiotherapy for residual neck lymph node. After completion of chemotherapy, we do the residual disease confirmed by PET scan or biopsy. If the result is there, we go for radiotherapy. The dose is very small, 2,000 vaccines around. Chemotherapy in heart disease is a risk directed. We have favorable, intermediate, advanced. What is favorable? Stage 1, stage 2, without B symptom, without bulky disease, we have to do 4-cycle therapy. There we are going to go 2-cycle chemotherapy. We do the PET scan, PET is negative, we do 2 more cycles. The intermediate risk, those with stage 1, stage 2 disease with a bulky disease, presence of B symptoms, we go for 6-cycle chemotherapy followed by infertility for residual lymph node. Advanced risk required 68 cycles without no infertility radiotherapy. Coming to brain tumor, they are as per the population data, it's the second commonest, but if you take hospital-registered data, it comes to fourth or fifth commonest because it's still undiagnosed. The 66% of the tumors in pediatric infantile, whereas adult law more of super tumors, incidence 24 as per the PBCR, 12% for HBCR data. Osteocytoma, brain stem glioma, medulloblastoma constitute 2/3 of brain tumor. Remember, there are certain causations of pediatric cancer, brain tumor. One is radiation, other certain genetic syndrome like NF1, NF2, ATAX, and it can occur as a part of Lehman syndrome. The large proportion of brain tumors are misdiagnosed, hence it is the fourth or fifth commonest pediatric cancer as per the HPCR data. The treatment of brain tumor, surgery. Surgery, a lot of progress taken place in neurosurgery also, and again, next followed by radiotherapy. Again, there is a lot of progress taken in radiotherapy. We have IMRT, IGRT, stereotactic radiation, chemotherapy depends on grade as well as histopathology. In India, about 56% of the patients with brain tumor receive complete treatment as per the protocol. Retinoblastoma, it constitutes 3% of pediatric cancers, 98% occur within 3 years. We have hereditary sporadic, that is, the 60% are sporadic, 40% hereditary, and 70% unilateral, and 30% are bilateral. In case of retinoblastoma, the RB gene is mutated, 13 deletion mutated. These 13 RB genes can transmit it from the parent child acquired as new mutation. Parents with patient present with in India, more advanced stage, and extra disease more common. In South India, reported 9%, whereas North India, 27 to 40% of the children present with extraocular disease. Here, the most important when compared to West, the early diagnosis, they say 90%, 90%, 5 years survival, 10 years survival. Here, we are still, results are not very promising because of the delayed diagnosis. Hence, the need for incorporation of red reflex testing during routine visit for the pediatrician during vaccination or even ANM through the we have RBSK through which one can able to pick up early retinoblastoma, intervene early and improve the prognosis. The treatment of retinoblastoma consists of surgery in the form of enucleation, advanced required exenteration. Radiotherapy we have extra beam radiotherapy in case of bilateral, don't enucleate, that is probably can adopt visibility of brachytherapy. Chemotherapy of neoadjuvant chemotherapy, which consists of carboplatinum in site, being 3 cycles, then local therapy like surgery or focal radiation, focal chemotherapy like cryotherapy for coagulation, then go for adjuvant chemotherapy, 3 more cycles. The advanced we have grouping system, group ABCD. The growth is group E may or D may require intrathecal chemotherapy through melphalan or topotecan to the ophthalmic artery. There is a practice about sub-chemotherapy like carboplatinum, topotecan. So focal like we have cryotherapy for coagulation. In case of bilateral blastoma, early disease, vision is present, we don't enucleate. It is one of the tumor. There is a role of organ preservation. In a pediatric, there are few cancers need for organ preservation. We are early retinoblastoma, we don't enucleate. The bilateral Wilms tumor, feasible for nephron splenectomy. The osteosarcoma, early disease, we don't do the amputation, and epidoblastoma are the few conditions one can go organ preservation. The retinoblastoma also is one of the organ preservation. Rehabilitation is very important. Your patient underwent enucleation may require prosthesis. Prosthesis, there is artificial this genetic counseling. In case of adenoblastoma, there is a need for genetic counseling to prevent the birth of the child, need for antenatal the diagnosis, look for any certain mutilation. Neuroblastoma is the second most common solid tumor. The next two, the brain tumor, the neuroblastoma constitute second common tumors. Arise from the adrenal medulla or stemmal ganglia is constitute 4.2 to 8.3% of cervical cancer. The 2/3 present with advanced stage of, that is, international listing system, and known for spontaneous regression, especially children below 1 year, above 1 year, majority of advanced disease. There are few cancers known for regress spontaneously. We have other than neuroblastoma, we have retinoblastoma, medulloblastoma, epidoblastoma, leukemia in case of the Mongol. And it is one of the elegant small tumor.
Sir, time is up, sir. International speakers are waiting.
And any complication of the case of advanced stage and poor prognosis. Workout, blood counts, biochemistry, including LDH, 13, serology, chest X-ray, CT scan, PET scan, imaging scan, morphology biopsy, immunohistochemistry include synaptophytes, chromogranin, bone marrow, urinary catechomens, any complication in case of look for risk stratification. The treatment of the surgery, chemotherapy, radiotherapy, target therapy in case of advanced neuroblastoma, and treatment decision depends upon risk stratification, 3 years, overall survival 47%, and EFS is 36%. Bill's tumor, the second common tumor, arithmetic and 80% below 5 years, unilateral 90%, bilateral 10%, plus abdominal mass, hematuria, abdominal mass, hypertension, 15% plasmatic disease. Workup, blood counts, biochemistry, serology. They include chest X-ray, ultrasound, CT scan, paraffin, and diagnose morphology including immunohistochemistry and karyotype, echocardiogram. Treatment of Bill's tumor, surgery, radical nephrectomy. In a bilateral, we go for nephrectomy, chemotherapy versus followed by adjuvant chemotherapy, radiotherapy. All depends upon histopathology and their stage. Survival equal about 70-85% 5 survival. Epidoblastoma, 1% period cancer, are 6 months to 36 months common age, abdominal mass, abdominal distension. Seroprotein is a marker for diagnosis, response assessment, and 50% for advanced disease. The workup, blood counts, biochemistry, including all protein, and radiology, like chest X-ray, ultrasound, CT scan, biomorphology, immunohistochemistry, and echocardiogram. The treatment, the CT scan, a very important role in the staging of the epidoblastoma. We go pre-testing system on the CT scan and plan chemotherapy, then surgery. And standard risk patients require 4 cycles of cisplatin followed by 2 cycles adjuvant therapy. High risk patients 7 cycles of cisplatin alternating carfamycin followed by 3 cycles of chemotherapy. Germ cell tumor 3% period cancer, occurs gonad cell site, secrete output beta CG. They will have definite pathogenesis spread and cisplatin change the outcome. And here in pediatric, it is more common like the yolk sac tumor, carcinoma. We don't have seminoma in pediatric. Our seminoma counterpart occurs in Galvia, dyseminoma. Workup, blood counts, biochemistry, tumor markers, serology, chest X-ray ultrasound, CT scan of the thorax, and MRI brain required in case of intracranial tumor, biopsy, morphology, biopsy for morphology, immunohistochemistry, CSF is required in case of intracranial tumor, echocardiogram. And treatment, surgery in case of testicular, go for immunochemotherapy, ovaries, or debulking in case of extranodal. Chemotherapy as per risk stratification, 3 to 4 cycles of PB or 4 to 6 carboplatin based surgery, radiotherapy indicated intracranial germ cell tumor. Rhabdomyosarcoma is a common sarcoma, 40% in areas, present mass lesion in the pain, rare in lung, brain, bone, and known to be associated with leaf and syndrome massacre, female syndrome. The workup, blood count, biochemistry, serology, chest X-ray, ultrasound, CT scan, MRI in case of primary RMS, biopsy morphology, embryon, we are morphologically embryon like a subset of embryon, patriod, spindle cell, anaplastic variant, allular, pleomorphic. Immunohistochemistry, we have myelin, desmin, actin. A karyotype include embryonal loss of LNP in allular law T213, T113, and FOXO gene present in the chromosome 13. CS examination case of RMS, bone marrow, chest. The treatment of RMS, surgery extremities, RMS, genitourinary, chemotherapy as per the stratification, the VAC chemotherapy, we are going to do increased cycle for 27 to 34 months and radiotherapy required for the local control. Osteosarcoma is a primary common tumors. Arithmetic long bone is the second common tumor, and is one of the malignant tumor with the present last diet. 80% of advanced disease as a metastasis diagnosis. Next. Workup, blood counts, biochemistry, serology, X-ray of the abdominal side, and CT scan thorax, biopsy morphology, bone scan, PET scan. The treatment of sarcoma, limb-bearing or ablative chemotherapy include neoadjuvant chemotherapy, which consists of cisplatin, adriamycin, ifosfamide for adjuvant therapy. And here, the most important include neoadjuvant histological risk, very important to plan adjuvant chemotherapy. Ewing sarcoma is second common tumors, or if you have long bone, it is one of the round cell tumor. Note factors in Ewing sarcoma, 20% for metastasis, and both chemo as well as tumor when compared to sarcoma. Workup, blood count, biochemistry, serology, X-ray local body bilateral, CT scan thorax, biopsy morphology history, karyotype, look for 11 location, along with molecular EWS gene present the chromosome 22, bone scan, PET scan, bone marrow. Treatment, chemotherapy, neoadjuvant, followed by local therapy in form of surgery or RT, adjuvant therapy. The drugs are used in doxorubicin, cyclophosphamide, etoposide. To summarize my talk, annually more than 3 lakh children are diagnosed with cancer in the world, whereas India more than 50,000. The average age of child with cancer is 6 years. The most common cancer in pediatric leukemia. The treatment of pediatric cancer is a team approach. Enroll the patient to protocol-based therapy is very important. Adoption of uniform treatment protocol through the country is very, very essential. And this play an important role in knowing the incidence, prevalence of the disease as well as the tumor that is survival. And in high-income countries, more than 90% children can cure, whereas lower middle income estimated 15 to 5%. However, for the last 4 decades, survival will need for long-term follow-up in the pediatric oncology. Thank you very much.
This is Dr. Vore. Can I make a small comment if you don't mind?
Yes, sir. Yes, sir.
I just want to mention Dr. Appaji should be congratulated because he's probably the most important pediatric hematologist state. He has done tremendous work for the last so many years. I'm so glad you called him because I've known him for 40 years. He's remarkably, done tremendous work. So everybody should congratulate him for his lecture and also what his talks. It's a remarkable job for whole of Mysore state, Karnataka state. Thank you. Sorry about that.
Thank you, sir. Thank you.
Thank you, sir. It was a very nice talk and wonderful. There is one question for you, sir, from Raj. Could you comment
one request? Request the host to please can I have a small? I'm Dr. Pradeep. Request the host not to have more than one instrument functioning in the hall, which is causing echo. Thank you.
Hello.
Please repeat the question now.
Yes, sir. I think
in person. Dr. Appaji, again, I said you've done a great job. I just want to ask you, you mentioned about the molecular markers. How is it available in all the hospitals, only in your hospital?
Yes, sir. Available, sir. Available, sir. Available.
Available, I say, okay. All over, everywhere.
Available.
Okay, good. Great. Excellent. Okay.
Sir, I think there is a question. Availability of molecular and genomic studies at Pete's Cancer Care Hospital. Is there a central testing center?
Repeat, sir.
Answer.
We have genomic laboratory.
Any other questions?
No. Thank you.
Okay. If there are no questions, thank you, sir. Thank you so much.
Thank you very much.
Thank you, sir.
Good to see you.
Thank you, sir, for sharing your great knowledge with us. Moving towards the next scientific session, we have with us a renowned and great spokesman, Dr. Sarjan Qureshi, Professor of Surgical Oncology.
Sorry to disturb. There's an echo coming from the main center. I repeat, there's an echo coming from the main center. If there are more than one instrument, please switch it off.
Yes.
Go on.
Moving towards the next scientific session 3, we have with us a renowned and great spokesman, Dr. Sajid Qureshi, Professor of Surgical Oncology, Tata Memorial Center and Hospital, Mumbai, to speak on pediatric renal tumors. For chairing this session, I invite Dr. Abhay, Associate Professor of Department of Surgical Oncology, and Dr. Prasad C, Assistant Professor, Department of Urology.
Invite. It's my great pleasure and privilege to invite my teacher, Dr. Sajid Qureshi from the Tata Memorial Center, Mumbai. He is the Professor of Pediatric Surgical Oncology at TMH, Mumbai, and has authored more than 120 publications in several reputed journals, and has authored several chapters in many reputed textbooks. Some of the many awards which he's received is the VG Kale Gold Medal in Anatomy and the International Outreach Fellowship in Pediatric Surgical Oncology at the St. Jude's Hospital, US. Over to you, sir. Sir will be speaking on pediatric renal tumors. Thank you.
Good morning, good evening, good afternoon, sir. With this background, I would like to invite Dr. Sajid Qureshi to our pediatric cancer CME. Over to you, sir.
Thank you. At the outset, I would like to thank the organizers for giving me this opportunity and Dr. Professor Gopinath for letting people know that someone is doing pediatric surgical oncology in our country. So I'll be talking on pediatric renal tumors. If you see a child with a renal mass, 90% of the time that renal mass will be a Wilms tumor. It's the commonest renal tumor in children. There are other renal tumors, which are the good ones and the bad ones. The good ones are the benign ones, and the bad ones are the very aggressive, like the clear cell sarcoma of the kidney, malignant rhabdoid tumor. And we do have renal cell carcinomas in children also. So since it is the most common tumor, we'll be talking more of Wilms tumor. And a small commentary about the non-Wilms tumor. Wilms tumor overall forms 6% of all childhood tumors. And this is the perfect example of a multidisciplinary tumor approach. Wilms tumor, with the treatment of Wilms tumor, started this multidisciplinary thing where everyone was involved in the care of the patient. And as a result of all these things, we are now currently having a very good outcome for Wilms tumors. Even the stage for the metastatic ones have attained a outcome of 80+ in most of the center, and the early stage tumors, they are reaching almost 100% in many of the developed countries. The evolution of treatment of Wilms tumor is summarized with this graph. It was a surgical disease to begin with, like many other solid tumors. Wilms tumors was a surgical disease, and with only surgery, the outcomes were around 30%. With the addition of radiation, the outcomes improved. But the significant step was introduction of chemotherapy, multi-drug chemotherapy, and there was a meteoric rise in the outcomes, favorable outcomes for Wilms tumor. And the cooperative group, the North American group, the National Wilms Tumor Study Group, took over from there in the late 70s. and a multidisciplinary approach, which involves chemotherapy, radiation, and surgery, gave this outcome what we are having right now. And subsequently, the Europeans also joined with their multidisciplinary approach. And now we have two important groups who are involved in the active care or running trials for WIMS tumors. Now, our country, we see all shapes and sizes of WIMS tumor, a palpable renal mass, not so small, we call it large tumors, but we have larger tumors, and we have the extra large tumors also. So we get all varieties of tumor in our country, mostly because of lack of access or ignorance about early coming for care of these patients. And it is not uncommon to find masses like this with venous engorgement, that is the thrombosis of the IVC. And this is so rare to find a varicocele in a patient with a left renal tumor and which obstructs the renal vein and then the gonadal vein. But here is an example in a child with a varicocele because of a large renal mass with an IVC thrombus. Most of the patient, the first investigation for abdominal lump is an ultrasound. Ultrasound is a very useful tool, and usually it identifies the site of origin. Sometimes adrenal tumors may give a little problem, but usually it very well identifies the site of origin. Apart from that, it also gives information about the patency of the renal vein and the IVC. The next radiological investigation is a CT scan, which is usually the standard now. MRI has its advantages, but it is the CT abdomen and pelvis and thorax, which is used in the staging of these tumors. It not only confirms the site of origin, it also gives us the information about the contralateral kidney, the lymph nodes, though one cannot say whether the lymph node, enlarged lymph node, is a positive lymph node, but we can get a fair idea about it. And pulmonary mets, which are usually seen in 10 to 15% of patients with renal tumors, are seen very well with a CT scan of the thorax. Some, because of its association with von Willebrand disease, acquired von Willebrand disease, it's always helpful to have a coagulation profile done for these patients, for any patient with a renal mass. And presently, the role of PET scan is not there, and hence it should not be used in the diagnostic workup of a patient with a renal mass. The next important thing is, once you have a renal mass, the commonest thing is people say that it's a renal mass and we need to confirm it. The answer to this question is very complex. Let me simplify this thing, and we'll touch upon that biopsy component later also. But here, if you have a renal mass like this, which is well circumscribed, the classic claw sign is there, displacing all the structures, but not infiltrating the adjacent structure. Instead of a biopsy, you can go ahead with an afferent nephrectomy, thereby avoiding a nephrectomy. So half I'll answer this question now and half I'll answer later. So a resectable tumor, well circumscribed tumor, you can go ahead with an afferent nephrectomy and avoid a biopsy. Now, when I was in my MBBS, I found the staging of WIMS tumor very complex because it was very wordy. And we are used to that TNM thing, which is T1, T2, 3, T4. And this was little wordy, but it's very easy to remember. Now I can remember it very well because I've just narrowed it. So a renal tumor or a WIMS tumor, which is completely confined to the kidney and it is removed completely, is stage 1. If it is extending outside the kidney, yet you have removed it completely, then it is stage 2. And if it is extending outside and not removed completely in the form that you leave some disease, or you remove but you have margin positive, or you have lymph nodes, or if there is rupture of the tumor, then it is stage 3 disease. And stage 4 and stage 5 are self-explanatory. We have a histological classification for Wim's tumor. And because there are two different groups, larger groups, which are taking care of, which are mostly involved with Wim's tumors, we have a two histological classification. The American use this approach, which is the favorable and the unfavorable histology. The unfavorable histology is by virtue of having anaplasia, which could be focal or diffuse, and the CCSK and the MRTA are also included in the unfavorable type. The SIOP, the European approach, this is after chemotherapy, so there is a modification in the histology, and this approach, this histological classification divides the tumor into three groups: low, intermediate, and high risk group. The low risk includes the CMN, the congenital mesoblastic nephroma, the cystic partially differentiated nephroblastoma, which is CPDN, and the completely necrotic tumors. The intermediate ones are the different variant and focal anaplasia. And the high risk are the patients with diffuse anaplasia. A small mention about nephrogenic rest. These are persistent embryonal nephroblastic tissue. They could be intralobar or perilobar. Multiple nephrogenic rest is called nephroblastomatosis. The importance of this is when you encounter in a single unilateral nephrectomy specimen these nephrogenic rest, you have to be cautious about the patient having a syndromic association or a tendency for developing new tumor, especially when you have done a partial nephrectomy. This is a patient we encountered recently. This is a very rare form. This is the DHPLN, diffuse hyperplastic perilobar nephroblastomatosis, huge kidneys. And in this huge kidney, there is a Wim's tumor. And in the pre-COVID time, there was a single lesion. The patient got lost because of the COVID. And when he came back again, they were bilateral Wim's tumor. So coming to the treatment of Wim's tumor, it is largely based on the stage of the disease. Stage of the disease is a surgical staging, not a radiological staging. And the histopathology, depending on which group you're following, you can take the favorable and the unfavorable, or the low, intermediate, and the high risk of the European group. The therapeutic modalities available for management of renal tumors are surgery. The frontline chemotherapy drugs are three: vincristine, actinomycin B, and doxorubicin. And radiation, not in all patients, only when indicated for specific reasons. Now, I'll just demonstrate all the individual component of the management. With surgery, you can have a transperitoneal approach. You can have the retroperitoneal approach, which the adult colleagues prefer for RCC. I cannot stop anyone from saying that transperitoneal or retroperitoneal is better one over the other. Both are having their own advantages. We prefer a transperitoneal approach. And when there is a large tumor which is displacing the liver or diaphragm, going high up in the thorax, you can also take the thoracoabdominal approach. The important component in a surgery in doing a nephrectomy is, according to many, a very simple job. But the two essential components in renal tumor, childhood renal tumor, is first, you should make all attempts to avoid a tumor spillage. And second, which is most important, don't forget to sample the retroperitoneal lymph node. For the people who say there were no lymph node there to be sampled, what we should remove: no lymph nodes are given by gods. They are the normal structure present in the abdomen. They need to be searched if they are not apparent. There is no child in the world without retroperitoneal lymph node. So it's not an excuse that there were no lymph nodes seen. That's why we have not sampled the lymph node. No, that is not an argument. Always you have to sample the retroperitoneal lymph node. We did a study, because there is still now in the literature, there is no template, which lymph nodes to be sampled. Many people, they just pick the nodes at the hilum and they conclude, yes, we have done the sampling. No, that's not the way to be sampled. And since there was not any template in the world till now from where to sample, people gave a arbitrary number that you have to remove 7 lymph nodes, you have to give 6 lymph nodes and all those things without any evidence. We did this study for the first time where we sampled the lymph node based on the normal lymphatic drainage of the kidney. And these are the lymph nodes which are involved in the lymphatic drainage of the kidney. And likely these will be the lymph node where the metastasis would go. So for right-sided tumor, we had paracaval lymph node, and for the left side, we have para-aortic lymph node. So we had suprahilar, hilar, and infrahilar, paracaval and para-aortic node, and we divided the interaortic caval region into suprahilar and infrahilar interaortic caval lymph node. For unilateral tumor, 5 stations of lymph node have to be sampled. Right side, the paracaval and the interaortic caval, and for the left side, the left para-aortic and the interaortic caval lymph nodes have to be sampled. Now, we had this study, we had several patients, and we were very disciplined in removing at least from 5 station, at least 1 lymph node, or even if lymph nodes are not present, you can take the adipose tissue because there may be microscopic lymph node. And throughout, the idea was not doing a clearance, it was only sampling. And we did not send for the frozen section because we have achieved the target of sampling the lymph node, which were most likely to have the lymphatic drainage coming from the kidney. And we found that the hilar station was the commonest site of lymph node metastasis. To our surprise, the interaortocaval lymph node were the second commonest site for lymph node metastasis. And the most surprising part was skip metastasis. You don't have any hilar or paravascular lymph node, but you have interaortocaval lymph node. Now, this brings to the attention that berry picking is not the case, and you should be very regimental in your sampling of the lymph node. It cannot be an arbitrary. It should be based on sound lymphatic drainage, and which we did. And we concluded that interaortocaval lymph node sampling should be performed in all patients because skip metastasis may occur without any metastasis to the hilar lymph node. We got this published, and this has found a place in the NCCN guidelines for management of Wilms tumor also. Coming to the treatment other than nephrectomy, can we do partial nephrectomy? Yes, absolute indication for partial nephrectomy for the upper 3 condition. For unilateral Wilms tumor, the evidence for a partial nephrectomy is not well defined because the basis is that why do you want to save the nephrons? You want to save the nephrons so that there should not be any end-stage renal disease, renal failure. With unilateral tumor, the incidence of renal failure is less than 1% at 20 years, but the chance of recurrence and the subsequent recurrence and aggressive treatment just overshadows this advantage. So we don't usually do a partial nephrectomy for unilateral Wilms tumor. And if at all, if it is a very small lesion, especially after chemotherapy, polar tumor, then definitely yes, if you can ensure a complete excision, definitely unilateral nephrectomy, partial nephrectomy is not banned. There is no solid evidence to that, but there is no evidence to not do also in suitable patients also. The next thing is laparoscopic surgery. Laparoscopic resection, I confess that I don't have any experience with this because I believe that there is no advantage. Forget about getting drawbacks or disadvantages. I don't find any advantage in getting the tumor out from a small keyhole and making a big incision for getting the specimen out. I don't have that sort of feeling. But definitely people are doing this laparoscopic dissection in selected patients. But the evidence for a better outcome with this is not there. So it's individual perception whether he'll be able to remove the kidney laparoscopically without creating a problem and with maintaining that supposed advantage which he has in his mind. The next thing for renal tumors, especially Wim's tumor, is the intravascular extension. I remember still in our MBBS days, people used to say that you should not palpate a lump in the abdomen in a child with Wim's tumor because you will break the thrombus and it may embolize. That's not correct. It doesn't usually happen, and definitely you can go and palpate. All levels of thrombus can be there. It could be renal thrombus, it could be infrahilar IVC, retrohepatic IVC, suprahepatic, or the first image on A is in A1 is the retrohepatic IVC thrombus. The second image is intraatrial thrombus, and the third image is intraventricular thrombus. In all these patients, it's always advisable, and we prefer giving chemotherapy first rather than doing any heroic surgery, because majority of these thrombuses, they shrink with chemotherapy, or at least they become fibrous, and removal thrombectomy becomes better with chemotherapy. We don't do these things venogram. For some reason, this patient had a venogram. You can see that segment of IVC is completely blocked and there is good amount of collaterals. The only positive thing what we get from here is that in these cases, in presence of good collaterals, you can go ahead and do a cavectomy also, because the collaterals are well formed. And for thrombectomy, we take good control, the infrahilar, the contralateral. This was a left renal vein thrombus. The right hilum is taken care of. And it is advisable that in especially retrohepatic thrombus, not infrahepatic, you can take a suprahepatic IVC control. Sometimes the tumor is just peeping into the IVC, not extending up. These are easily removed. And for the other ones, here is the difference between RCC thrombus and Wim's tumor thrombus. Most of the Wim's tumor thrombus, what we operate, or rather almost all, we give chemotherapy. So after chemotherapy, these tumors are not like simply can be pulled down like a ribbon like you have in RCC. You have to work for their removal. They are not infiltrating. This is a misnomer that the tumor was infiltrating. No, the thrombus don't infiltrate the vein. Vein is a very sturdy structure. They become adherent to the intima, so you have to work for removal of these thrombus by gentle, blunt and sharp dissection, and then you can close with the regular Prolene or whichever suture you prefer. And we don't give any anticoagulation in these patients. Only when we have a cardiac bypass and atriotomy has been done, only in that cases, very brief period, and within 3 months we stop the aspirin also what is given. The idea of removing the thrombus is it has to be removed in toto, because the moment you fracture the thrombus, you will make the tumor stage 3, and the advantage is lost. So you can remove the thrombus. And one more thing is that the thrombus is not definitely going in one direction of the blood flow. It can go back. Here in the left image, you can see this is going down into the infrahilar IVC. It went into the contralateral renal vein and also in the left adrenal vein. So it can go both way in the direction against the blood flow also. And we got our experience of intravascular extension also published. And this was the outcome we had. So usually they say whenever there is an intravascular extension, the outcomes are inferior, but we disproved this. Our outcomes were almost similar to our patients who were not having an IVC or vascular thrombus. That's what we are saying. And in fact, if there is an atrial or a ventricular thrombus, the regression may be so beautiful that the thrombus may come down in the retrohepatic region and you will avoid a cardiopulmonary bypass. So that's the advantage. And one important finding we had that if the tumor thrombus is having Weibel disease, is it significant? Is it affecting outcome? Majority of our patients receive radiation, so we could not answer that question, but that question is still open. Presence of Weibel tumor in the thrombus, does it affect the outcomes or not? Finally, after the chemotherapy and surgery, we have the radiation. Radiation is only given for patients with stage 3 disease. Ideally, it should be started at 10 to 14 days. If there is local stage 3 disease, the local radiation is to the point of 10.8 grays, which according to many radiotherapists is a homeopathic dosage. It does not cause any problem, but that's the dose which WIMS tumor respond to. So it is very well tolerated by children. And if there are lung metastasis, they have to be given radiation. We prefer giving radiation even if the mets have disappeared based on our outcome. But things have changed both in the PSYOP and the COG group, and they avoid radiation but continue doxorubicin if the metastases have disappeared at 6 or 9 weeks of chemotherapy. Now, that was the broad outline of the different ways of diagnosing and managing the tumors. Now, when the patient comes to you, how do you decide which course you should take, whether you go the North American ways, which is the NWTS group, which is now being renamed as the COG renal tumor study group, or the PSYOP group, which is the European group, which is also doing great work, had done great work for improving the outcomes of WIMS tumors. So the next thing is you would like to compare which one is better. Is the American better or the European better? But they are like apples and oranges, and there cannot be a direct comparison. Why? Because the nephrectomy group, the NWTS group, COG group, they prefer upfront nephrectomy, and depending on the surgical stage and the uncontaminated histology, adjuvant treatment is given. While the European, they give chemotherapy first and do the surgery later, and depending on the histology and the stage, the further treatment is decided. The problem, or rather the end point, is here. With either of the approach, you can see the outcomes are almost similar stage by stage. So it could be said like this: if I want to go from one place to the other, there are two ways of going. Both take similar time. So it is on us. Basically, it's a cafeteria which is open, and we can take sandwich or we can take our dosas. The bottom line is that your tummy will be filled. So based on your capabilities and your infrastructural support and your ease and comfort, you should decide, not dictated by the Americans or the Europeans. So each one, if we dissect the advantage and the disadvantage, the Europeans say when you give chemotherapy, the large tumor becomes small and the rupture rate goes down, and that's why you get more stage 1 disease. And more importantly, you can demonstrate in vivo whether this tumor is chemoresponsive or not. If it is shrinking in size, it is a prognostic indicator. The disadvantage, or the NWTS group claim that these are the disadvantages, that since they don't do a biopsy, it is a blanket chemotherapy for all. You may give chemotherapy to unindicated region, or inferior chemotherapy to non-WIMS tumor, which would have required aggressive chemotherapy. Plus, you change the histology, and your stage 1 is not really stage 1; it was stage +1. Because of your chemotherapy, it has stage migrated. So those are the disadvantage. And what they say, why we are better, the Americans are better, because we get to know the uncontaminated histology and the true tumor extent. And we can take tissue for untreated tissue for biological studies. And they have been doing LOH1P and 16Q, and they have been altering their management based on this. So these are the things. But when you analyze all the results together, you should see what is there for me. And once you have taken all the advantage and disadvantage, you summarize that. If you go the European ways, 50% more are treated with doxorubicin. And because the North Americans are cowboys, they want to operate anything, they cause more rupture and more stage 3 disease. 50% of them receive more of radiation. What is the midway? Can we have something which is best suited to us? That is the question. And these are the disadvantages of giving radiation or chemotherapy. What we have done is a cafeteria approach, which is customization of therapy based on the individual patient. And it is not the surgeon, because according to surgeon, he can remove anything. And one of my favorite teacher used to say, I can remove anything provided it is not stuck to the table. But we have to get away from that mentality and come to objective criteria like radiology. So with radiology, the radiology should help us that these are the patients you can go the American way, like upfront surgery, or these are the patients where you should go the European way. Like, for example, the first image. This is a very well circumscribed tumor. It is not involving the adjacent structure, can be taken up for upfront nephrectomy. And when you have a situation like this, there is perinephric fluid indicating a rupture. The margin in the second image, lower image, is very fluffy, indicating that there is perinephric extension. In these patients, when you have extensive lymph nodes and these lymph nodes are, if positive, then it is stage 3 disease. If you have vascular thrombus, if you want to do a venotomy, there is a chance there will be a spillage if your thrombus is friable, and thus makes it stage 3. And here, when you have large tumor, what is the definition of large tumor? It is very subjective. What is not subjective is radiology showing that the tumor is crossing the midline. Means half of the abdominal cavity is filled with tumor. So with this anatomical landmark, if you have this, now what's the problem in this? Many surgeons will say this is very resectable, I can do it. But the problem is that large tumors, there is a chance for tumor rupture. Why do you want to intentionally put the child to risk of rupture and having a stage 3 disease when you can very well give 2 drugs of chemotherapy for 4 weeks, make this tumor small and operate nicely? So if you have these 4 or 5 criteria, we planned this study. And based on the study, we do a clinical radiological assessment, and only well circumscribed tumor, low volume tumor will be operated upfront. The other tumors were not called purely inoperable, but they were borderline. And in these tumors, we did a biopsy because the UKCC group have advocated biopsy, and they have showed that biopsy does not upstages and does not causes any complication or recurrences. Based on that evidence, we had done biopsy in patients where we felt the tumors were borderline. After the biopsy, we get to know whether it is a WIMS or a non-WIMS. We give 4 to 6 weeks of, or 4 to 8 weeks of chemotherapy, followed by surgery and then adjuvant treatment. So we had these patients, and we selected only non-metastatic unilateral tumors without any evidence of rupture or stage 3 at the outset only. And these were our aims. That was the tumor distribution, bilateral, unilateral. And these were the 5 radiological criteria we have taken. If you notice, the first perinephric spread and crossing midline were significantly lower in the patients we selected for upfront nephrectomy, and after chemotherapy, there was a reduction, significant reduction in the perinephric spread and the size of the tumor. And here, the volume, you can see in the upfront nephrectomy, we had a volume of only 218. Please focus on the red highlighted area. And the large tumors had a volume of 504, which reduced to 300, significant reduction after chemotherapy. For example is here, this is a left-sided large tumor. On the left side, after chemotherapy, it has become so small, so easy to operate. Just 4 weeks or 6 weeks of chemotherapy. Right-sided tumor, significant regression after chemotherapy. Here, not only the size of the lymph node, if you see there are lymph nodes, that lymph nodes have also responded or regressed or disappeared with chemotherapy. There have been situations where the size does not change, it remains the same size. And there are instances where the size rather increases. The left was the pre-chemo and the right was a post chemo, you can see this bulge, which shows that the size has increased. But if you compare the images, the solid areas are gone. It is a completely necrotic tumor. So definitely there is a not a morphological, but definitely there was a tumor response. And these are the different histology we got. We got all the WIMS and non-WIMS in the upfront setting. And since we did a biopsy in the delayed setting, we identified the non-WIMS tumor and we upgraded their chemotherapy. So the chemotherapy was not the inferior chemotherapy in the other patient. And this was the stage distribution. We had only stage 1 in one WIMS tumor and in one non-WIMS tumor. And this is the stage distribution when we compared our results with NWDS5, which they do for upfront an immediate nephrectomy. So we found very low incidence of stage 3 disease. The single patient with stage 3 disease was because of inadvertent spillage in our set. And when we compared with the delayed nephrectomy, almost a similar distribution were there. And when we compared the incidence of overall rupture in a subset of patient, the COG earliest study, even the latest AREN 532 study had a rupture rate of 11.5%. The SIOP, which gave chemotherapy, had a rupture rate of 2.8%, and our rupture rate was only one case, which made the percentage 1.3%. If we see the duration of surgery and the blood loss, it was not different. It's not that if you do an immediate nephrectomy, you take more time and do more blood loss. It is not the time and duration remains the same, except for one rupture. No other complication was there. And we had almost 100% outcome in the immediate nephrectomy and 80+ outcome in our patient with delayed nephrectomy. We published this approach of ours, and we also won the best paper for the study in SIOP. And finally, we conclude that we can stratify patient based on not on subjective criteria of the surgeon that I can operate, I cannot operate. It is on reproducible radiological criteria. Even a medical colleague and the radiation colleague can take a decision on the surgeon's behalf. No, you have these criteria, you should not be operating these patients. And radiology definitely identified low stage tumor. Majority of our patients were stage 1 who were operated upfront, and the surgery is facilitated by chemotherapy. And biopsy is safe. We didn't have any problem with biopsy in our patient. And on the plus side, we identified a few non-WIMS tumor and a benign tumor, which helped us in changing the treatment. The next aspect is bilateral WIMS tumor, which is seen in 4 to 13%. They can occur at the same time, that is synchronous, or after successful treatment of the index kidney, the contralateral kidney can have. And this is an example of a synchronous bilateral WIMS tumor. This is an example of a metachronous bilateral WIMS tumor. Left nephrectomy and treatment has been completed, and now there is a lesion on the right side. Usually bilateral tumors have an earlier age at presentation. They are more often syndromic. The problem here is syndromic bilateral tumors as compared to syndromic unilateral tumors have a higher tendency for renal failure, so end-stage renal disease. So a little extra caution, and that knowledge is very important. Again, the question of whether to do biopsy or not. Here, the biopsy for WIMS non-bilateral tumor, why it is not done? How common do you find bilateral non-WIMS tumor? These are all anecdotes. If you have bilateral renal masses, almost all the time it is WIMS tumor, because there are very few instances of having bilateral non-WIMS tumor, as these are reported as case report or as part of large series, only few. And in last 16 years in Tata Hospital, we have seen one bilateral malignant rhabdoid tumor, that's it. So biopsy is not required because most of them are a WIMS tumor. Secondly, with doing a biopsy, you would want to know whether there is any high-risk feature so you can upgrade the treatment. Again, the biopsy does not help to identify any place here. And lastly, is it a WIMS tumor or a nephrogenic rest? this question cannot be answered with a biopsy because you cannot really differentiate a nephrogenic rest from a Wilms tumor because histologically they'll be same. Yes, there are certain radiological features, especially MRI, which are useful for differentiating Wilms tumor and nephrogenic rest. Otherwise, biopsy is not the tool to identify nephrogenic rest. So treatment of bilateral as compared to unilateral is challenging. There were no evidence-based approach as of yet, but the recent ARN 534 study did a programmed study in the sense that the chemotherapy was fixed, the surgery at a fixed duration, and they have published this prospective study with good outcomes. The goals of treatment for bilateral Wilms tumor is save the kid first and save his kidney. This can be done by removing all tumor and preserving as much renal parenchyma, especially in the syndromic one, as possible so as to reduce the risk of renal failure. This treatment is very standard. You give all. This is a place where the Americans are in sync with the European, where they say, yes, chemotherapy has to be given in all these patients, followed by delayed surgery, and radiation will be decided based on whether it is stage 3 or not. So 3 drugs chemotherapy, assessment at 6 weeks. If you don't see any response, it could be either an anaplastic histology or a rhabdomyomatous or a teratoid differentiation. You can give 6 more, and beyond 12 weeks, there is no point in waiting, changing or increasing the dose or the drugs. You have to go ahead with surgery. The surgical component, the surgeon's fear is, what approach should I take? What is the function of individual kidney? Should I do the tumor same sitting, or should I do one side first and followed by the other? Or should I do the worst side first and the less affected side first? Should I clamp the renal vessels, or should I just apply ice over the kidney for the ischemia? These are the questions which a surgeon should answer to himself, and whichever way he is comfortable, he should perform. The options are either you do a bilateral nephron sparing surgery on both sides. The worst affected side, you can have a nephrectomy, provided the contralateral side, you can do a nephron sparing surgery. In a very difficult situation, though this is not uncommon, it may occur, but majority of the people in our own experience is that the radiology sometimes overestimates the thing, and something which is not appearing to be like nephron sparing surgery possible on table, you can find that it could be possible. And people have now advocated enucleation or a tumorectomy, wherein the idea is to have just a sliver or a marginal resection is also advisable. But the bottom line is that you should never forget to sample the lymph node again. Examples of some, the left side is a large tumor going into the sinus. You can get away with a nephrectomy because the right side is polar and you can have a partial nephrectomy. Another example, this is a bilateral large tumor. You can see the fat areas. This is a teratoid differentiation. No further chemotherapy is going to be helpful. But if you carefully analyze, there is some normal renal parenchyma here in the lower part, and you can exploit that. Though you should take a consent for a bilateral nephrectomy and be ready with your team and the nephrologist for having a nephric state, but definitely an attempt can be made for a partial nephrectomy or saving at least 1/3 of the kidney. And when the tumors are superficial polar like this, you can have bilateral partial nephrectomy also performed. Some of the surgical examples, cortical tumor, very well circumscribed, the calyces are seen, identified, taken care of, and then you can achieve hemostasis with sutures or clips. This is a complete hemostasis, and you can either apply glue in the upper left-hand corner, or you can use Surgicel or gel foam or box stitches to control the bleeding. If you want to see a nephrogenic rest in vivo, this is how the nephrogenic rest looks like, and we do pouring for these or excision of these tumors. In the event that you encounter a bilateral nephrectomy, what is the problem with that? Bilateral nephrectomy, definitely these patients will require a kidney. These patients have to complete their chemotherapy. The transplant cannot be done. The transplant has to wait. These patients will be on dialysis for at least a year till the patient declares himself a survivor, and then you can go ahead with the transplant. The problems with transplant is that it requires immunosuppression, lifelong immunosuppression, and it is not once for all, it is having a lifespan. The lifespan of the transplanted kidney is 10 years if it is a cadaveric donor, and it is 15 to 20 years if it is a live donor. And size constraint, because majority of the kidneys are from adult cadavers, and those things are there. So these are the issue with renal transplant. Any complication, the complications with partial nephrectomies are very standard, and last complication I have not mentioned is the anephric state. Even after a successful partial nephrectomy, there may be event or a renal shock, and the kidney may refuse to function. So you may land up with an anephric state. And the most dreaded one is the renal failure. End-stage renal disease. For synchronous, it is 9% incidence at 20 years, and for metachronous, it is 18%. Most of the time, it is the need for a nephrectomy in metachronous Wilms tumor. That's why the incidence is high. And especially in the patient with genetic predisposition, the chances of end-stage renal disease is also high. These were the initial survival figures of the COG and the SIOP group. The ARN study have reported excellent survival with their regimented approach, but long-term data is awaited. And will this continue, this better outcome continues with time has to be seen, but definitely a way is being provided in treatment of these tumors. So nephron sparing surgery may be feasible in many, and the treatment is definitely not simple. The non-Wilms tumor, I'll just briefly touch upon them. These are very bad tumors. This rhabdoid tumors is most common in infants, and this is called the brain metastasizing tumor of the kidney, because they are associated with brain tumors, atypical teratoid tumor, and they are known for their resistance to chemotherapy. We had very few patients who were non-metastatic. They received their induction chemotherapy and went on to go ahead with surgery, but the outcomes were dismal. Then the second type is the clear cell sarcoma, which is relatively better, and the favored site for metastasis is the bone. Sometimes this is called as the bone metastasizing tumor of the kidney. Brain metastasis is also there, but again, as compared to Wilms tumor, the outcomes are not that great. And the favorable ones are the CMN, congenital mesoblastic nephroma, the CPDN, the cystic nephroma, metanephric adenomas, and all those things. They are benign tumors, and surgery is the only thing which is required. We published our experience of more than 100 patients with non-Wilms tumors, and this is the lowest tumors are the benign one. They had 100% outcome. We had 60% outcome with the other high-risk tumors. And individually, as expected, malignant rhabdoid tumor, we didn't have any survivor after 2 years. The renal Ewing sarcoma, we had a survival of 50% with them, and the RCC fared better as compared to the clear cell sarcoma of the kidney. Thank you very much for the attention, and I'll be happy to answer any questions.
There are 2 questions, sir.
Yeah.
Thank you, sir, for your excellent and lucid talk on Wilms tumor. There are 2 questions in the chat box, sir. One is, please give your opinion on clear cell sarcoma of the kidney and Wilms difference bar similarity in prognosis and management.
in clear cell sarcoma and Wilms tumor. Clear cell sarcoma, they are mostly amenable for chemotherapy. They do respond to chemotherapy. They, as compared to Wilms tumor, as surgical component is concerned, the response with Wilms tumor is better than clear cell sarcoma. The ease of surgical resection is better with Wilms tumor as compared to clear cell sarcoma. Lymph node metastases are quite high, and you may end up with extensive lymph node dissection in clear cell sarcoma, which is not recommended in Wilms tumor. And except for stage 1 clear cell sarcoma, even stage 2, 3, and 4, we require local radiation. So that's the difference between clear cell sarcoma and Wilms tumor.
Thank you, sir. One more question, sir. 7-month-old boy with atrophic right kidney with Wilms tumor in the left kidney. Kindly opine regarding the management.
Sorry, come again.
7-month-old boy with atrophic right kidney and Wilms tumor in the left kidney. What's the management?
Wow, that's a very interesting case. I'll be delighted to treat a patient like this. So effectively, we have, we can say, a solitary kidney, Wilms tumor in a solitary kidney. We had a few solitary kidney where the kidney here it is atrophic, but we had patients where the kidney was absent. And you should not change your track. Continue with the principle of giving neoadjuvant chemotherapy. Don't be heroic. If it is a small lesion, don't disturb it. Go ahead with your chemotherapy. If you want a biopsy, do a biopsy just to exclude whether it's a non-Wilms tumor so that you can upgrade your chemotherapy. Go ahead with the induction chemotherapy. Assess again after 4 to 6 weeks of chemotherapy. And the same principle what you apply for partial nephrectomy, you should go ahead. Age is not a problem. Extent is not a problem. Metastasis is not a problem. The approach should be very standard, which has been prescribed. And definitely, even despite all these things, then it is God's wish, and then you have to go ahead with the management of a nephric child and the transplant. So you should hope for the best and continue the treatment which is documented, rather than doing any experiments.
Thank you, sir. Thank you. Any more questions? Any more questions? Thank you, sir, for your wonderful talk.
My pleasure. Thank you.
That was a great session, sir. Thank you. We shall now have a break for lunch in the second floor of library. We'll be back by 2 p.m.
All the delegates, please join by 2 o'clock. Thank you. Sir, Shashidhar sir, good afternoon, sir. Shashidhar sir,
Yeah, good afternoon.
can
Hello.
we start the session, sir?
Yeah, we can start.
Okay, sir. Okay, sir.
Welcome back. We shall now proceed with the next scientific session on a glimpse of future postgraduate education in Pacific. We are very fortunate to have with us Dr. Venkatesh Murthy Shashidhar, Associate Professor of Pathology, College of Medicine and Dentistry, James Cook University, Australia. To chair this session, I invite Dr. T.N. Suresh, Professor of Pathology, and Dr. N. Sarala, Director of Academics.
Very good afternoon to all of you. I have the pleasure of introducing one of the eminent pathologists and educationists, Dr. Venkatesh Murthy Shashidhar sir. Most of the esteemed staff know sir because in the December 2018, sir visited our campus and he enlightened us on the innovative e-learning, and also he guided us how to set up a digital pathology lab. So we are fortunate to have you once again, sir. Sir is at present working as Associate Professor and Head of Pathology at the prestigious College of Medicine and Dentistry, James Cook University, Australia. Sir had several publications in reputed journals. He received several awards. To name two awards, one is a faculty citation for outstanding contribution to the student learning from James Cook University in 2011. Sir also rewarded with Australian National Learning and Teaching Council Award, that is citation for outstanding contribution to student learning for innovative pathology teaching in rural medicine school in 2011. What we know is Dr. Shashidhar is a very eminent teacher. He loves teaching. So he always gives talk on how to make the teaching simplified. So today we have sir educating us on postgraduate education in Pacific. So what are the changes that's happening? So over to you, sir.
Thank you. I'll share my screen. Is my screen shared and audio okay?
Yes, sir. Yes, sir.
Thank you very much. Thank you all colleagues. Thank you for the opportunity. My special regards to Professor Ram Narayan and Pradeep, Vice Chancellor, for inviting me to share my experience. I do apologize because I'm talking something different, but I have tried to include cases of pediatric oncology. So this is my journey of establishing a very unique postgraduate training in Fiji Islands, and also now extended to Samoa, PNG, and Kiribati. Our team is actually very big, but the key people are Dr. Abha Gupta. She's the head of pathology at FNU, Fiji National University, Fiji, and Dr. Leslie Kuma from Africa. He is the consultant RCPA, Royal College of Pathologists of Australasia, and Dr. Raghwa Sharma. He is also a consultant RCPA. And recently, about over a year ago, Professor Rajendra Singh, the inventor of Path Presenter in USA. Giving acknowledgement to this, I'll start my journey. Most of you know probably Fiji and other Pacific Islands are the premium 5-star destinations for tourism. All famous people visit there. Most expensive hotel in the world is in Fiji. So Pacific Islands is a beautiful natural beauty islands, but very small islands distributed all over South Pacific. between Australia and Hawaii, America. Very small islands. Some of the islands so small, only few people can stand. And whenever we were asked how many islands in Fiji, the next question comes, is it high tide or low tide? Many islands disappear on high tide. But some big islands are inhabited. Now, although it is the nature's bounty, it is a developing economy. These are some of the pictures, the past and during my presence there in Fiji, and the current bustling economy, thriving, developing. So it's very rapidly developing. I joined Fiji as a single pathologist in the medical school. The medical school caters for all the Pacific Islands. The students from all different Pacific Islands come to Fiji for their medical course. Now, the second medical school has started in PNG and now in Samoa. Now I'm teaching there as well. So, my story of Fiji Islands. I joined as a single faculty in 2000 and I worked there till 2005 before moving to Australia. I was the single pathologist, and the second pathologist was partly training in New Zealand, was the hospital pathologist. Naturally beautiful islands, 5-star tourism facilities, but lack of healthcare and shortage of professionals. And very interesting history is that since 1996, the government funded overseas training for specialization because of lack of specialists. Government funded overseas training became a failure because many of the trainees who went for overseas, that is Australia and New Zealand, did not return back. Whatever the reason, the country suffered lack of specialists. And in pathology, there was no pathology training. And a very interesting innovation was done by Solomon Islands at that time. And it was a telepathology, but established by surgeons. The surgeons who were visiting from Switzerland had this difficulty of lack of pathology service, no pathologist. So they trained a technician to cut the tissue, prepare a digital slide, and send the images overseas, including Fiji, where I used to report, and also to Switzerland. The pathologists used to report there. I'm still part of that telepathology, Pacific Telepathology Network. And then I started adding value to that by inviting our own doctors to send their cases for second opinion, teaching for medical students. So it was successful for some time, but it was not the answer. So in 2004, we established a unique postgraduate pathology course, and we did not call it fellowship and no equal accreditation for overseas, so that students should not go overseas. So we created a diploma and a master's program, 2 years of diploma covering basic science, pathology, microbiology, biochemistry, all targeted at a district level laboratory. And then masters in anatomic pathology, forensic, and hematology are currently, we have registrars for this. Now in 2004, we created the course, it was approved, but establishment of the course and starting of the program took nearly 4 years. In 2008, we started with the support from JCU, that is myself, and Royal College of Pathologists, Dr. Raghava Sharma. We started the program as a traditional program. That is, the consultants visited Fiji in block mode. I visited Fiji 3 to 4 times a year, conducting meetings, exams, teaching in block mode. But then it was difficult to get all the specialists in time. So curriculum was broken in its delivery. So we thought of what to do next, how to improve this. So the registrars were there, plenty. In the beginning, we had about 8 registrars, and then every year we have 3 to 6 registrars from all different Pacific Island countries, including Fiji. We used to have traditional teaching, lectures, seminars, slides, and specimen sessions, all face-to-face by visiting Fiji. But then in 2016, we started thinking about how to change. Now, these are some of my mobile pictures of my visit to Fiji. That was Professor Kamal Kishore. He was the head of pathology and microbiology. And then the registrars, the microscope room, we had the luxury of a 5-head microscope as well. And Professor Ferguson and all the registrars and Professor Kamal Kishore. The fun part was, it was a very good social interaction. We used to have a lot of parties. And of course, the 5-star hotel facility. But the problem was not getting specialists, consultants in time for the continuation of the program. The registrars were suffering from lack of continuous supervision. So then I took up appointment as an adjunct, and then I suggested, why not we do it partly online? So we had used Zoom, and we tried quite a few, 7, 8 softwares. Finally, we agreed on Zoom, and we started teaching. Now I take regular weekly sessions for diploma students and master students, covering the topics which were not covered by visiting specialists. So visiting specialists were still important between 2016 to 2018. And then the pandemic hit, the lockdown happened. So then we had an online meeting to discuss how best we can continue, what can we do. And in 2 years, Zoom had worked very well for us. I'm going to show you a demonstration of actual microscopy sessions, specimen sessions, how we conducted. So then everybody agreed. The consultants were supportive. The Royal College of Pathologists of Australasia allowed us the use of all the digital slides. I, being the member, I had the access to all the teaching resources. So we started a completely online, totally online in 2020, 100%, no visiting. Of course, there was no travel possibilities. Dr. Filipina, who was my student, is now the head of medical school, dean of the Samoan Medical College. Dr. Viola was the head of pathology and the pathology postgraduate program in PNG. And these are the registrars and the staff in Fiji. So we had discussions with the support of Royal College. We developed a totally unique, totally online, 100% teaching of postgraduates. So initially, yes, we had little problems. I'm going to discuss that more. That is Professor Ferguson from New South Wales in Australia. And then that is his colleague. And we had discussions. So he started microbiology program and I started pathology program, postgraduate, diploma, and masters. Now, the first thing we did was to create a WhatsApp group, simple, Pacific Pathology group. I invited all my known friends of pathology from all over the country, other countries as well. And then we started having discussions, and then all our online sessions were scheduled using WhatsApp, the best way to communicate for us. And then we started the regular sessions every week. specimens, slides, and teaching. Now, I'm just showing the video. I hope the audio works. Please comment me if any problem. This is an online session of teaching pathology using specimens, but also this actual recording was from a live it was a examination situation. Okay, so it was formative mid-year exam.
Sir, no audio, sir.
Aha. 1 minute. So I'll just try. No audio. Okay. Audio is coming for me, but 1 minute. Headphones, test speakers, and microphone. Hello, hello, hello.
Oh, yes, sir. Yes, sir. We can hear, sir.
Yeah, I think what you cannot hear is the system audio. You can hear.
So when you share the screen, you'll have an option of ticking share audio from that window. When you click share.
That's okay. Thank you. I'll just try. Yes, share sound. Optimize for video clip. That's the one. Thank you. So the technology still okay. I hope
the small polyp, and then at the bottom the red areas show the ulceration.
So what I'm trying to show here is the registrar describing a specimen and the two examiners, one from Royal College of Pathology, Australasia, myself at JCU, observing and giving comments. Yeah.
And this is one of flat ulceration, and then we can appreciate that the lower red arrow, there's a hollow and a hole inside, in the middle of the lesion. So this lesion is of elevated, ulcerated.
Okay,
central.
so that was just a clip of gross specimen session. And here is the microscopic session. Now, in the microscopic session, I usually open up multiple digital slides on the top. And each slide could be one from US, one from Europe, maybe a few from RCPA, Royal College slides. And I give control of the mouse to the resident. Probably most of you know, if anybody wants, I can give remote control to the person who can explain the slide. So what I do is I give the mouse control to the registrars, and he will discuss by moving the slide, giving the opinion, much like a real 5-head or 1,000-head microscope. Except that the microscope heads are in different countries and continents. So no limit geographic. So this is a video of an actual final exam situation where we open the slides and we give the control of the mouse to registrar at a time. Each registrar will get his chance and he will discuss the slides, means he will study the slide and he will write answers in his answer sheet, and which will be supervised by the local coordinator in Fiji. Okay. Question 7, question 8, 9, and 10. Totally 10 slides.
Okay.
Okay. And you can feel free, zoom in, zoom out as you wish, and we will give you the control. And because we are using Zoom, so we are planning to give extra time. So we are planning for only 10 slides for 2 hours.
Okay.
Okay. And make your answer in 3 headings. One is I'm just Abba know, and she will message me.
How good is Zach? How good is the resolution? Are you happy with the?
Yeah, very good. That's a good
Yeah.
thing. Okay, I will just give control to Zach, and Zach, just try before we actually start. Huh? So this is a cytology slide.
Looks like the quality is good.
Is good enough? Okay, thank you. And the timing is also reasonably okay. Okay. You view one of the slides after case number 5, which is histopathology, which will be slightly different. So, yes, this one. Use the mouse wheel to see if it zooms.
Let me click.
And just in case if you need to know what's the case number, on the top left, yes, that's the number. So that will be there in your question paper. Reasonably okay? So very good. Everybody, is it okay now? Shall we give him written paper? And then Friday we will have both viva, gross specimens, and feedback. Yeah. I have just sent it the link to you on WhatsApp.
Okay, I'll check it.
Yeah, you check it later. It is actually there are both.
Thank you,
So,
sir.
Zach, how did you find?
Okay.
So maybe we will have time for marking, ready for the feedback session.
Yeah.
Yeah. Okay. So one day that should be sufficient. Only one person. So VIP student. Okay. Thank you all.
Thank you, sir.
Thank
you,
you.
Dr. Leslie. Bye.
Okay. Take care. Bye. So what we did was we had meetings and we discussed how best we can transform the actual traditional face-to-face teaching to online. Now, these were the demo slides. I had kept it for you people to get some idea of actual how we did the digital pathology. So I've just selected, but today, because of time, I think we will just go through one slide only. And this slide will take me to the actual Royal College of Pathologists. And we will go to the slide, how it opens. Yes. It opened here. That's the Royal College of Pathologists. I've just opened. How do I? No. Yes. I opened the slide here. And the slide, we will open it again. And that's the slide. So now we are viewing the actual digital pathology slide of Royal College of Pathologists Quality Assurance Program. And these are the slides sent to all the labs in Australia. And the report is used to assess the quality of the anatomic pathology reporting. Now, can I give control to anyone who would like to? Can I give this to class 4 SDU-MC? That is
Yes,
probably.
sir. Yes,
Okay.
sir.
I will give control and just demonstrate whether it works here or not. So I have given now remote control to SDUMC. Try moving the mouse and a click will zoom in to the area where you click. And if you have missed, you can click on the upper right one. Yeah, wherever you click, it will zoom in that area. Yeah, and now you click on the image, it will zoom in or zoom out.
Yes, sir.
Okay.
Yes.
Thank you. So I just want to give that. Yeah, full. Yeah. Now I will just take back the control, stop remote control. Okay. So what I had selected was a case sent by Royal College of Pathologists, this one. And because I am the staff, so I get all the response. The actual case specimen. Now this is a 10-month-old baby male query Wilms tumor. So that was the tissue, that's the tumor, and that's the surrounding normal kidney. Now, the organ is kidney, specimen, and diagnosis. Now, before I just show only for pathologists, I'll just show back the slide and tell me the appearance. Okay, so I'm zooming in. That is the compressed renal tissue, glomeruli, tubules, interstitial inflammation, and some amount of fibrosis, and then the tumor. And the tumor seems to be infiltrating into the capsule. And the tumor as such is just areas of cars and sheets of fairly uniform cells, but they are all vesicular nuclei and a very clear cytoplasm. There were no tubules, there were no blastoid elements. Throughout the tumor was this collection of clear cells. So the diagnosis is quite obvious for a pathologist. Of course, we have to rule out a Wilms tumor, triphasic, biphasic, monophasic, everything is a possibility, but here it is very clear, suggestive of clear cell sarcoma. Now, if I go back to the slide, the lesion was correctly identified by the majority of the respondents. The HNE, even at low power, is a bland uniform blastomal component. Now, why we need to know the importance? The clear cell sarcomas represent a special type of non-Wilms. So they have a slightly poor prognosis compared to Wilms, and we need special stains, although the special stains in case of clear cell sarcoma are usually negative. Mutational changes are a new appearance, but again, it is not 100% sure. But one interesting note about this tumor is they respond very well to doxorubicin or adriamycin. So chemotherapy is the best option for these clear cell sarcomas. So it is a variant, not true Wilms. Okay, so just one sample case. We'll not go into too many these ones. I will just go back to one was clear cell sarcoma of the kidney, alveolar rhabdomyosarcoma, ischemic changes. I had selected few slides, but we will continue with our summary of the features. So what I try to give you is my experience of developing a totally online. Now, interesting is this year, to 2021, although still borders are not open, so it has to be still online. So we did again all online teaching whole year. Thank God it was smooth, technology worked okay, not always, but okay. And just before coming here, I have finished the curriculum. Now, I just want to summarize my words with this. Technology will never replace great teachers. I've just added great, not not for myself, but it will not replace any teacher. Simply because whatever we did was human. The technology only took that teaching to the students. We replicated all traditional teaching as much as possible online. And we feel our program is still academically sound. Now, because of COVID, the students have been posted to COVID duties. So now I take classes even off duty hours, evenings, because now I'm teaching from home. So I can teach from anywhere. In fact, sitting here in India, I can teach those students continue, although we have finished the program for this year. Okay, so I want to just stress this picture. Although the technology, it is still the hands which are holding. Technology will fall down if it is not properly used or without sound academic humans behind. So, summary of what went on well. Now, these are the questions are probably the summary points I'm discussing, but please feel free to stop me and ask me or put in the chat box. I will be watching. If you put any questions, we will discuss that. So for us, what went on well? We had the problems of existing traditional system. Means this is before COVID, okay, 2016. We started making it partially online because we did not have traditional specialists available in time throughout the year. So although we used to get great teachers, but it was all occasional, sometimes. So we had team discussions on past, present, and future, and this brought us together. So we had regular meetings with the Pacific Islands, the Fiji, FNU, and RCPA. So we had a good understanding. And academically important aspects of traditional mode were listed and made sure to be equal in online mode. We did study of several technologies. Finally, we selected Zoom because of sharing of the mouse. See that small thing, sharing of the mouse made it any resident to present his slide, to present his journal club, to present his points. So he could present and every else we will be watching. Then give the control to the next resident. So a great sharing of the resources and involvement of residents. Step-by-step implementation of technology, meaning we started the program traditionally, totally traditional. Going there to Fiji, teaching in block mode. But then we made it partly online. And since 2020, we did not have any other choice. And our program was the only one prepared ahead for the pandemic. Complete online mode, including examinations in 2020. The only thing I miss is the visit to Fiji, the fantastic hospitality of Pacific Islands, the fun part of socializing with the people. But I'm happy that the program is strong. Now we had successful partnership with the Fiji National University, RCPA, myself, that is JCU and USA. And we are still expanding. Every time when I meet someone, I invite them to Pacific Pathology Forum, put them on the WhatsApp group. And people have excellent response for our Pacific Pathology program. So it is academically sound PG pathology program with a global support. Now we are training 3 to 6 every year. And I'm happy to say that currently our graduates of pathology are in the key positions. In forensic pathology, the Fiji national head is our trainee. He has developed standards for forensic pathology. He has made partnership with consultants from US, Australia, and developing our own guidelines for forensic pathology. Another graduate who is the Dean of the Medical School in Samoa. So we have very positive response. And at present, now we have sufficient staff in both teaching and in the hospital in the major cities of Fiji. Still we need, so every year we are training 3 to 6 registrars. Now, the majority of the pathologists in the country are now locally trained. Previously, Fiji was depending on overseas trained pathologists like me. Okay, some of the challenges. Probably you all know what we faced was first need for management support. If you remember now, when we established the program approved by the academic board of the university, it took 4 years to implement, to get the government support. We need good IT support. We need good internet speed. The team needs motivation. Luckily, our team were all motivated. But if not motivated, it is impossible. We need team motivation, but also training. Everything is new. Our registrars had to learn new technology, and they had to accept this. Now, having said, if you see a trained, not means a registrar compared to a senior pathologist, the digital images will not be accepted by the senior experienced pathologist. Says, no, that's for me, the traditional microscope. Whereas luckily the new registrars, they are open to technology. May not be suitable for clinically intensive programs. So I'm not suggesting that this is the method for all the clinical programs. So this is only our experience in pathology. Technology, network connectivity, and speed were issues. Initially, we had not good video, then not good internet connectivity. Many times we had to postpone our sessions simply because at that time internet speed was not good. But later, interesting to note, the registrars started using their mobile phones as an additional connectivity for Wi-Fi. So whichever worked better, so they used that. And also, many of the times, our registrars have joined the sessions while driving, parking the car on the side, while going to work, and they join for the class. Now, this is interesting, time difference. Now, previously, we had little bit of issues, means the first 2 hours and the last 2 hours were not suitable because Fiji is 2 hours ahead of Australian time. That is my time in Queensland. And Samoa is 3 hours ahead. So it was not suitable. But then it became an advantage because in Fiji, all the registrars were working full-time in the hospital because of the COVID work. And we used to take sessions in the night. So after 6 o'clock, when they finished from the hospital, although it was about 4 o'clock for me in the evening, my day work would continue. And for Samoa, I started taking early morning 6 o'clock. It just helped my health because I could get up early. Okay, so limited staff time and resources, because at present, all are currently voluntary staff, overseas staffs. Let me know if I'm crossing the time. 2 more minutes only, we will finish. Okay, so it is a limited experience of Pacific pathology, but I'm happy to say it is a successful plan for us. It worked. Success depends on commitment of leadership. That was the most important, crucial. The leadership in the university or wherever we want to bring the change. Pandemic has changed the world, including education. We all know that now. Very interesting point is my students, we used to do only online for last 2 years. Now this year we made it on face-to-face in the class. Now students want virtual, they want online. They are saying it's difficult for us to come to class every time. We are working in the hospital. So now we have made it optional. So students can choose to come to the class or join the class online. So all my lectures in the class are now streamed online as well. So it has changed, pandemic. Now, the last summary, what is the future? I want to stress on this point, that is, more pandemics are inevitable, particularly the RNA virus. The current coronavirus is fast changing because that's the nature of the RNA viruses. It's very difficult to develop the vaccine. We all know, but media doesn't seem to understand this. That is, every year, every country produces a new vaccine for flu. We all know this, but we are scared of corona. Of course, it should be logical to be scared of, but we need a plan. And good thing is, WHO has come up with disease X plan. That is, to be ready, how to be ready for any pandemic in future, how fast we can sequence, identify, diagnose, develop treatment, vaccines. So many pandemics are inevitable, and most likely our education will become online, if not fully, definitely partially, most of us. Now, what is the advantage of this? I can teach now 3 countries sitting in my home. Isn't that an advantage? Technology is not a luxury anymore. It is the future. We all need to understand this. Universities will be vanished if universities do not adopt online, digital technology. Establishment of dedicated department, staff, and resources is very important. Every institute should have a dedicated staff to think about and develop future-proof programs. Global sharing of experiences and innovations, like how I learned by going through experiences of others, and how am I sharing with you people. So it is, even if you think it is silly what we did, but if it has worked or not worked, please share your experience. And that's how we create new knowledge. We have to develop local and global guidelines. At present, online education is still a fancy. Okay. Now, we all know about e-learning, massive open online courses, and what I have introduced in JCU is a small private online course, and important is micro-credentials. Probably most of you know, but those who are interested in education will know. But otherwise, please Google Uber University. To me, I feel personally, that is the future of higher education. Uber U. It's still a concept. It's not a real thing. But to me, I feel it is something like electric cars. The petrol cars have to vanish. Uber University. So there's a nice article, research, a lot of work on this, which is similar to micro-credentials. So our Pacific pathology experience is one experience of going fully online in a postgraduate pathology program. So most of the time I end my talk with this slide. How the dinosaurs vanished, a pandemic. Currently we are facing different kind of, it's not the strongest or the smallest. The only way we can survive is to be adaptable to change. How we survive is by change. Charles Darwin. Thank you and welcome any questions. I will.
Thank you, Venkatesh Murthy, sir. Prabhakar sir has a question. Prabhakar sir, you have a question?
Yes.
It was an excellent talk, sir. I
Thank
learned
you.
a lot from your talk, especially that micro credentials. I would like to know something about it, sir.
Yeah. Okay. Because you have asked, so I'll just talk a brief. Probably you will get more on Google. This is an example. Example of Uber University. What is micro credentials? This was a story. A student in, say, for example, business management or accounting, and had difficulty in statistics. He was struggling. He opens his mobile. He goes to Uber University app and he asks for, I have this problem. I want to learn this topic. Some corner of the world, one professor says, I have the best option for you. And he will say, this is my cost. And the student accepts. And they go through the teaching online. And he successfully completes whatever the assessments by that professor. And the professor sends his credentials directly to the university, and the university has an option to accept or not accept. Now, what is micro-credentialing? Is chunking up or breaking up our curriculum. Say, for example, my pathology. Yeah? Now we have microbiology, anatomic pathology, biochemistry. Now we have one professor for microbiology and one professor for biochemistry in different countries. Now they will go through that portion of the curriculum and they will conduct assessments on their own, of course, according to the university guidelines, and they give the credit to the student. The student gets the credit from his university, micro-credentialing. So you go on accumulating credentials, points. So probably in medical career, it may not be so easy, but in a management, I did online training in online teaching from University of London. It was in 2002 when I was in Fiji. I did online education. When I came to Australia, our JCU offered me the MBA in higher education. So it was a leadership in education in MBA. And I had 3 of the units similar to what I had done online in London, means sitting in Fiji. And to my luck, the university accepted those credentials from University of London directly. And I got exemption from 3 units. So what I'm talking is universities have to think of micro-credentialing. Chunk-wise or break up the curriculum and offer the freedom to get the credentials separately. Micro-credentialing. Thank you.
Thank you, sir.
Thank you, sir. It was excellent, sir.
Thank you.
So small, this one, how do you teach practical skills in pathology to students when it's online?
Very good. You picked up my weakness very much. Yes. Now, because I'm not there, I cannot teach them the gross specimens. So what we have done is we have the Royal College of Pathologists Australia's video series. So we distribute the video series to the students, and the local pathologist who is now in Fiji will teach only those, means because the students are in the hospital, so they are working in the pathology department. So the grossing, the actual practical work is supervised by the local pathologist, Dr. Abba at present. Okay. And only the theory part, the teaching, slide seminars, the journal clubs, I take.
Okay. So the other thing is diploma is for how many years? Masters is for how many years? Sir?
Yeah, diploma is for 2 years and masters is for 2 years. In that, 1 year is on course teaching and 1 year on course plus thesis.
Okay.
So totally 4 years.
4 years. So they are accredited only to work in that particular country and not outside.
Only in Pacific Islands.
Okay.
And we specifically mentioned this because this is in partnership with RCPA, And RCPA has agreed that they won't consider this as their equivalent.
Okay,
It is
because you
only-
want to build your team.
Yes.
You want to build the number of pathologists in that particular area.
Yes.
Thank you, sir. Thank you so much for your talk.
Thank you.
Now, because there are no more questions, I think we'll be ending the session. Thank you for the good interaction. Thank you, sir, once again.
Thank you. Thank you very much. Bye.
Thanks.
Thank you, sir. For the next session, we have with us Dr. Elendra Singamani, Associate Professor Pathology.
Sir, is there any problem?
Sir, 5 minutes, sir. 5 minutes.
Okay, sure, sure.
Sir, Prabhakar, sir.
Yeah, yeah.
Yeah, you can
So,
continue, sir.
continue. It's my pleasure to be part of this pediatric cancer update conducted by the Department of Pathology. I think it's my privilege for having been with so many learned, wise people. Today we have Dr. Elenthal Singamani, who is Associate Professor of Department of Pathology at CMC Vellore, and who has got several publications in reputed journals and is a recipient of the Best Paper Award in international conferences. So he'll be going to speak on the pediatric lymphoma. It is a very fascinating subject as far as I am concerned, because there are few malignancies where the modern science could help us to cure almost, I can say, especially in the lymphoma. When it comes to Hodgkin's lymphoma, as all of us know, the 90 to 95% of the Hodgkin's can be cured, especially when they land up in stage 1, stage 2. In stage 3, stage 4, it can almost 70 to 80% of the pediatric cancers, pediatric lymphomas are curable, thanks to the modern science and the chemoradiotherapy, advanced chemoradiotherapy. And I always remember lymphoma, especially HL. My senior professor used to say, whenever the question is on Hodgkin's lymphoma is asked, at least remember one word, that is called Reed-Sternberg cell, RSL. They say that he used to tell us that Hodgkin's lymphoma is synonymous with Reed-Sternberg cell. So at least you mentioned that keyword and you'll get pass marks. That was the teaching which I used to have during my UG days. I know a lot of developments have taken place over the course of time. And to speak about these pediatric lymphomas, we have with us Dr. Elenthal Singamani. It's over to Singamani. Please, stage open to you, sir.
Thank you, sir, and very good afternoon to everyone. And thank you for your kind words and very interesting introduction. And I'm very glad and honored to part of this wonderful CME is being conducted. Especially the previous session was quite interesting, and I'll try to make it up, not up to that level, but I'll try my best. Yeah. Is my screen visible?
Yes, sir. It's visible, sir. Please go ahead, sir.
Yeah. So I'll be talking about approach to pediatric lymphomas. So this is the outline that what I'm going to share. And initially we'll just have a quick look at the normal histology, then a few words about the WHO classification and the difference between Hodgkin lymphoma and non-Hodgkin lymphoma, and also some of the prerequisite in making a diagnosis and some biopsy techniques, clinical details, and finally the diagnostic approach to these pediatric lymphomas based on case studies, and finally few words about the lymphoma mimicus. So I'll just take you through a normal histology of the lymph node. Okay, this diagram, actually, if you see here, it shows this is the cortical cortex, and you can see the primary follicles without the germinal center and secondary follicles with germinal center. And the blue color is the paracortical region, and here we have the medulla. If we go much detail into the histology, we can see the follicles distributed mainly in the cortical region, and you can see the pale area is the germinal center, and you can see the entire follicle here. And we have the medulla here, the medullary sinus here coming, and this is the sinus with filled with histiocytes. Okay, this is the normal reactive finding where we call it as a sinus histiocytosis. And this is the CD20 marker for B cells, and which highlights all the B cells in the follicles and some of them in the medullary region, the memory B cells and all. And this is a CD3, this is a T cell marker, which highlights all the T cells in the paracortical region. And we also can see some T cells inside the germinal center. They are the T helper cells. This is a close view of the germinal center where we can see the light zone and the dark zone. Dark zone is composed of centroblast and light zone is centrocytes. And this is called polarization, which is the finding of a reactive lymph node. And MIP can highlight this dark zone and light zone. And MIP1 shows a high MIP in the dark zone, where the highly proliferating centroblasts are there. So here, this is the germinal center, and you can see the marginal zone cells here. And in the close view of the germinal center, we can see the major two population of cells, and the centrocytes and centroblasts. The cleaved small cells are the centrocytes, and the non-cleaved larger cells with the membrane-bound small nucleoli, they are the centroblast. This is the large centroblast here, and some of the mitotic figure we can make it here. This is the high endothelial venule where we can see the plump endothelial cells lining those high endothelial venules. So there are a lot of causes for lymphadenopathy in children. These are the examples like it could be infective etiology, it could be autoimmune diseases, it could be due to storage diseases, it could be due to drug reaction, and the malignancy part is the one which we are going to deal with, the lymphomas. Okay, so basically, what are the factors that have high predictive value for the non-benign nature of lymphadenopathy? So basically, the age more than 10 years and duration of lymphadenopathy longer than 6 weeks, and lymph node size larger than 2.5 centimeter, and supraclavicular site, especially the left side one, and also the matting and limited mobility to palpation, and more than one continuous lymph node area are involved. So these are the findings which gives us the clue that we are dealing with the lymphoma or non-benign disease. So WHO classification, this is the one which we could see that in the picture, the evolution of the lymphoma classification from various group of people, and finally we are stick to the WHO classification since 2000, and the current one is the 2016 WHO classification we are using. So the WHO classification is mainly based on these 4 pillars, basically the cell of origin, histomorphology, clinical details, and molecular and cytogenetic findings. So we can divide based on this, the lymphomas can be broadly divided into like Hodgkin lymphoma and non-Hodgkin lymphoma. Okay, so the both of them are like they differ each other from in the basis of clinical presentation, treatment, prognosis, and proportion of neoplastic cells. So non-Hodgkin lymphoma as such in a whole, not particularly about the pediatric non-Hodgkin. I'm just talking about the non-Hodgkin lymphoma, the entire spectrum. Basically, they are the most common type, and they are very heterogeneous because they have like B cells, T cells, and NK cells, and they can be broadly categorized into low grade and high grade. So Hodgkin lymphoma as such, they are quite rare comparatively and less heterogeneous, and they have uniformly their B cell origin and highly curable. So if you see the differences, main differences between the Hodgkin lymphoma and the non-Hodgkin lymphoma, basically the Hodgkin lymphoma are more often localized, and they will involve generally the single axil group of lymph nodes. But in case of non-Hodgkin lymphoma, they have multiple peripheral lymph nodes involvement. And the orderly spread or the contiguous spread is the characteristic of Hodgkin lymphoma. And also the mesenteric nodes and Waldeur's ring are rarely involved by Hodgkin lymphoma, but that is quite commonly involved by the non-Hodgkin lymphomas. Extranodal involvement is also quite uncommon with Hodgkin lymphomas. Okay, so these are the differences in a pediatric patients between the Hodgkin and non-Hodgkin. You can see the age group, mostly the Hodgkin lymphoma occurs in more than 10 years of age, and non-Hodgkin lymphoma can involve any age. Okay, and the stage of diagnosis usually this is a localized one, and it's a commonly widespread one. And also CNS involvement is quite rare with Hodgkin lymphoma, and also the mediastinal involvement is more common with nodular sclerosis type Hodgkin. And here among the non-Hodgkin, lymphoblastic lymphoma is the commonly involving the mediastinum. Okay, and also the extranodal involvement all like quite common with non-Hodgkin lymphomas. So if you see here any lymph node biopsy, first of all, we need to see whether it's adequate or not. If it is adequate, we have to see whether it's a reactive or neoplastic. Then if it is a neoplastic, whether it's a lymphoid neoplasm or a non-lymphoid neoplasm. If it is a lymphoid, we can say whether it's a non-Hodgkin or Hodgkin. And if under the non-Hodgkin, we have immature and mature type. And Hodgkin lymphoma, we have nodular lymphocyte predominant Hodgkin lymphoma, classic Hodgkin lymphoma, which is the most common one. And further, we can divide them into subcategories like this. Like for example, all the immature and mature non-Hodgkin lymphoma can be B and T cells, and the classic Hodgkin lymphoma has the 4 main types, subtypes. So this is the picture just to show you the mature B cell neoplasms as subcategories like this. There are so many varieties are there. Like we can divide them into large B cell lymphomas, small B cell lymphomas, plasma cell neoplasm, and others like Burkitt and all. And under the small B cell neoplasms, we have lymphomas. We have all these entities, and the colored ones are the one which are the new entities, or some entities undergone some modification in the recent WHO classification. So we need to be aware of these entities. These are T cell lymphomas where it shows either it is primary cutaneous or non-primary cutaneous. So this data taken from the AFIP fascicle, it shows that among all the non-Hodgkin lymphomas, you can see the DLBCLs are the most common, followed by follicular lymphoma. And among the T cell lymphomas, PTCL, peripheral T cell lymphomas are the most common, followed by angioimmunoblastic T cell lymphoma. And among the classic Hodgkin lymphoma, nodular sclerosis type is the most common worldwide, and mixed cellularity next to that. But in case of countries like India and the other developing countries, mixed cellularity is the most common one. So this data from CMC published data, it shows that the classic Hodgkin lymphoma, mixed cellularity is the most common type among all the 4 subtypes. And among all the B non-Hodgkin lymphomas, the DLBCLs are the most common, and followed by follicular and CLL or SLL. So among the T cell lymphoma, PTCL is the most common, followed by ALCL. Unlike the worldwide data, which shows the AATL, angioimmunoblastic, is next to PTCL. And this picture shows, even though it's old data, but it shows that how the pediatric and the adult lymphomas, how they differ. Like the incidence of DLBCLs are the most common here, but here you can see the lymphoblastic overtakes the other large B cell lymphomas. And here also you can see the trend here, and the blue color is the DLBCL, and here we have this Burkitt lymphoma, maroon color, and the red color is the lymphoblastic. So the lymphoblastic and Burkitt are more common under the age group of 20 years. But in case of DLBCL, you can see slowly it is showing the increasing trend when the age increases. So this is just a 1 year data from our setup here, CMC Vellore, where you can see the trend. Here we have like classic Hodgkin lymphoma is the most common type, followed by lymphoblastic and DLBCL and Burkitt lymphoma. And here it shows the 10-year data from our CMC Vellore. It shows that almost like 50% of the cases are Hodgkin lymphoma, classic Hodgkin lymphoma, and followed by DLBCL, and then we have the T lymphoblastic lymphoma, which slightly differs from the worldwide data, and also like adult type also, which makes a big difference here. And also if you see the age group also, like most of the people fall into the category of like above 15 years of age group into 18 years. Majority of the pediatric population fall into that group. And male-female ratio, male almost coming around 71%. So the overall distribution of childhood cancer, you can see the non-Hodgkin lymphoma and along with acute lymphocyte leukemia and all, it composes like almost like that most common subgroup of pediatric cancers. And incidence lymphoma increases significantly from 0 to 20. For example, 3% tumors falls under the category of 0 to 5 years. In case of 15 to 19 years, it is coming up to 24%. So the two major subcategories we saw, Hodgkin and non-Hodgkin, and NHL is more common in younger children. Hodgkin is more common in the adolescent age group. So we can see that they both of them, like Hodgkin and non-Hodgkin, they have their unique presentation, and the prognosis of pediatric lymphoma is excellent with prompt treatment. And the cervical lymphodenopathy is a common presentation in most of the childhood lymphomas. So Hodgkin lymphoma commonly appears with the lymph node conglomerate at presentation and frequently located in the cervical and supraclavicular region. So it is usually painless and unless the mass compresses the any other adjacent anatomic structures. So pediatric non-Hodgkin lymphoma, these are the major categories that we frequently encounter. Like for example, mature, you can divide them into four major categories, like mature B-cell lymphomas, which comprises of Burkitt lymphoma, diffuse large B-cell lymphoma, and coming to the lymphoblastic lymphoma next to that, and which most commonly it is T-cell phenotype, and anaplastic large cell lymphoma, and finally the post-transfusion lymphoproliferative diseases, which is mostly of B-cell origin. Okay. Apart from that, there are some other entities also occurs in the pediatric age group. Okay. So
Sir, Inkamani sir.
sorry. Yeah, so we can make sure that there are you are taking a biopsies for snap freezing tissue for the later molecular workup and the culture if you are suspecting infectious etiology as well, and also other tests like flow cytometry or cytogenetics can be planned even while you are doing the biopsy itself. And finally, whatever you do, like sufficient tissue has to be given for paraffin block for a proper histological examination. And so we have like the paraffin block should be like thinly sliced, and 4 micron is the ideal one, and it should be adequately fixed for a good cytological details and good preservation of antigens for further immunohistochemistry evaluation, and also good preservation of mRNA and DNA. For everything, the adequate fixation is very important. We use generally the 10% buffered formalin for fixation, and we also, like whenever we receive the biopsy, the excision biopsy, we generally bisect and fix it overnight, and next day only we will process it. So it should be good quality H&E section, 4 micron thickness, and also we may encounter some problem due to traction, compression, drying artifact, over or under fixation. So all those things we need to avoid. And many mistakes are committed because of suboptimal quality of histological sections. So we have to be careful when processing. So these are the common biopsy techniques we use: fine needle aspiration and throughput core needle biopsy and excision biopsy. So among all of them, like we prefer the excision biopsy as much as possible. FNAC is not recommended or encouraged for primary diagnosis of lymphoma. Maybe FNAC can be used in case of like you are suspecting either carcinoma or lymphoma or what, like just a preliminary clue it can give, or it can be used in case of like staging purpose, or it can be like in a relapsed conditions. Maybe we can use FNAC. Through needle core biopsy is also like as much as possible go for excision, and if it is in a unaccessible area and it's intra-abdominal and interior parts, maybe trucal needle core biopsy is very much valid in those occasions, so we can use that. So why we need excision biopsy? Because it provides ample tissue for all necessary testing, and also it allows the evaluation of architectural patterns and accurate grading. It reduces the sampling error that can be seen in paucicellular neoplasms or partial involvement. So it eliminates the need for additional biopsies and possible delay in the treatment, because generally for lymphoma, we tend to do a lot of immunohistochemistry markers. If the tissue is very small and is very poor biopsy or something, then we'll exhaust the tissue and it won't be available for further examination. So better to have a excision biopsy in most of the cases as much as possible. So the clinical details like age, gender, and location of the tumor, symptomatology, medication, serology, prior history of malignancy, any immunosuppression is there. So patient occupation, everything is like very important. It's all the details should go hand in hand when we are examining a lymph node biopsy. And also, like for example, how the age group and the location, how it helps. Like for example, DLBCL commonly occurs in an older age group. And also the location wise, if you see, most of the extranodal sites and often a large and multifocal involvement that suggests that probably it is a DLBCL. Burkitt lymphoma commonly occurs in children, and extranodal, especially abdominal. So all those things gives us the clue that we are dealing with some particular lymphoma. Okay, so that's why all the details about all the clinical details, the demographic details are very, very important. And here also it shows that how these different pediatric lymphomas, they have that predilection for different sites and how they involve. And the other recommended investigations for lymphoma are like these are the set of investigations we supposed to do, and the imaging studies we have to do, and for the staging purpose, bone marrow biopsy, all those things we need to do. Okay, so this is the clinical staging system for Hodgkin. We use INR staging system. For non-Hodgkin, that Murphy's staging system generally. So coming to the diagnostic approach to lymphomas, so I will be discussing about some of the cases, and based on that, we'll just have a small discussion after that. So, like these are the questions we need to ask whenever we receive a lymph node biopsy. We need to see what organ is this, and is this consistent with what is indicated on the requisition? Is this sufficient and adequate material for diagnosis? And is there any normal architecture? And is this alteration due to reactive or any neoplastic process? Is it a lymphoma or non-hematologic neoplasms? All the questions we need to keep it in our mind. And coming to the morphological approach, we can approach the lymph node based on these two broad categories, like low power examination and high power examination. So under the low power examination, mainly we can see the architectural pattern, like the effacement of the normal architecture and what is the pattern of infiltration, whether it's a nodular or intrafollicular or diffuse or intrasinusoidal. And although these are typical cytological patterns described for each entity, they are not always present. That also we need to keep it in our mind. So high power examination. Under the high power examination, we have to see the cell population, whether it's a monomorphic or it's a polymorphic, and what is the size of the cells, medium sized or large sized or small sized lymphocyte, what is the shape of the nucleus, whether it's the nuclear irregularities there or cleaved nuclei, and also the chromatin configuration, whether it's a fine chromatin or coarse chromatin or clumped chromatin or vesicular chromatin, how the nucleoli looks like, is it incomplex nucleoli or it's a prominent nucleoli or a membrane-bound nucleoli. So all things we can see, and the amount and hue of the cytoplasm, whether it's a basophilic cytoplasm or a eosinophilic cytoplasm, a scant cytoplasm, abundant cytoplasm, all those things we need to see while we are thinking about any lymphoma. And this is picture shows that these are the histiocytic nuclei and the endothelial cell nuclei. They are very useful in terms of like calling the lymphocyte as a small lymphocytes or medium size or large size. These are the scales used actually. These are the internal scales, like the lymphocyte which are equal to these cells or medium sized cells, which are smaller than that are the smaller cells, and which are larger than that are the larger cells. Okay, large lymphocytes. So this is how we call them as a small lymphocytes or medium size or large cells. Okay, so how the mature lymphoid cells look like? Mature lymphoid cells generally they will have a clumped chromatin and vesicular chromatin or hyperchromatic chromatin, and low grade but the immature lymphoid cells generally they will have a fine and homogeneous fine chromatin with or without any contiguous nucleoli. And the low-grade lymphomas, coming to the low-grade lymphoma, generally they have a small cell morphology and they will have a mature chromatin, and they will have absence of significant mitosis or apoptotic cell, and the proliferation index will be low. And high-grade lymphomas, generally, they have a large cell morphology, and they can be immature chromatin, or they can be like vesicular chromatin, and they will always have a brisk mitotic and apoptotic activity, and proliferation index will be high. So basically, the immature lymphomas tend to be clinically high-grade, but not all clinically high-grade lymphomas are immature. So majority of the low-grade lymphomas are usually they are mature. So almost all in a non-Hodgkin lymphoma that occurs in children is a high-grade lymphoma. Okay, so what are the features favoring a diagnosis of lymphoma over lymphoid hyperplasia? So they are like the abnormal architecture and invasive or destructive feature and cytological atypia. These are the areas that we need to see whether the lymph node is having abnormal architecture, is there any invasive or destructive feature, and what is the atypia present, the cytology of the nucleus and the cell morphology we have to see, is there any significant atypia. Okay, let me take you through some of the case studies, some of the cases. This is a 12-year boy with a suspected lymphoma. Ultrasound abdomen shows hepatomegaly, bilateral bulky kidney, and the CT also shows intra-abdominal mass involving the bowel mass. Okay, so here you can see the lymph node architecture is completely effaced by a diffuse infiltration of atypical lymphoid cells, and these are the dark appearing cells are the residual mature lymphoid, reactive lymphoid cells. Here you can see a lot of tingible body macrophages also, and which is also, we can call it as a starry sky appearance. So you need to remember that starry sky appearance is not exclusively for Burkitt lymphoma. It can be seen in any other high-grade lymphomas as well. For example, DLBCL also we can get, and the lymphoblastic lymphoma also we can get this kind of starry sky appearance. The starry sky appearance mainly the indicative of high proliferation and high apoptotic activity that is happening. Okay. So high-grade lymphomas can have this kind of appearance, and the nucleus, if you see the high power, the most of the atypical lymphoid cells, the nucleus are vesicular nucleus, and we can even the high power, we can see the prominent nucleoli, and there are cells like these are the tingible body macrophages, and we can see some of the apoptotic cells as well. And the atypical lymphoid cells are the medium to large size cells with vesicular chromatin and prominent nucleoli. And if you do the immunohistochemistry markers, you can see CD3 is negative, and here you can see 20 is diffusely positive. CD10 is the germinal center marker, which is diffusely positive. MIG1 is high, around 90%. And you can see BCL6, another germinal center marker, that is also positive here. And CMYC is highly expressed, and the cutoff for CMYC is 40%. It is more than 40%. And the BCL2 is also nicely positive, and cutoff for BCL2 is the 50%. And MUM1 here, MUM1 is also positive. Okay. So basically, we have a diffuse infiltration by the medium to large size cells with a vesicular chromatin and prominent nucleoli with a high-grade morphology. Basically, it is a high-grade lymphoma. Is it a B cell or T cell? Yes, it is a 20 positive, so it's a B cell high-grade B non-Hodgkin lymphoma. So further, we need to subcategorize them. What category? Which category it belongs to? And because it is positive for 20 and a diffuse infiltration in the morphology, we can call it as a diffuse large B cell lymphoma. And further, cell of origin, we have to see whether it's a germinal center B cell type or non-germinal center B cell type. I will explain later the Hans algorithm. And here it is this germinal center markers are nicely positive, CD10 is positive, so it's the germinal center type. And BCL2 as well as CMYC both are highly expressed, so we can call them as a double expressor phenotype. Maybe that also I will explain bit later. Okay, so the more common, basically the large B cell lymphoma are more common in adults than in children, and variety of mutation can lead to this morphologic subtype of B cell lymphoma. 5 to 10% have a translocation 814. Other translocation involved are the BCL6 gene due to translocation 14 and 18. Okay, so these are the terminologies we need to be familiar with: double hit lymphoma, triple hit lymphoma, double expressor lymphoma. Double hit lymphoma, basically they are high-grade lymphoma with the rearrangements of MYC and BCL2 or MYC and BCL6. Okay, it must be diagnosed with FISH or other more advanced genomic techniques. Okay, what are triple hit? Triple hit is like apart from BCL2, and you have like along with the MYC, BCL2 and BCL6, all three together. So that is a triple hit lymphoma. This also should be diagnosed only by FISH or more advanced genomic technique. Okay, double expressor lymphoma, basically this is just a protein expression of MYC and BCL2. and it should be measured only by immunohistochemistry. Okay. So basically double hit lymphoma by genetic analysis, okay, genetic diagnosis, okay, and double expressor lymphoma is a immunohistochemical diagnosis, okay, that we have to remember. Both are different entities because if you see here, and most of the double expressor lymphomas, almost 1/3 of DLBCLs are double expressor lymphoma, most of them falling into the category of ABC type. Okay, and here if you see double hit lymphoma, majority of the double hit lymphomas falling into the category of GCB type. And also another point we have to notice here is majority of the double hit fall into the category of double expressor lymphoma, but not all the double expressor will fall into the category of double hit lymphoma. Okay, this is a quite complicated thing I'm talking, but if you see the picture in a relaxed manner, you will understand it. Okay, this is the Hans algorithm for making a cell of origin. So what type of cell of origin, like it's a germinal center origin or non-germinal center or activated B cell, we use this algorithm. For that, we need to start with CD10. If CD10 is positive, that's the end of the story. You just label it as a germinal center B cell type. That's all. We don't need to do any BCL6 or MOM1. If it is negative, then you do BCL6, another germinal center marker. If it is again negative, then you can call it as a non-germinal center B cell type without even doing MOM1. But in case if that comes positive, then you go and do MOM1. Okay, if the MOM1 is positive, then it is a non-germinal center B cell type. If MOM1 is negative and BCL6 is positive, then you call it as a germinal center B cell type. Okay, and for all of them, CD10, BCL6, MOM1, 30% is the cutoff. Okay, it should be to qualify to call it as a positive, it should be more than 30% of cells should be positive. Okay, coming to the case 2, is a 11-year boy again, and suspected gastric lymphoma. Patient is having abdominal pain and vomiting, and also has having a large mass in the epigastric umbilical region, and you can see the bowel wall thickening and the multiple bowel loops and everything is there. Okay, here also diffuse effacement of the architecture, again the starry sky pattern. And comparing to the previous lymphoma, that was more of a eosinophilic, but here more of a basophilic appearance. And you can see here multiple distinguishable body macrophages and lot of apoprotic and mitotic activities happening. And the cells are like medium sized and very uniform, unlike the previous one that was quite pleomorphic. Here also they are uniform but medium size, and if you see the chromatin, mostly the chromatin is a clumped chromatin. Okay, they are all clumped chromatin, and you can see a lot of protein here. And you do the CD3, T cell marker is negative, and B cell marker CD20, which is diffusely positive, membrane positive, and maybe is almost taking up all the cells. Okay, so it's almost like 100%. Okay, that's a very characteristic. And you have BCL6 germinal center marker, another germinal center marker that is also positive. And this CD10 germinal center marker is nicely positive. And CMYC, which is highly expressed and almost around 70 to 80%. And BCL2 is very classically, it is negative. Yeah, all the 6 are negative. So it's basically it is a diffuse medium-sized cells and which is having a clumped chromatin and multiple nucleoli, as having a starry sky appearance, and 20 positive B cell lymphoma basically, because it is 10 positive germinal center and BCL6 is also positive and CMYC is also highly expressed and BCL2 is very much negative. So it is 100%. So this is a classical Burkitt lymphoma. Okay. So Burkitt lymphoma has to be differentiated from diffuse large B-cell lymphoma because both are aggressive lymphomas and both can occur in a childhood age group. And we can see that the Burkitt lymphoma, mostly the cells are intermediate sized. DLBCLs can be large to intermediate, and Burkitt, they are very uniform. Here it is varying size and shape. And here the clumped chromatin, here the vesicular chromatin. And we can see here the basophilic cytoplasm, here it is more of a eosinophilic cytoplasm. Okay, these are the differences. And another lymphoma which has to be differentiated from Burkitt lymphoma is lymphoblastic lymphoma, especially the B lymphoblastic lymphoma. Both are B phenotype and both can occur in children and both are labeled as small round cell tumors. So we have to be very careful in differentiating both of them. So the main differences are, and this lymphoblastic lymphoma, the nucleus can have an irregular nuclear membrane, but here in Burkitt lymphoma, they are quite round and they can have a squaring of cytoplasm, and also here the nucleoli is inconspicuous, and here you can have a multiple small nucleoli, and here we have the fine chromatin lymphoblastic lymphoma. In case of Burkitt lymphoma, we have a clumped chromatin. Okay, so these are the main differences. So Burkitt lymphoma as such, they are basically mature B-cell lymphomas, and the tumors typically can divide them into the endemic form and the sporadic form and the associated with immunodeficiency. Okay, the endemic forms are the one which are like African Burkitt lymphoma. They typically arises in the jaw lymphatic tissue that is present in the area of erupting teeth. Okay, they are highly associated with EB. Almost 95% of the cases we have EB association. And coming to the sporadic form, which are typically arise in the abdomen recently. In our country, we see this kind of forms, sporadic forms, and the immunodeficiency associated Burkitt lymphoma we commonly see. And here the EB association is quite less comparing to the endemic forms, and intersubstitution can be usually a symptom of bowel loop involvement and adhesions and all. So whenever the child presents with intersubstitution, we should always keep this also as a differential in our mind. And immunodeficiency associated Burkitt lymphoma is associated with typically they associated with HIV and other immunosuppressive conditions. Okay. And Burkitt-like lymphoma. So basically, they are histologically, these tumors are similar to Burkitt lymphoma, but they have a variability in the size and shape of the cells. Okay, but they are not actually they are not very distinct entities, and most of the Burkitt-like lymphoma also contain the classic translocation 814. So these tumors are treated identically to Burkitt lymphoma and have a similar prognosis. Okay, coming to the case 3, 16-year boy with suspected lymphoma and tuberculosis and having a generalized lymphadenopathy. This is the cervical lymph node biopsy. We can see the biopsy is showing a very diffuse effacement by this very monomorphic population of atypical lymphoid cells. Here you can see the very small sized lymphocytes, most of them. And you can see that the mitotic activity and apoptotic activity is evident and looking like a high-grade morphology, but they are very monotonous population. And the chromatin, if you see, most of them are having a nice fine chromatin. Okay, and fine chromatin. So by saying, like we are saying this itself, we must have got the diagnosis. Okay, if you do the markers, CD3 is diffusely positive, CD20 is negative, staining only the residual B cells here, and say Mebon is around 80%, and TDT is like nice, like diffuse nuclear positivity is seen. Okay, so this is a blastic morphology with the TDT positivity, and the T cell marker is positive. So we call this as a T cell lymphoblastic lymphoma. And lymphoblastic lymphoma as such, the patient typically they present with a mediastinal mass, which often is more rapidly growing than Hodgkin disease. Okay, the patients may present with pleural effusion, pericardial effusion, superior vena cava syndrome. All complications can happen. Okay, and also the patient's mediastinal mass should they ultimately they should undergo bone marrow aspirate. We need to see whether the marrow is involved or not. If marrow is involved, having more than 50% this blast, then we can call it as a T cell acute lymphoblastic leukemia. Okay, and also the lymphoblastic lymphoma, usually they are T cell phenotype in children, and also the small percentage of T cells also can be seen. Prognosis wise, the long term event-free survival is almost 80 to 90% with a prompt treatment. Coming to the case 4, which is a 5-year girl with a suspected lymphoma, mediastinal widening is there, and having enlarged bilateral level 2, level 5 cervical lymphadenopathy is present. Okay, and the core biopsy was performed. You can see the core entirely composed of atypical lymphoid cells. No normal structures are seen, and even the high power, you can see the lot of large cells are mixed with some small inflammatory cells around. And these large cells are having the vesicular chromatin and very prominent nucleoli and all is present here. And you can see here some of them are looking like embryo-like cells, and the mitotic activity is seen. and this kind of wreath-like cells are hallmark cells. Okay, this is very characteristic of anaplastic large cell lymphoma, and here also you can see a lot of inflammatory cells in the background and large cells you can see atypical large cells. And markers wise, if you see CD3 is negative and CD20 is also negative, CD15 is negative, but CD30 is nicely positive, very diffuse and strong positivity with CD30. Whenever you look at a lymphoma, but suspected lymphoma, but with basic T cell marker and B cell marker, both are negative, we need to think about all these lymphomas, like anaplastic large cell lymphoma should be in our mind, and myeloid sarcoma is another condition which we should keep it in our mind, and other lymphomas which are like B cell lymphoma, but 20 negative lymphoma, like plasmablastic lymphoma, ALK positive, large B cell lymphoma, all those things should be in our mind as a differential. And here, so then we can try out the alternate B cell and T cell markers. Like for alternate T cell marker, we can do CD4, alternate B cell marker, we can do CD79A or PAX5 we can do. Okay, and alternate T cell markers, 4 is very diffusely positive and MIB is very high, 80 to 90%. And you can see ALK1 showing nuclear as well as cytoplasmic diffuse positivity. Okay, ALK1 is highly expressed here, and the clustering shows very focal positivity here. And CD43 is also positive, the large cell, and the EMA is also positive. So vesicular chromatin, prominent nucleoli, hormonal cells are present, and 30 diffuse positive, 4 positive, clustering, EMA, ALK1 is positive. So we call this as a ALK positive anaplastic large cell lymphoma. So anaplastic large cell lymphoma is unlike the other non-Hodgkin lymphomas of childhood, that it can present with a more indolent course, like patients with Hodgkin disease. Okay, these patients frequently have fever and weight loss, and these tumors often arise in lymph nodes. They can also involve skin and bone. The classic finding is lymph node involvement, skin. Okay, especially the skin of the lateral thorax and the GI tract is rarely involved. Okay, 80% of the children with ALCL, they'll have 2-5 translocation. Okay, coming to the case 6, this is a 7-year female, and where we have suspected lymphoma, neck swelling is there, left cervical lymphadenopathy, and the patient is also having splenomegaly with multiple regular nodules. Okay, here we can see effacement of the architecture, and here we can see a lot of scattered large cells are present with a lot of mature looking small lymphocytes and histiocytes are present in the background, and more high power can show you there are some binucleated cells are there here, and the mononuclear RS like cells are present, and background shows histiocytes and small lymphocytes, and a few occasional plasma cells and eosinophils are there. And you can see the prominent nucleoli, the nucleoli size is almost like a RBC size. Okay, here you can see the binucleated cell here, and typically this is scattered large cells in a polymorphic background. Okay, again you can see here triple multilobated RS cell here, and here binucleated RS cell here again, and you can see there is again binucleated and that prominent RS cell, and some plasma cell in the background, histiocytes in the background. See, CD3 is negative typically in the large cells, only the background cells are staining, and CD20 is almost negative, and some of them are showing some weak and variable positivity, and CD15 is nicely positive in the large cells. You can see here the binucleated cell here, and CD30 is also nicely positive in all the large cells, and this is called the Golgi positivity. You can see here the Golgi positivity which is more specific and significant. And also PAX5, which is the B cell marker, which is very lowly expressed. Okay, weak positivity for PAX5 is very significant in classic Hodgkin lymphoma. Basically, even though it's a B cell origin tumor, they are crippled B cells. Okay, the expression of B cell is very much reduced. Okay, so that's the reason B cell markers generally will be negative, and PAX5, which picks up the large cells, which will be very weak staining. Okay, and EPV LMP1 is positive, and HOM1 is also positive in the large cells, and LCA is typically negative in the large cell. You can take out here the surrounding cells are positive, large cells are negative. LCA is negative. That's the characteristic of classic Hodgkin. Polymorphic background, scattered large cells, 30 positive, 15 positive, PAX5 weak positive, EBV positive and LCA negative. Okay, this is a mixed cellularity type. Okay, so these are the differentials we need to consider whenever you have a large cell scattered and scattered large cells and polymorphic background. Okay, it could be reactive also, it could be T cell rich large cell and Hodgkin lymphoma. So all the differentials has to be considered and the large cells should be characterized. Okay, this is a RS cell which is typically we call them as a owl's eye appearance. Okay, there are variants are there. I will show the picture and they are typically 15 positive, 30 positive, LCA negative. Okay, and these are the different variants of RS cells. This is a mononuclear RS cell, this is a binucleated or classic RS cell, and this is a latinar cell, and this is a multilobated or multinucleated RS cell. This is a popcorn cell, which is commonly seen with nodular lymphocyte Hodgkin lymphoma, and this is again a mononuclear cell and a mummified cell here. Okay. And the classic Hodgkin lymphoma can be further subdivided into lymphocyte-rich and mixed cellularity, nodular sclerosis, and the lymphocyte-depleted type. Okay, lymphocyte-rich 10 to 15% of the cases, and fibrosis is not generally seen, and easily it can be missed out thinking of reactive hyperplasia. So you have to be very careful taking multiple deeper sections to demonstrate the RS cells, and mixed cellularity is the common type which is seen in countries like India, developing countries, and numerous RS cells can be seen, and the background will have a polymorphic trait. And lymphocyte depleted is the one which is usually seen with HIV infected patients or any suppressed patient. And the RS cells are seen. Many RS cells are seen because you don't have many other distractors. So you will the RS cells will be very much evident, and also lymphocytes will be very few in the background. And diffuse fibrosis and necrosis can be seen in lymphocyte depleted one. And also this can be easily confused with anaplastic large cell because of the many number of large cells. Nodular sclerosis is the 40% of the younger patients, and orderly collagenous band divide the tumor into nodules. Okay, that is a very classical presentation in the nodular sclerosis type, and the mediastinal involvement is quite common in nodular sclerosis type. Prognosis wise, overall prognosis is 80 to 85 to 90% even survival is there, and high risk features are bulky mediastinal disease and extranodal extension, these symptoms, and advanced stage disease, all the high risk features. Okay, and this is the last case, case number 7, 9 years female with a bilateral tonsillar enlargement, and elsewhere reported as diffuse large B-cell lymphoma. So this case was diagnosed by Dr. Mari, our senior consultant, and this was initially looked like you can see the serpiginously enlarged expansile follicles here, and then you can make out here the fibrous bands are there, and the high power you can see there are large cells, very diffuse large cells, vesicular chromatin, and visible nucleoli, and 3 was negative, and big one was high, and BCL2 was positive, and CD20 was nicely positive. So basically it's a high-grade lymphoma, high-grade B-cell lymphoma, where MUM1 is also nicely expressed here, highly expressed, and BCL6 also positive. Okay, so basically it's a medium-sized to large lymphoid cells with vesicular chromatin and inconspicuous to visible nucleoli. 20 positive, 10 positive, MUM1 is highly expressed, and BCL6 positive, maybe is 90%. So this was given as a large B-cell lymphoma, possibility of IRF4 rearranged large B-cell lymphoma. Okay, this is the entity we need to be aware, and not very commonly seen. It's a very rare entity only, and need to be aware. Basically, they are very rare subtype of diffuse large B-cell lymphoma, primarily affects children and adults. Common sites are the head and neck region, always seen, and GIT very rarely it also involves. Okay, basically it's a very head and neck tumor, basically, and it arises from a germinal center B-cell type, and with the IRF gene chromosome resulting in a IRF4 MUM1 expression. Okay, so a very peculiar type of lymphoma, and the clinical presentation basically isolated tonsillar enlargement. Okay, that gives us the clue that this could be a IRF4 rearranged large B-cell lymphomas. This table summarizes all the morphological and findings of the major lymphoma varieties seen in the pediatric age group, which I already explained. I will skip this one. And the another entity we have to be aware is post-transient lymphoproliferative disease, PTLD. Okay, basically they are also very quite common with the children, those who undergone transplantation, like bone marrow transplantation or solid organ transplantation. So most of them are like B-cell origin, B-cell lymphomas, and so we need to be like if we find that this is lymphoma followed by transplantation, so we can stop the immunosuppression and we have to treat accordingly. Okay, and another few words about the pediatric type follicular lymphoma, which is also another entity which was recently introduced in the previous recent WHO classification. So basically, there are some diagnostic criteria. Basically, they are localized neoplasm of germinal center B cell, entirely follicular pattern, and lymph nodes of children and young adults. Okay, follicular lymphoma as such occurs only in adults. Okay, and if that this is the type which occurs in a pediatric age group, so that's why we call it as a pediatric type follicular lymphoma. Okay, and so there should be a partial effacement of at least partial effacement nodal architecture should be there. It's purely follicular proliferation, and any component of diffuse large B-cell lymphoma is there, then we should not call it as a pediatric type follicular lymphoma. Okay, and that disqualifies that. And BCL6 positivity will be there. Adult follicular lymphoma, BCL2 positivity is very, very classical, but here it is in contrast. Here, either it will be negative or weakly positive. That's a twist here, so we need to be very careful. Okay, no BCL2 amplification seen. Okay, these are the differences between pediatric type follicular lymphoma and usual type follicular lymphoma. Okay, these are the picture shows very expansile large follicles and loss of polarization is there, and we can't see any dark zone, light zone here. CD20 is diffusely positive, and here you see CD10 is diffusely positive in the germinal center type, and BCL2 is typically absent here. Okay, so quickly I'll just mention few words about the atypical proliferation of neoplastic mimicus. Okay, atypical proliferation and neoplastic mimicus, and this is not just a stick or anything. This is a stick insect. Okay, that's how sometimes we encounter. These are the conditions we need to be careful. Like follicular reactive follicular hyperplasia can mimic like a follicular lymphoma, and the PTGC can mimic like NLPHM. Infectious monocytosis can mimic like a classic Hodgkin lymphoma, CL and large B-cell lymphoma, and a plasmablastic variant of multicentric carcinoma can like HHV8 positive plasmablastic lymphoma. Kikuchi's disease can mimic like a peripheral T-cell lymphoma, and we quite often we encounter this Kikuchi's disease. So dermatopathy can mimic like a Sézary syndrome. Okay, this picture shows follicular hyperplasia where the BCL2 is negative typically in the germinal center. This is a reactive. But in case of pediatric follicular lymphoma, this will be the picture. So we have to be very careful and correlate everything together. So here you can see the large cells, a lot of large cells are there. Okay, this is a case of infectious mononucleosis. So we have to be careful. And Kikuchi's can have a marked paracortical expansion and incipient necrosis. All those things can be there, and we have to differentiate it from PTCL. Okay, so here I'm doing my presentation. Thank you so much for your patience, and I thank my team, entire team, pathology team, the senior consultant Dr. Mari for tireless efforts in teaching us and mentoring us, and this is our team. Thank you so much. Any questions?
It was excellent presentation, Singamali. Actually, you took me to my student days about these lymphomas. I know a lot of advances have taken place over the course of time, but the way you explained this, it's a very tough, especially NHL. I agree, very tough topic to cover in such a short time. But you have done excellent job, and I think all our the PG students and also staff members will have definitely got benefited by your talk. Now, section is open for questions.
Sir, there are two questions. First question is, do you know, that is related to history, that is by Raj Warrior, sir. Do you know who was Dr. Reed? And second is, who was Murphy and what specialty?
This is not for the professor, but just for anybody else. He knows. I'm sorry, this is Dr. Warrior. This is not for you, Dr. Lender. This is for anybody in the audience. No, who is he, but this is just for the audience, not for you. Anybody in the audience, medical history? Because
Sir, I have a small question.
Do you know who Murphy?
Sir, I have a small question.
Yes, go ahead. Do you know who Dr. Reed?
Sir,
Anybody knows in the audience? Anybody know who was Dr. Reed? Anybody in the audience? Other than Dr. Allen, not the speaker, okay? Anybody else? She was a lady, okay? I remember Dorothy Reed. She was a pathologist only for 6 months, 1 year. She diagnosed this disease for older people. Most of them were old white men. Didn't like the lady being a diagnosis. They were very hard. She left pathology, became a pediatrician. So I know she was a developmental pediatrician, died about 2-3 years ago. So she was a lady who was a pathologist who left pathology and became a pediatrician. So just show you that she was a lady. Same thing, Dr. Murphy. Do you know Dr. Murphy? Anybody knows what specialty was he? It's also she. She's one of my Sharon Murphy. She's come to India twice with me actually. She was a pediatric oncologist from St. Jude's who did the classification. Just to let you know some medical history. Both of them are female. So please remember, a lot of famous females in medicine, we don't give them enough respect. So respect women in medicine, very important. Okay, that's all. But I had a question for you. Do you routinely do HIV test? Go ahead.
Yes, sir. We generally do like routine as a routine workup. We do HIV tests for all the patients.
Okay.
Sir, I have a small question, sir. What is the role of bone marrow biopsy in NHL, sir?
Yeah, especially for the staging purpose, we have to do bone marrow biopsies. So ultimately, as soon as we call it as a lymphoma, immediately they will go for bone marrow biopsies. Sometimes,
otherwise, for the routine diagnosis, we need not do, no, sir.
Routine diagnosis. Actually, the thing is like when the patient is presenting like in a very atypical manner, sometimes they go on a shortcut. They do a bone marrow biopsy. We may find bone marrow involvement. Then ultimately, we will suggest them to do a lymph node biopsy. So usually, the low-grade lymphomas are the one which will commonly goes to the bone marrows.
And one of the mimics you said about a few diseases you mentioned about the mimics. I would like to know your opinion on this pseudolymphoma, sir. Especially these drugs like a eptoin-induced pseudolymphoma. Or you have any experience about that particular condition? Oh. Drugs like ferritin sodium, resulting in pseudolymphoma-like condition.
Yeah, they all can cause lymphadenopathy. Generally, maybe I think nowadays the clinician themselves are judging very well, like no need to biopsy it, like because the patient is on particular treatment, they may wait and see. So we don't get much biopsies of these kind of entities. So I don't really see any of them. Actually.
Yeah, if I can add, you're right. We rarely see any more pseudolymphoma dilatation at all. I've not seen one in my last 40 years in my life, so very, very, very uncommon. And I just want to add I'll ask one more question. You mentioned PTLD. Do you guys do like EBP genome studies in those also? Or
yes, actually, nowadays we have the EBERISH, like in situ hybridization. So that we are doing. So that is the most accurate one, gold standard. Yeah. So generally.
Excellent talk, wonderful talk. I learned a lot of stuff. Very good talk.
Thank you, sir. Thank you so much. Very encouraging to receive such a compliment from such a senior person. So I'm very humbled.
Excellent, sir. Excellent talk once again, sir. I think if there are no more questions, we'll go to the next section. It's over to the organizers. Thank you once again for giving me this opportunity.
Can I share my slides now?
Dr. Rajwarrier, I'm supposed to introduce you now.
Oh, sure, Pradeep. Okay. Just say I'm a good-looking man, that's all.
Oh, yeah. You are. Organizers, over to you to do any remarks before we start the next session. Host. Swaroop. Kalyani. Hello, somebody there at the host?
Yes, sir. Yes, sir.
Yeah, please.
Yes, sir.
Yeah.
We are
Yeah. Right.
So yourself and Dr. Sampath, both of you are the chairpersons.
Okay, I mean, let me take the privilege of introducing
Yes,
Dr. Raj Shekharan Warrior. Popularly, we used to call him Raj Warrior in Manipal. I'm privileged to have you, sir. He was my vice chancellor when I was a faculty and associate dean in the medical school at KMC Manipal. He also happened to be a teacher for my son. My son was a student in KMC Manipal, and also my daughter, though she was dentistry. Warrior sir used to have a lot of teaching activities across all specialities. The very special character Raj Warrior is asking questions. Even today, my daughter is scared of you for your questions, sir. You're a very wide, well-read person. He used to ask questions not only medical but all fields. Even he used to put me to a corner asking questions in forensic pathology also. Let me briefly introduce you, sir. Professor Raj Warrior is a professor of pediatrics, hematology, and oncology at the Ochsner Children's Hospital, New Orleans. And he has several publications in reputed journals. He received several awards, including awarded Fulbright Scholar by Fulbright Foundation, USA, by the Department of Education and Cultural Welfare in 2005, and the Lokeshwar Memorial Award by Hemato-Oncology Chapter of Indian Academy of Pediatrics at the National Meeting in India in January 1996. More than anything else, Dr. Raj Warrior has been a very, very active teacher, and he believes in posing questions and quizzes in the midst of his sessions in classroom also. He was a very popular teacher and a very popular vice chancellor in our campus. I'm very thankful to you, sir, for accepting our invite and coming at odd time for you in USA, probably Eastern time. It is 5:30 in the morning, so you got up at 5 and you are with us.
Actually, it's 3:30 in the morning. I'm in Salt
Mountain
Lake.
zone?
I'm in mountain zone, so it's 3:30.
So you had a sleepless night, sir. Thank you for sparing your sleep for the cause of our academy in India and my other pathologists in India. So over to you, Raj Warrior.
Thank you very much. Okay, guys, thank you very much, Pradeep. And as I said, I've known Pradeep for many years. I'm Pradeep's son. I don't know if you know, he was playing international cricket league for Bahamas. I'm very proud of him. I used to play cricket with him. He's a very good sportsman. Thanks a lot, Pradeep. And I also want to thank Dr. Das, who'll be very patient with me with a lot of questions I've asked him. But more important, Dr. Shilpa. I hope, Pradeep.
Yes, sir.
Give Dr. Shilpa a raise. You've been very, very kind, very helpful. So
Yeah.
make her give her a salary, okay? She's very helpful. So as he said, I love to teach, and I travel all over the world teaching. I'm a professor in many universities. I don't want to, but basically I want to show this because they all demand that I show where I teach. So I teach a lot of medical schools across the country and the world. So I have fun teaching. This is actually Manipal, where I'm most proud of. But I'm a student of Manipal. I studied in Manipal, did my MD, DCH, Pediatrics in Manipal before I came to the United States many years ago. I have questions for all of you guys. Like Pradeep, I like to ask questions. Anybody, even the staff can ask me, what is wrong with this picture here? Anybody in the audience? What is wrong with this picture? It's a clinical question, observation. 10 seconds. Anybody in the audience? Even pathologists can answer. Anybody in the audience? What is wrong with this picture? Anybody in the faculty? 10 seconds. 1, 2, 3. Anybody? There's only one leg. See that? So as a doctor, the first thing you do is you learn to ask questions, look at the patient carefully, examine the patient, make a diagnosis, and then rarely, please don't raise your hand, just unmute and answer me, okay? So only one leg, okay? Same thing, this patient, I want all of you guys to just relax, don't take any notes, just sit back, relax, and listen carefully, okay? So we're going to talk about pediatric cancer and genes, and hopefully have some fun. So just, it's late in the day, so just sit back, relax, and have some fun, okay? I want to thank my colleagues. You can say I'm fading off. I'm 75 years old. I'm still working clinically, but I'm going to fail. Next 1 year, I'll cut off my clinical activities. So my colleagues were all either MD, PhD, plus transplants. These two are my students who work with me. So I love my colleagues, and I love my patients. This is my patient who is cured of leukemia. We have a camp for children with cancer. These are my medical students who help me run the camp, okay? This will show you that we work as a team, students, nurses, patients, all of us work together. And we had a tough time the last 1 year, 2 years because of, I love to come to India to teach, but because of this slow moving trains like the coronavirus, I've not been able to make it. So I'm really sorry that I'm not there in person to spend time with you guys. Also, we have and pediatric hemong. We usually generally very good looking, intelligent, handsome people. We have a lot of fun. These are my nurses. We got dressed up for our functions like Mardi Gras, etc. Again, I love my medical students. This is one of my teachers. I was listening to Dr. Vinay Kumar, basic sciences. Being an Indian clinician, I didn't like basic science at all. This is Dr. Susamu, taught me how to work at the lab. This is my first fellow from many years ago, in the 1970s. He's retired, I'm still working. Okay. I want to show this picture because I want all the students, there are students, residents. Please remember, as a medical student, as a junior faculty, very important for you to, like Dr. Vinay Kumar said, just important, absolutely important for you to write up cases, do some studies. That's how you learn new things. If you don't do that, you will never be very smart. So this is one of my friends from Manipal. I'm sure Pradeep knows, remember this guy. There was Aman Chauhan. He was a third-year medical student. Came to the VC's office. Dr. Varia, please give me something to do. Again, a small project. He wrote a case up. Today, he's an associate professor of oncology, one of the best universities in the country. I got more than $4 million in grants. With a medical student, Manipal, just interested in research. And so please remember, all junior faculty, medical students, residents, take time to write case reports, do some projects, etc. Okay. And this is my latest student who's also just wrote a very good paper. Like Dr. Vinay said, we looked at procalcitonin in malignancies. An excellent original paper, got an award for doing the paper. So all students, residents, please be active and do clinical research, basic science research, and more important, write papers and continue to teach. Okay. So question number 1. This is a poll question. You can all answer your poll questions. Okay, please. What is the difference in genetic background between a chimpanzee and a Homo sapien? I'll give you 10 seconds. Shilpa, is the poll working?
Yes, sir. Yes, sir.
Okay. So 10 seconds, give them 10 seconds. Okay, then we can have that answer. Okay. End poll, very good. So 50%. Let's see what the answer is. And the next slide. Okay, close that. So your answer is C, 1 to 2%. Okay, C. So close to how close we are to the monkeys. Okay, so close. Answer is C. What is the sapien? Does anybody know what a sapien means? Anybody in the audience and the faculty? Anybody? Sapien means, so it means wise. Okay, it means wise. Sapien means wise. So the difference between us and all the other Homo erectus, if we are wise, we can think and do things. So not much different in chromosomes, same chromosomes, but we learn to talk, we learn to think, we learn to work as a team. So it's called the wise man. It's called Homo sapiens. Okay. So I heard Dr. Apaji is an excellent speaker, and I love Dr. Elanthan's pathology lymphoma speech. I learned a lot today from all of you guys. But in cancer in children is a very important disease. Why? Because it's the second most common cause of death in children in the US and many parts of the world. And about 1 in 300 Americans will have cancer. And there are a lot of murders in the US, but still cancer is a very important cause of death in children, in adults and also in children. So we see about maybe 15,000 cases per year in the US. And India is supposed to be more than 60 to 80,000 or more. That's very important. And as Dr. Apaji said, we do have a pediatric oncology group in India, a pediatric hematology oncology group in India. They're doing a very good job and I'm very proud of them. We have a special group called AYA, adolescent and young adults. Just now, Dr. Elanthan talked about the lymphomas. So this group between 15 to 30 behave very differently from other age groups. They had very poor prognosis because they were caught between adults and pediatric. They were not on studies. So we formed a group called AYA, which includes all cancers common in children between 15 and 30 to 40 years. So if it's a non-Hodgkin's lymphoma, 40 years, they're taken care of a pediatric oncology along with adult oncology. So it's called AYA group. Okay. And another important factor for all of us to remember, so by 2025, 1 in 300 children less than 20 years will be a cancer survivor. So all of you guys in ophthalmology, radiology, medicine will be seeing pediatric cases who are cured who come to see you. So you should know about cancer in children, how they recover, what the sequelae are. It's a very important point to remember that there will be many patient survivors that will be seeing other specialists. So overall, you heard Dr. Apaji say that, you know, when I was a medical student in the 1960s, if you had leukemia, we would say, go to the temple, church, or mosque, pray, and you're going to die. 20% survivor. Now it's almost 95%. All tumors, just in my lifetime, from 20 to 30%, it's gone up to mostly to 70, 80% of almost all pediatric cancer. If you have pediatric cancer, about 70% survive. With leukemia is 95. With Wilms tumor is 98%. So tremendous improvement in survival, mainly because of pathology, molecular biology, blood transfusion, infection control, not so much because of oncology. Basically, tremendous improvement. If you say leukemia alone, you can see here, it's almost 95% for the classic, ALL, pre-B, with good markers, almost 95%. So tremendous improvement, thanks to pathology, surgery, all working as a team together. So I'm going to talk about genes and cancer and environment. I hope you can, I'm going to talk to mostly at medical student, resident level, because some of you have professors in pathology, so surgeons. This is just an overview, mainly meant for residents, medical students, and PGs. Okay, so I hope it's not too low below your standards. And I want to remind you that, unfortunately, my medical school days, I was not a great student. I was mostly a lazy guy who play cricket, tennis, and run around most of the time. But we didn't teach them about genetics, immunology. But fortunately, I did 6 months of pathology, so I learned a lot of stuff during my pathology. As part of my hematology fellowship, I took 6 months of pathology to learn. So I learned a lot of pathology during that time and learned some genetics also. Okay, so genes are very important because they can cause disease. We just read about all the different genes that can cause disease. It's used in diagnosis. We just heard the pathologists talk about diagnosis. A lot of genetic, every pathological diagnosis now got a genetic disease. So you have a round small cell tumor. When I was a medical student or pathologist, a resident said, oh, it's a small round cell. What is it? I don't know. It could be lymphoma, leukemia, neuroblastoma, even sarcoma. But now every disease, you got a genetic marker or immunophenotyping to make out what the diagnosis. Prognostic classification. You heard Dr. Pajis talk about leukemia. ALL is not diagnosed anymore. ALL is hyperdiploid, DNA index, Philadelphia chromosome, so prognostic classification. In fact, for AML, there's no more M1, M2, M3. It's classified as presence of genetic markers or not. So genetics makes a big difference in classification and prognostic classification. It's high risk, low risk, etc. Drug resistance and pharmacogenomics. Genes play a very important role. For example, 6-MP, it's a very commonly used drug in pediatrics. We used to get the same dose, milligram per kg to everybody. We found out that African Americans did very poorly because there could be rapid metabolizers or slow metabolizers. The dose differs markedly. So now we use genomic factors to give the correct dose. So drug resistance and pharmacogenomics. MRD, again, we have pathologists in our audience. When I was a medical student, resident pathology, resident pediatrics, we do bone marrow. And my job was those days, as pediatrics, we do our own bone marrows and look at them. So we had a tough time. We sit and count 500 cells. And Dr. Wari had a headache, migraine, I would miss some cells, call it leukemia in remission, not in remission, 5% blast. But now we know how wrong it is because you got molecular markers, genetic markers that can pick up 1 in a million cell and say child is not in remission, child is still in relapse, do give more treatment. So MRD. So every patient today, like you heard, bone marrow, lymphoma, leukemia, we do bone marrow. Even peripheral blood, you can look for MRD. It's more than, depending on each 0.1%, etc. I would say, is not in remission, requires more treatment. So growth factors, again, we heard about infections, the patient Pseudomonas infection. We don't see it much anymore. You can see that, but when they're neutropenic, we can give them growth factors. Again, these are recombinant gene products. So GCSF, GMCSF, thrombopoietin, erythropoietin. So we can control the blood counts very much by again, genetic factors. Okay. Prevention. If you're familial polyposis in your family history, you can do colonoscopy early on in life or do a colectomy if you want to. For breast cancer gene, like Angelina Jolie, you can do a breast cancer, breast removal. So if you've got xeroderma pigmentosa, don't get exposed to sunlight. So prevention is very important. Genetic counseling. Again, I was asking Dr. Pinay about genetic screening. We have started screening for SCID gene now in pediatric in many parts of the US. And we just picked up a case who was SCID positive. We can treat them from birth itself. They can avoid dying or getting malignant. So genetic counseling becomes very important. So the family can counsel, see who's got disease, and maybe someday in the future, pre-implantation screening can be done. Gene therapy, as you all very well know, both sickle cell anemia, thalassemia, many genetic disorders are doing gene therapy more and more, including, in fact, CAR therapy is part of gene therapy also. So a lot of involvement. So genes are involved in all this part, causing disease, making a diagnosis, all these issues. Okay, so important to keep that in mind. Rhabdomyosarcoma, again, I just heard the pathologists say about lymphoma, same thing, rhabdomyosarcoma, the small round cell tumor, but now we can make out by genetic markers, is it alveolar, is it embryonal, very clear diagnosis, specific markers for all, many cancers. This is a small round cell tumor. No, it could be Wilms tumor, we just saw lymphoma. They all look at the same. So the pathology requires immunohistochemistry and special stains find out what it is. Now you can give me a very clear diagnosis. You just heard him say, oh, such specific diagnosis, DL, what kind of EBV induced, monoclonal, all this can be done by chromosome, molecular studies, immunohistochemistry, and good pathology. So without pathology, without molecular biology, there is no oncology at all. Okay, next question. What percentage of childhood cancers proven genetic etiology or are hereditary cancers? 10 seconds, 15 seconds maximum. Yeah. Can I get some answers, please? Okay.
Majority of them have told option C, sir.
Okay, very good. Excellent. I can see that. Yeah. End poll. Very good. Excellent. Good. That's a correct answer. About 5 to 10% is genetic cancers. Okay. Very good. Excellent. So about 5 to 10% are confirmed to be hereditary with specific etiological. So please remember, it means this is found in the germline series, also can be inherited, recessive or dominant, but most mutations in pediatric adult oncology are somatic mutations. So there are proto-oncogenes and tumor suppressor genes. We'll talk about that in a few minutes, okay? But please remember, all cancer cells are mutated. Otherwise, you could not have cancer. So but some of those mutations are what you call driver mutations, that's what you call passenger mutations. So every patient has got with cancer got mutated, but some of them are cause of cancer, some of them just there. Should we learn what those are? Are they causing changes in clonal evolution? Are the cancer stem cells? Role of somatic mutation, we'll learn pretty soon what this might mean, okay? Then there are epigenetic factors, environmental factors, methylation, maybe environmental factors that affect them. So it's a combination of you're born with some abnormal genes, then if you've got good genes, live in the Himalayas, you may never get cancer. If you've got bad genes, live in Louisiana, you will get cancer. It's a combination of genes and environment. So when I was a medical student, Dr. Pradeep will remember that Dr. Krishnamurthy was a famous pediatrician. I was not a very good student those days. I used to play tennis and run around, but he was my partner. So my tennis partner. So one day he asked me, Dr. Raj, what causes cancer in exam? I said, I don't know, sir. So don't worry, nobody knows because it's unknown. But we can't say that anymore because we know that can be genetic, can be environment, especially radiation. We dropped a bomb in Hiroshima, they're still getting cancer. Smoking is well known to cause lung cancer, asbestos, mesothelioma. Immunological deficiency, very important, but immune deficiencies, just like you said earlier about PTLD, people with bone marrow transplant or especially liver transplant, they get immunosuppressed. EBV can cause malignancy, so immunodeficiency leads to malignancy. Autoimmune diseases, especially SCID and Wiskott-Aldrich syndrome are examples of immune deficiencies. So people think that we get abnormalities pop up, all of us now and then, but your immune system suppresses it. If you're deficient, you get malignancy. Infection is really important because, again, you just heard the pathologist talk about HIV, HPV, EBV, hepatitis. These are all viruses that can cause cancer. Please remember, for all of the students, residents, young people, all of you should take the HPV vaccine, boys, girls, everybody. It's a cancer vaccine. You can prevent cancer. Hepatitis is a cancer vaccine. Everybody should take it. So make sure that these are things that hepatitis B vaccines or hepatitis B, I'm sorry, hepatitis B, HPV vaccines can prevent cancer. Again, Chronorchis is a parasite found in Korea. It's predisposed to cause cholangiocarcinoma. Some hematoma cause bladder cancer. So please remember, not any more unknown, can be genetic, environment, immunological, infections, and known etiology. So again, I'm not going to go, this all of you know about cancer cells, the normal cells, you get a proliferation, local invasion, metastasis, that's carcinogenesis, okay? Again, what causes cancer? Genetics, environmental agents, infections we talked about. I just want to add obesity because there are more and more studies that show if we just eat too much food, if we just eat too much fat. For example, if a Japanese guy, you never get any colon cancer at all. You move to Hawaii, insulin goes. If you go to America, just like Americans. So a lot of it is physical activity, what do you eat? So please keep that in mind that as you become more obese, less physically active, eat more meat, eat more calories, risk of malignancy is going to go up, in addition to environmental factors. Am I too fast for you guys? Pradeep? Anybody think I'm speaking too fast? Anybody in the audience? Philpa?
No, sir. No, sir. No, sir.
If you have any
Yes,
questions, please feel free to stop me anytime, okay? So
Okay,
genetic, okay, sporadic. So most cancers in pediatrics are sporadic. Familial, about 15 to 30%. And hereditary, about 5 to 10%. Please remember, familial does not mean hereditary. Family is a combination of hereditary plus environmental factors. Because there are some cancers, for example, I will come in a minute, that are familial but not necessarily hereditary. So keep it in mind, most of them are sporadic. Especially adult cancers, almost all of them are sporadic, hereditary and familial. So as I told you, the driver genes are the ones that give you the proto-onco genes and could be tumor suppressor genes. So they're called driver mutations, specifically that give you that. And can be, again, like a pathologist said, I was very impressed by his talk, can be specific genes that are causing tumor suppression. And I'll go through some of them. So P53 for many types of different cancers, the tumor suppressor gene for many different cancers. Many of them are called passenger mutations. What the role is, we don't know. I said they develop during the cancer. They might have a role in developing resistance, maybe new mutations, maybe role in metastasis, but we don't know. But these are called passenger mutations. Again, this is the principle of malignancy. A normal cell, there's some mutation happens that causes the cell to clonal expansion. The more driver mutations, than a malignancy. Typical example is in the polyps. Again, I know I myself go for colonoscopy every time they find a polyp and remove it. Hopefully I'm in good shape, but basically it's a normal epithelium, the small adenoma, mutation happens, you get a larger adenoma, becomes malignant. So with the colonoscopy, find it at this stage in time, remove it, chance of malignancy become less. Okay, so this is clonal proliferation. So proto-oncogenes, the activated proto-oncogenes give rise to they make cells proliferate at many mechanisms. I can't go through all of them, but many mechanisms, they proliferate, but they prevent from being killed. Okay, so no apoptosis. So proliferation, lack of apoptosis because of proto-oncogenes. Can be gain of function mutation, amplification, point mutation, frame shift, so many things that can make you have gain of function. The tumor suppressor genes, if they're not there, you get malignancy. Best example is retinoblastoma. Apaji showed a beautiful picture of retinoblastoma, best known as retinoblastoma for tumor suppressor genes. Okay, so these are, we'll talk about the roles, lost. But if you have tumor suppressor genes absent, activated proto-oncogenes genes, you get malignancy. This is a slide I borrowed from Cell just to show you things have changed dramatically. Again, I was very impressed by the speakers today. They said so many things I'm going to show again, but this is a good example of how hallmarks of cancer can proliferate, signaling, abnormal signaling, can evade growth suppress, very important, they can prevent, so the cells don't die. There is a cell that no apoptosis, keeps on multiplying. So defective chromosomes, they keep on multiplying. Activates invasion metastasis. If the cells don't, if the tumor goes in the kidney alone, the kidney may die, but it goes to other parts of the body, metastasis. Enabling replicative mortality. So the cells can keep on multiplying. And if the cells have to grow, it requires blood supply. So inducing angiogenesis, these are all factors involving having a cancer. Why does that matter? Because we have now learned that the cells can avoid immune destruction. They hide from, just like HIV and tumor promoting inflammation. Again, pathology has taught us for many, many years that chronic inflammation leads to cancer. I remember when your medical studies were Kashmiris, smoking cigarettes, or keeping things in the chest getting malignancies, so promoting inflammation, avoiding immune destruction, and again, instability and mutation that make you cells grow fast but not be killed. And this has really become very important. It's called metabolic. It's no more genomics. It's genomics, metabolics, proteomics, all together, because we now know that many cells require special metabolic functions and they can avoid normal requirements and bypass enzyme system, keep on growing. So these are all emerging hallmark. The reason I'm showing all this is because now we are able to target treatment specifically at this. We can get targeted treatment looking at these specific factors in oncology. Okay, not so. I was taught to give incretin, actinomycin, the adriamycin. But if you guys, the students become oncologists, all they'll be gone. They'll be mostly targeted therapy, like a specific marker, specific peptides, etc. Not anymore what like we know, incretin, actinomycin, and all that. Okay, so here you go. So treatment based upon specific factors. Okay, avoiding immune destruction. Okay, telomerase inhibitors. We'll talk about in a few minutes. Selective anti-inflammatory drugs. Okay, we use VEGF signaling. We use a lot of that medications for some types of malignancies. Okay, so make things like the cells go into apoptosis, and a lot of metabolic inhibitors finding out. So these are all things based upon what is wrong, specific targeted treatment based upon these multiple factors. So unlike our old chemotherapy agent, a lot more targeted, more precision medicine based upon genetic molecular factors. So pathology, genetics, molecular biology is a major part of oncology today. Again, I can't go into detail, but it's a proto-oncogene, can be gene amplification or gain of function mutation. For some reason, the cell begins to grow more and more, and you get a malignancy. This is again, gene amplification is a proto-oncogene, amplifies, so it becomes multiple samples. So just for example, in neuroblastoma, you heard about neuroblastoma, there's an NMYC oncogene. It's not only cause of malignancy, it's used for diagnosis, also for prognosis. So NMYC is amplified multiple times, more than 10 times the number, prognosis poor. If it's not, the prognosis, so we can decide is prognostic classification plus classification based upon the multiple of these markers. So this activated oncogene, example MEN2, so gain of function mutation, RET oncogene, and you get high incidence of medullary carcinoma thyroid. It's not a common cancer in pediatrics, so but we are very concerned because the mother or father has got RET oncogene. It's so common that we do prophylactic thyroidectomy by a couple of years of age, sometimes even the first year of life, because it's a rare cancer, common in children of parents with the RET gene. It's very important to keep it. So this genetic defect, you do prophylactic thyroidectomy to prevent thyroid cancer in children. Okay, and another question for you guys. Anybody in the audience? Can we do the poll again? Dr. Shilpa, 10 seconds.
Yes, sir. Yes.
I'm sorry to keep bugging you, but you've been very helpful, so I'll bug you even more. Okay, so that's 15 seconds. Anybody? It's a trick question. Very good. My God, you guys are too smart. I can't teach you anything at all. Pradeep, you got a good crew there, okay? So it's Rett syndrome is not malignancy. It is a syndrome found in children, mostly females. It's a neurodegenerative disease, but this is all malignant, pre-malignant. Ataxia-telangiectasia, Fanconi, NF, Down syndrome can get cancer, but not Rett syndrome. Okay, very good answer, very good. You guys are too smart for me. So it's a neurodegenerative disease, not MEN2 caused by Rett oncogene. So different spelling, different gene. Okay, so okay. One more question. Anybody wants to answer this? 10 seconds. Shilpa, one more. This is one of my last questions. Okay. Anybody? Yes, let's get the poll and see whether. Can you guys poll for me? Are you all awake? Okay. Okay, no. Well, listen for us. Okay. Very good. Actually, I'm surprised. I'm going to change my opinion of you guys. It's actually many wild copies of P53 is the correct answer, okay? Not telomerase. So it's a tumor suppressor gene. We have got only one wild copy. Okay, it's changing now. Very good. The correct answer is D. Okay, correct answer is D. Not. So elephants have got almost 39, 40 copies of the wild copies. So in you and me, if this disappears, you're going to get osteogenic sarcoma, retinoblastoma, some kind of lung cancer. So, but in elephants, they've got almost 40 copies of this gene, so they don't get malignancy at all. Okay, very uncommon. So they live for a long time, but they don't get malignancies. There are people studying to find out, can we do this genetically in human beings? Because if I got to a couple extra tumor suppressor genes, it may avoid some cancer. So good example. So cancer, elephants live long time, not because of telomerase, but they get because of extra copies of P53. They rarely get the cancer at all. Okay. Okay. So this elephant again, being from Kerala, I love elephants. So P53 is a very, I can't go into detail, but again, very important tumor suppressor gene, multiple roles, especially cell cycle arrest. So what happens is that normally in all of our bodies, as cells multiply, their abnormal chromosomes pop up now and then. So when it comes to multiplying, P53, AT gene says, no, you got abnormal chromosome, don't multiply. Go back to the class, sit down, listen to Dr. Warrior again. When you're normal, come back and multiply. But if there's missing, these cells multiply. So you get a clone of cells that are with abnormal gene, abnormal chromosome, get a leukemia. That's what happened. These cells don't die. no apoptosis, and they multiply rapidly, so you get lymphoma. So tumors, okay, it's called there's tumor suppressor genes. Retinoblastoma is the best example. This is very important concept for all of you guys. Please remember, this is called the two-hit hypothesis. And I know Dr. Knudsen is a pediatric oncologist from Sweden. So I'm very proud of pediatric oncology. It's called the two-hit hypothesis, multiple hypothesis. You are born with, most cancers in adults, especially sporadic. You're born with normal-looking genes. One first hit could be, I don't know, maybe infection, or could be radiation. You get abnormal defect. Then second hit, you get cancer. So two hit here, whereas genetic like retinoblastoma or ataxia-telangiectasia, you're born with defects. Second hit happens, you get malignancy. So in general, hereditary cancers happen early on in life. Okay, and that's but other can happen much later on in life. This can be sometimes bilateral, multifocal. This takes time, and that's why the difference in outcome between pediatric adult cancers is very important. You just heard pathology about lymphomas, non-Hodgkin lymphoma in children. I'm telling you, it's almost 90% survival. They have such good chemotherapy, such good care that almost 90% of most lymphomas survive. Hodgkin disease is 95%. So the tumors in children are different from tumors in adults. So as an example, the proto-oncogenes. Best example is neuroblastoma and non-Hodgkin lymphoma. That's where you see MYC oncogene studies, NMYC oncogene studies. Anti-oncogene, best example is some forms of breast cancer, but most important pediatric is colon cancer as an example, but retinoblastoma is the best example, and Lee-Fraumeni syndrome, so tumor suppressor genes. Okay. But if anybody has any comments, please feel free to stop me. I like being interrupted. So anybody, Dr. Pradeep, Elanthan, anybody, feel free to interrupt me. I don't mind at all. Okay. So DNA damage can occur endogenously, exogenously, can be genetically, or can be external factors. It can be DNA repair mechanism. I show some pictures. Can be mutation of DNA repair genes. So it can be DNA damage or changes the DNA repair genes. Both of them can cause malignancy. So this is a DNA repair mechanism. Best example is patients with Fanconi anemia, for example. They get abnormal DNA chromosomal breakages. They can repair properly. They get multiple called sister chromatic exchanges and get malignancy. So it can be genome instability mutation. This is the telomerase we're talking about. Always remember, it's like a shoelace. If you don't have the tip there, you can't put it through. This is compared to telomerase enzyme, which makes you multiply cells properly without any. Here's an example. See, this telomere is normally there. If it's not there, they can fuse themselves. And then these cells multiply, and you get abnormal clone aneuploidy. Please remember, hyperdiploidy is a bad thing. Even in ALL, hyperdiploidy, the prognosis is poor. Aneuploidy is even worse. So aneuploidy, hyperdiploidy because of abnormal telomerase enzyme. And you can get cells multiply, they become what immortal cells. So cancer stem cells are immortal, they keep on multiplying with respect to the defect. Some examples you just heard from pathology about non-Hodgkin lymphoma. There are different types. Burkitt's lymphoma can be American type, African type. Hodgkin's disease, a patient with Burkitt's lymphoma. We just saw the starry sky pattern, and they have the 814 translocation. And a good example of proto-oncogene is non-Hodgkin lymphoma. We heard about EBV, atypical lymphocyte. This is not malignancy, but we know that EBV can predispose to non-Hodgkin lymphoma. It's a patient I saw a couple of years ago, the nasopharyngeal carcinoma. It's had epistaxis, had a huge mass. This patient had both EBV and HPV. She had oropharyngeal carcinoma. Only 12 years old, so already had HPV. So this again, both virus and genetic factors play a role in this. This patient with HPV-induced oropharyngeal carcinoma and EBV-induced nasopharyngeal carcinoma. And please remember, all of you guys in the audience, young people, I've got my grandchildren from 11 years of age. Everybody should take the HPV vaccine. So risk of cervical carcinoma, oropharyngeal carcinoma becomes much less. So it's almost mandatory for, just like COVID vaccine, everybody should take. Boys and up to, I don't know what age in India, but some people up to 25, 30 years, you can get HPV vaccine. Prevents at least 2 or 3 types of carcinomas. This is what, again, you just heard pathologists talk about. PTLD is a patient of mine who I have quite a few patients who had, especially cardiac transplant, liver transplant, renal transplant. They're more than BMT. They're very severe immunosuppressed for a long time. It's a patient with EBV-induced PTLD, had ptosis, CNS finding, looked like toxoplasma. Turned out to be PTLD, so post-transplant lymphoproliferative disease. Again, good example of viral infection. immunosuppression, both leading to a tumor again. Okay, it can be different type. PTLD can be monoclonal, polyclonal, can be different types of non-Hodgkin lymphoma. Again, I show this because these are all cases that my students, these are all my students who become doctors now, but papers with me on. Okay, so just to show you that how students, residents are invited to, advised to, sometimes forced to write papers. Okay, otherwise they can't proceed in their academic career. This is neuroblastoma. Again, you heard Dr. Appaji talk about that, but proptosis. This is called stage 4S neuroblastoma. It's a special type where they got. So again, NMIC oncogene is used for diagnosis, as well as amplification gives you prognostic classification. So for amplified NMIC oncogene, especially stage 2, 3, it's a bad prognostic sign. You can think of aggressive chemotherapy and treatment. This is neuroblastoma. So cancer predisposed syndrome is very important. Pediatricians, pathologists to know this because Down syndrome. I always say Down syndrome is not only found in human beings, especially the beluga whale, also Down syndrome. Okay, so it can be found in all animals. I've got pictures of tigers with Down syndrome. This is the patient. So they're called ALL, AML, and we just heard of megakaryocytic leukemia. Ataxia telangiectasia can give ALL and non-Hodgkin lymphoma. Neurofibromatosis, many types of tumors, including rhabdomyosarcoma, different kind of tumors. Tuberous sclerosis, angiomyolipoma, low-grade astrocytomas. Xeroderma pigmentosa, melanoma, and skin cancer. Fanconi anemia, almost all of them they're not treated by AML. Philadelphia chromosome, 19 translocation, BCR-ABL fusion, CML. You can get AL with Philadelphia chromosome also. Okay, and Canute's hypothesis we talked to hit here. Here's a patient with rhabdomyosarcoma, sorry, cafe spot. They can get many tumors, including rhabdomyosarcoma. So Down syndrome is one of my patients who's cured of Down syndrome leukemia. He's almost 25 years old now, 20 times higher than leukemia. And there are many cases called congenital leukemia, called transient myeloproliferative disorder of newborn. Baby was born with a sapphire hematoma, Down syndrome, pale, thrombocytopenia, hepatosplenomegaly, and at what looked like leukemia. But child had transient myeloproliferative. In 2 months, the blast all disappeared. Child became normal, but this higher, they can get leukemia later on in life too. Okay, so you can look for the mutations. In addition to trisomy 21, they also get GATA1 TM mutation that predisposes to TMPD and leukemia. They can also get JAK and JAK-STAT mutations. Okay, so please remember, Down syndrome, leukemia is more common, especially with other mutations that are along with Down syndrome. This is MEN2. They look like Marfan, tall, thin. They have mucosal neuromas. This child's mother had Rett oncogene, had thyroid. Unfortunately, they were in a small town. Nobody realized what's going on. And surgeons just removed the tumor, sent them home. This boy came with thyroid cancer, with thyroidectomy at his age. But nowadays, there's oncogenes present in the family. They follow them very carefully. And thyroidectomy as early as newborn, according to some people, but at least by first during infancy or early age. Okay, so family studies can counsel them genetically. This is some syndromes again, giant bathing trunk nevus. It's called Bloom syndrome. This child is 5 years old. They have short stature. You can call skin lesions, so they get leukemia. This is called Peutz-Jeghers syndrome. Again, they get colon carcinomas, osteomas in the bone, with sarcoma melanosis. Gorlin syndrome, another skin condition, can predispose to CNS tumors. This is Xeroderma pigmentosa. This is actually both the parents are doctors. They have consanguineous marriage. Child had Xeroderma pigmentosa, had malignant melanoma, squamous cell carcinoma, multiple basal carcinomas. Sunlight falls on the skin, chromosomes are broken, they don't get repaired, they multiply and got skin cancer. If you know the diagnosis, you can avoid sunlight, go out only in wearing skin protection, covered clothing, can be prophylactic, and also genetic counseling. Ataxia telangiectasia, walks like a college student, maybe in Manipur on a Friday night, maybe Manipur every night, I don't know, but football game, look at the eyes, it's a telangiectasia. It's called the AT gene, again, cell cycle inhibition. This gene is not there. So I have a doctor called Dr. Kevin Brown, who's a PhD in our lab, who works a lot on this gene. You can put them in the mice, take them out and cause leukemia, make the leukemia go away. So leukemia, non-Hodgkin lymphoma. Important for the autosomal recessive people, if you have the gene in your family, if you get radiation or chemotherapy, you get malignancy because of that. So very important with genetic counseling or ataxia telangiectasia. Retinoblastoma, you already heard about retinoblastoma, but a good example of tumor suppressor gene. It's a cat's eye reflex. You can see the tumor here. So it's hereditary, it can be bilateral, early onset, or it can be acquired. So you talk Lee-Fraumeni syndrome, a famous syndrome, 50% mutation. I just want to mention about Laron syndrome. I don't know if you have heard about this for pediatrician. This is a very interesting syndrome where they have IGF-1 receptor deficiency. So it's required for cells to grow. There's no growth factor, cells can't grow. So they have this receptor deficiency. They're very short statured. They never get cancer at all. They never get cancer at all. But this is normal pituitary growth hormone deficiency. They're small, cute, we call them Peter Pan or cutie pie, no. But here they are dysmorphic, short statured, Laron syndrome, receptor deficiency, 5p13 minus p12, sorry, and they get no cancer at all. Very interesting syndrome called Laron syndrome. Okay. This is Fanconi's anemia. This is the older sibling of the patient. The others are younger sibling. So she's short statured, has got dysmorphic facies, triangular facies. The girl, a 15-year-old girl. Got abnormal thumb, abnormal kidneys, and they have multiple, so there are almost 15, 20 genes that have been associated with Fanconi's anemia, but most importantly, they have chromosomal repair defect, breakage defects, they fuse abnormally, called sister chromatic exchanges. Almost all of them die by the time they're 15 years, unless they get a bone marrow transplant. Okay. This child had a cardiac defect, kidney defect, no thumb at all, and died before we could do anything at all. So it's Fanconi's anemia. We talked about Down syndrome and with leukemia itself. Down syndrome is Philadelphia chromosome. We'll talk about it in a few minutes. Maternal age, older the mother, higher the risk of leukemia in children. Maternal radiation, had a patient with congenital leukemia. This little boy, mother got radiation. That we think that is the cause of leukemia at birth. Fanconi's anemia, leukemia again. Telangiectasia and Wiskott-Aldrich syndrome. This little boy with Wiskott-Aldrich syndrome, diagnosed soon after birth with a bone marrow transplant. He's cured. And doing what's the treatment of Wiskott-Aldrich only is a transplant. So again, in leukemia, sex, race, ethnicity. For a long time, if you are a boy, you have poor prognosis leukemia. We used to give them longer duration of treatment because of CNS disease, testicular disease. But now because of better chemotherapy, the prognosis is the same. Race, for a long time, African Americans have poorer prognosis because of, we don't know, maybe because of 6MP, the genomic factors or other, and ethnicity. So right now, this is all almost changed, but we're the same prognosis. So I told you we use diagnosis and prognosis. Hyperdiploidy for leukemia. If you got hyperdiploidy, the prognosis is better. Explanation, maybe they got rapidly multiplying cells, respond better to chemotherapy. For hyperdiploidy, aneuploidy, prognosis is poor. So chromosomes, again, I'll come to that in a minute. Leukemia itself, there are different prognostic factors based upon chromosomes and molecular study. We talked about MRD already. She's a patient of mine. Actually, I just want to show off. First patient leukemia almost 40 years ago. He's cured. He got married, came with his family, and we diagnosed, they're all doing well. I said, now you got so many children, you're productive, go and produce some other way, go and study. You went and studied, became a policeman, the chief of police in the town nearby. So you get a ticket. If you get in trouble, come and call me. I can, for a small amount of fee, I can settle it for you. Okay, so professors don't get paid very much in America. You have to take some bribes now and then. Okay. Here again is a picture showing leukemia. Here's Dr. Warrior, handsome, good-looking young man. But these are all children with leukemia, same age, same time, same diagnosis, same chemotherapy, same doctor. But these three girls are now finished college, doing well. This boy died from his leukemia. This boy is at an Indian birth, got a transplant. So for a long time, girls have better prognosis. But right now, it's the same. Okay, so again, this is showing the leukemia. So many. I can't go through all of them, but ETV16, RONAC, so many hyperdiploid. So we can do so many markers. All of them are used for prognostic, but mainly ETV6, RONAC, hyperdiploid chromosome, you can see Philadelphia chromosome here, MLL genes. So a lot of, every patient that we see in our system today, every patient, whether lymphoma or leukemia, we do sequencing now to find out what are the new things or the old things, can they be used for diagnosis. So every patient gets genetic sequencing done for every tumor. Okay, so leukemia again, you can see for leukemia, it used to be just in the olden days, age of the patient, sex of the patient, white blood cell count, T cell, B cell, but now we've got so many markers. Because it's favorable, got 1221 translocations, we've got tele-ML1, unfavorable, we've got Philadelphia chromosome or MLL4. So these are all, at the end of 1 week, 1 month, we've got all the prognostic factors, all the markers back, we decide the high risk, low risk, standard risk. The low risk, they get less treatment, high risk, they get more treatment. So that's the principle. Again, other prognostic factors, BCR with a poor prognostic factor. They also get TKI and imatinib sulfate as part of chemotherapy. So prognosis, diagnosis, treatment are all based upon pathology and molecular biology factors. Okay. I just want to tell you a small story. I hope I still got time, no, right? Okay, I'll try to go a little bit fast. But this is a little patient of mine who was diagnosed. The first baby died with skin before he was diagnosed. Okay, second baby was diagnosed at birth. So my hospital did a bone marrow transplant. He was cured. But the mom was persistent. Another boy and had skin again as a boy. So we decided to transplant. He said, no, I don't want to transplant to a 1-year-old man. I got better. I'm going to go to France, to Paris to do a gene therapy. So we're fine. They went to gene therapy, came back. We looked after him. After about 1 year, 15 months or so, he got leukemia. So I called my colleagues in Paris. The doctor, no, doctor, worry, not because of our treatment, because they live in Louisiana. It's a bad state. You got leukemia. I said, okay, fine. We started treating him. And then here's a patient with MRI has come back. MRI thymus has come back. So antibodies are gone, doing very well, but then got leukemia. So okay, this is what I call for the pathologist. I'm a bad pathologist. I call monotonous, monomorphic, like a convent school, all wearing uniform, ALL. Happened with T-cell ALL. So after 6 months, the gene therapy guy called me. Dr. Worry, I'm very sorry. I want to call you back again because out of 18 patients, so almost 9 or 10 developed T-cell leukemia. They found out that what happened was it's called insertional tumorigenesis. They are using a lentivirus for transferring the gene. It is not completely inactivated. It got attached to it's called LMO2 site and cause malignancy. So 2 examples: one, viruses can cause cancer, genes can cause cancer. It's called insertional tumorigenesis. So they suspend all gene therapy for some time. My patient survived both leukemia and immunodeficiency, is doing well. But just to show you that gene therapy got complications and setbacks, and especially when you use lentiviruses, they're using different viruses now. But can give you called insertional tumorigenesis because causing leukemia. This is the best example I can give you, and also a remarkable finding in leukemia. This boy had priapism, had a white count of 600,000, and so leukemia can priapism also. This is CML. Here for the pathology, I call it a garden party appearance because you can see blasts, you can see promyelocytes, myelocytes, metamyelocytes, polymorphs, everything. Like a garden, a lot of smart boys and girls wearing different clothes are like ALL, which is monomorphic. So it's a garden party appearance. Philadelphia chromosome is positive. No, BCR is positive. That works on TPK enzyme. This is an Indian child, one of my patients who had no bone marrow. So those days, only when I was a medical student, you had a bone marrow transplant or they died. This child had no donor. So this is before, just before when TPK was available, not available to pediatric population. I had started him on the chemotherapy, hydroxyurea, etc. The parents went to, this is a transplant team. This is Dr. Donald Thomas, who is the father of transplant. So we started doing transplant in my hospital in the 1980s. This is Dr. Worry with our transplant team here. It's the first patient we transplanted, actually CML. Okay, he's the patient who's cured now. He's got a job. He's working very well many years later. But this patient's parents, the CML patient, first Indian patient, parents were concerned because they could not get a transplant, and the imatinib cell is not available for children. So they went to this doctor, Dr. Drucker, where they would discover this medicine. There's some Sloan Kettering, but they went and requested, can I start? Can you give me this medicine for my child? Then no donor is going to die. I said, no, I can't because it's against the FDA rule. Ultimately, they went to FDA, my university, my hospital, the doctor. They got the medicine to be given. One of the first children to get this medicine. That's me and my wife. He came to see me in my university. We had dinner together. He said, Dr. Worry, you take the responsibility. If anything goes wrong, you go to jail, not me. So ultimately, the FDA, NIH, everybody, we were one of the first patients to get this medicine orally. And here he is. I don't have a picture. I'm sorry, I don't have a picture. But he's now in his 30s, no transplant. He's in completely continuous remission, no side effects at all. He's a lawyer from Harvard, doing very well. So it's like a miracle how a genetically targeted drug can cure leukemia with no side effects at all, nothing at all. So he's going to get a Nobel Prize pretty soon. Remarkable finding in medicine. Pathology, Philadelphia chromosome, BCR able, tyrosine protein enzyme, imatinib sulfate, and complete remission for many, many years. Good example of how medicine, pathology, molecular biology work together. Another example is APML. Again, you saw pictures earlier of, you can see all the rods, promyelocytes. So when I was a medical student resident, for APML, you always died, almost 90% mortality, and you had to get a DIC. But now we know some mutation 15, 17 translocation is for diagnosis. Also, this is RARA gene, works on maturational arrest. So just give the retinoic acid, called L-retinoic acid, they get cured, no chemotherapy, no side effect, almost 95% survival. So just total change around from before, okay? So progressive molecular-based treatment, targeted therapy, monoclonal antibodies, designer drugs, biological modifiers. There are a lot of new drugs available. Not even oncology, also eosinophil, etc. And targeted cell growth factor is a good example. And Dr. Vinay Kumar talked about NK cells and T lymphocytes. So CAR T is a new form of therapy. It's available also all over the world now. So immunomodulated T cells against specific antigen. So you know the specific antigen, CR chimeric antigen, you can make antibodies against them. Grow the cells outside, infuse the patient, especially for leukemia, relapse ALL, and it's really very effective, very expensive, but it's going to be more and more standard treatment in the future. So you can prevent infection by giving GCSF with herpes simplex. Pseudomonas all become much less because of medication. I know this can't be an answer, but it's a question for you guys. Any of the pediatricians or pathologists, clinicians, what is the diet? If you don't answer, I'm going to ask Dr. Pradeep to cut Dr. Shilpa since does salary for 1 month. Dr. Pradeep, somebody should know that, otherwise they're not teaching them well. Anybody in the audience? Put in the chat if you want. Unmute and tell me. What is this? This is hemihypertrophy called Beckwith-Wiedemann syndrome, big tongue, pot belly, Beckwith-Wiedemann syndrome, called WAGR syndrome, Wilms tumor, aniridia. This is an aniridia. What tumor is this? Anybody in the audience? What is the most common tumor? Pathology, including staff. Chat, anybody answering? Nobody, okay. So tumor is Wilms tumor. Wilms tumor is very common in these people. Next tumor is hepatoblastoma. So if you have this condition as a pediatrician or a surgeon, you have to do ultrasound every 4 weeks, 4 months, 3 to 4 months until they're about 8 years of age, because there's so much Wilms tumor. It's the most common, next hepatoblastoma. It's with the normal kidney, Wilms tumor. So Pradeep, cut salary for Shilpa, okay? And so Wilms tumor, next most common hepatoblastoma. So cancer in families, again, as we look at mental inheritance, cancer principal syndromes, it's usually multifactorial, genes plus environment, can be hereditary or familial. About 5-10% of all cancers are hereditary. This example of hereditary cancer syndrome, we talk about MEN type 2, tumor suppressor genes, retinoblastoma, polyposis, von Hippel syndrome, and of course, sometimes hereditary breast cancer. I'm not an adult doctor, so I don't know much about these things. Lynch syndrome, HBOC, Li-Fraumeni syndromes. So hereditary cancer, 5-10% of all cancers, important for diagnosis because you can manage them better, you can monitor them carefully, you can understand cancer biology, and can counsel risk because you estimate autosomal dominant or risk, what is the risk of other people carry the gene. So breast cancer is commonly inherited. 5 to 15% of breast cancer have this gene mutation. Significant increase of risk, 4 to 7-fold. It's earlier onset, often bilateral disease. Just an example, if you have a breast cancer gene, normal population is 12%, for the abnormal gene, it's almost 50%, 80%. Okay, very important. Okay, this is I'm not a geneticist, but there are a lot of technology available. Sanger sequencing. Here's a mutation here. Here's a wild type. Sorry, my arrow is gone. Okay. Here's a mutation. This is whole genome sequencing. Next generation sequence, you can see here's the patient sequence, here's a normal sequence. The difference. Okay. Again, familial cancers, not necessarily hereditary, combination of complex, it's both inherited plus acquired factors. The risk can be, I'm not a smart guy, but if you're a geneticist or a statistician or oncology, adult oncology can give you the risk. It's called standard incidence ratio. I can tell you if you had this kind of cancer that's familial, what is the risk of you getting that, okay? But not as accurate the Mendelian inheritance. It's called familial cancers. So I want a couple of words about environment. I just want to remind you that all of us live in big cities, Bangalore, Manipur, in Delhi, a lot of environmental factors. I don't want to scare you, but I want to remind you that as a doctor, it's very important to be politically active, environmentally active. And suppose so microwave oven, I always wonder about small children who live combination of microwave oven, TV, cell phones, high energy. These are all things that people think might be. Cell phone is now declared by WHO as a potential, at least to observe carcinogen, including brain. Cell phones, all of us use it immensely every day. Milk, again, especially in America, Canada, India, we want to get more milk. So the cows are given 5 hormones. They're given estrogen, steroids, they're given androgens. So all that goes into your milk. So risk of, especially you can get by 8 years, they've got their breast development, they get pubic hair development, all because of hormones in the milk. So again, this looks funny, but orange juice and cereal, orange juice is grown in Florida. So it's a commercial enterprise. They don't want oranges to die. So if you see these big planes come and spray, it's called EDB, ethylene dibromide. Not to be carcinogenic. Pathology knows EDB is not to be carcinogenic. Okay, cereals, they're grown in Battle Creek, Michigan. There are a lot of rats in the cereals, right? If you go by Kerala, go by Alua, there are the big storage units, different rats running around. To kill the rat, they use phosgene. That's why they used to kill people in Germany. So a lot of chemicals in food. And again, a pesticide is called, it's called Roundup in America. This used for the lawns look nice, but now proven to cause non-Hodgkin lymphoma. Red meat, red dye, so all things that are potentially carcinogenic. Pesticides, the food chain, almost all of our food now, if you eat a grape, if you take an apple and scrape it, you'll find wax, you'll find taurine. So if you want an apple with a worm, buy it because it's a good apple. Buy a shiny apple, don't buy it because they put taurine and pesticide. Okay, so very important. Please remember, a lot of things that we do every day, we are putting ourselves, you can't avoid it, but to remind you that environment does cause cancer. So good example of tobacco causing lung cancer, chemotherapy that we use called VP16 causing leukemia. This is the patient of mine with Hodgkin disease by stage 4, stage 3, so that is old, in the 1970s. We had chemotherapy and radiation. She did have some bad reaction, but she was cured, very happy for her. But 26 years of age with a dentist, she got breast cancer. We evaluated, she had both, her mother, and her grandmother all had breast cancer gene, and she did bilateral mastectomy. But now we know, just like you had the pathologist speak, stage 1, stage 2, and what Apaji told, we get less chemotherapy, almost no radiation, try to avoid combination of chemotherapy and radiation because second cancers are very common. But 8% of children with cancer get second cancer. We want to avoid that, okay? Asbestos and mesothelioma, that about weed killers. Talcum powder has now been, there are many lawsuits in America, talcum powder causing ovarian carcinoma or uterine carcinoma. Zantac and Losartan are commonly used drug. They're supposed to contaminate with a drug that can cause leukemia, some contamination. So a lot of things that we do every day, risk of leukemia, malignancy goes up. So I want to remember about environmental factors, very important for pediatrician, pathologists, all clinicians to remember this. The critical window is exposure, especially when they're growing intrauterine small babies. And cluster of cases are very important. We find you live in Kolar, the multiple number of, at a place called Morgan City, about 100 miles from New Orleans, small town. There are 10 cases in 1 year. So when I looked what happened, they started a new factory to remove waste. They just burned them. And there are a lot of neuroblastoma. Then they shut down and the case went away. So this is any cluster of cases, always worry about some environmental factor. There's a study we did in Manipal and Mangalore a few years ago from people from life science department and our pediatric oncologist, Dr. A.T.K. Rao. This is a study. This is a place near Coorg and in part of South Canara district. Beautiful forests, western hills. Then the farmers became smart. They said, let's not go rice, wheat, because it's not better money. Let's go cashew nuts. Let's do some other pepper estate, etc. So when you start growing cash crops, a lot of money is involved. They found that the insect, there's a little fly, I forgot to call some kind of fly, because there's infestation and death of these cells. So they said, oh, we can't allow that to happen. Let's press endosulfan. Endosulfan is a bad drug made in Germany by a famous company. It's banned in many countries, but because of influence in our country, they were able to spray it also, just like in Florida, spraying it all over the forest. And we found out that in many places, there were no fish, no birds, children started getting anomalies. So they did the study at Manipal with life sciences and Bangalore. They found children who came for hematological malignancies, looked for endosulfan in the bone marrow, pathology, microbiology lab, along with biochemistry did the study. Endosulfan was for the bone marrow of many patients with hematological malignancy. I don't want to get the numbers, but it just showed this definitely positive. And all children in the study with endosulfan came from the sprayed areas. And increases of marrow dysplasia and malignancy noted these children. So can pesticide cause cancer? For sure. We don't know about endosulfan, but definitely it was high in these people. Did it cause cancer? We don't know. But as a doctor, as a pediatrician, pathologist, clinician, please remember to involve your children, your community, and the families. Look at any potential role for pesticides. So don't be happy, smiling, be tough, give them a heart. As a little patient, you can see here how angry she is because she got cancer. Okay. So risk factors. Lifestyle, I want to include lifestyle factors, physical activity, dietary, and medications. This is Manipal River. When I was a medical student, it's all forest. There are no buildings there. We used to go jump in the river, swim around, have fun. But now, I don't know, I'm sure there must be a lot of arsenic chemicals from all around the floor. This looks totally empty. Nobody's running around there. Okay, so. And again, as a doctor, it's very important as an educator, alert clinician, advocate. I don't want to sound like a communist or a socialist, but please remember, industries are very, very powerful. So we were doing the study in Manipal. At that time, we were sued by the company that makes the medicine, saying that it's not science, we are faking it. So even now when I give talks about environmental factors, people come and boo us because the companies pay them to come and sit there and boo us. Okay, so it's really tough. But just remember, as a doctor, our job is to protect children, especially children, but everybody also. As a doctor, they trust you, so counsel them, be involved in activities with the environment. So precision, you heard of precision oncology. There are different types of cancer you can target treatment. Breast cancer is a good example. And then just to show you again, chronic myeloid leukemia, imatinib sulfate. So if you not only in cancer, other fields also, if you've got hematology or factor V Leiden deficiency, you got a lot of females who want birth control pills, you can advise them about what drug to take, avoid thrombotic drugs. Okay, a good example. Okay, in all fields. This is in pediatric oncology. 6MP was the best example. If you got abnormal gene for 6MP, rapid metabolizer or slow metabolizer, those are 6MP changes. Okay. Another good example, breast cancer. If you have chemotherapy alone, chemotherapy with specific molecular markers, targeted therapy, prognosis better. But if leukemia, chemotherapy alone is nothing. You should interferon nothing. Gleevec is almost 95% survival. So in today's pediatric management, we use Gleevec or a substitute. Do transplant only if there is progressive disease, or if there are very bad prognostic factors, or they've completely matched donor. But pretty soon, transplant will become a second option, not the first option anymore. Okay. That's one more about CAR T cell therapy. Dr. Vinay talked about T cells and NK cells. This is an example where you can, if there's especially ALL, CD20 positive, CD20 positive, CD19, you can take the patient's cells from the patient, make an antibody against the particular antigen, grow it outside, and infuse it back again. It's expensive right now, but still becoming a very good second line. People are thinking about bone marrow transplant, especially if there's no transplant donor available. It's a good therapy. And for ALL relapse, this is a good line of treatment. Expensive, but very effective. So just again, brain tumor again, we've got genetic factors, but glioblastoma, very poor prognosis. Most people die within 9 months, but one of the options for treatment now again, CAR T cell for specific antigens, specific peptides, they're trying to do CAR T cell therapy for gliomas. So prevention using genetics, if you know dietary, all of us should eat less calories, less fat, less red meat, and run around. Avoid sunlight. Anybody? Again, talking to Pradeep, I would remind him to ask his son to wear a hat. I'm a dark-skinned person. I play a lot of cricket. I played cricket for Karnataka University, Madras State Schools. Never had a cap in my life. Never knew about sunscreen. I had a best cell. I'm a dark-skinned guy, but got best cell carcinoma. So please, whether in India, Australia, anywhere, if you're in sunlight, wear protection, wear a cap. Tobacco, no smoking, of course, for all of it. Hepatitis vaccine, it's a cancer vaccine. HPV vaccine, a cancer vaccine. For familial polyposis, get colonoscopy done and can do colonoscopy. Genetic screening. I told you, many of our states, we do screening for SCID. SCID is severe combined immunodeficiency, is X-linked, or can be autosomal recessive. If we find a diagnosis at birth, we can start them on chemotherapy on treatment early on and monitor for cancer. So pretty soon, I'm pretty sure in the next few years, they'll start more and more screening. Like 23andMe, it's available as a commercial, but now they're using that also for genetic research and genetic cancer research. So gene therapy, we talked about sickle cell, thalassemia, and skin. So this example of prevention, she had breast cancer gene is positive, she had bilateral mastectomy, we got big news all over the world because of a movie star doing mastectomy. So in the future, as we grow old, as our students become residents and doctors and oncologists, chemotherapy as we know today will go away. I don't know what happened to surgery, etc., but mostly it'll be every patient will have a gene profiling done, specific antigens, specific markers for diagnosis, prognosis, MRD for classification, treatment based upon gene expression and gene variations, and again, newer modalities of profiling, imaging, which is PET scan using particular markers, etc., advanced transplant approaches. So this will be the treatment, not like we know today, giving chemotherapy, removing half the body, or they'll probably go. Most will be directed precision medicine using molecular markers. And so this is the last question. To be a pediatric hematologist, you have to be smart, intelligent, good-looking, kind, empathetic, and more of all of the above. But that includes me also. So we are very kind people. Fortunately, in our lifetime, it is difficult to take care of children with cancer. We've gone through bad times and good times, but slowly, good times are becoming more important. I told you about 70% of my patients live, 90% leukemia, most of Wilms tumor, and those who die, we are doing a lot of research, and almost 90% of our children are on studies. We have a pediatric oncology group, children's oncology group. So they're all on studies, and those who don't do well, we have very good palliative care, end-of-life care, they die in their parents' hands without too much of pain. So I'm glad I studied in Manipal, became a doctor, and became an oncologist, and learned some pathology in that began, and it's a really remarkable experience. So this is a pediatric oncology all over the world. This is in Mangalore, pediatric oncology group. These are all the residents and fellows putting on a patient, the patients sitting on the floor, putting on a drama or a dance program. This is my camp for children with cancer. We take 100 children and their siblings for the camp for 1 week. No parents, no patient, no treatment. I mean, we give chemotherapy, but they have great. I'm the tennis coach. Okay. This is again when patients require chemotherapy, they lose their hair, they get wigs free. We're modeling wigs. But they choose my book because I look so nice. Most of the patients but choose my kind of wig. Okay. So again, my patients at the camp. Actually, so this is my non-Hodgkin lymphoma. He had it twice. He's cured. He's a camp director. This is one of my patients' mom who patient died, but she comes to camp. This is my little daughter who's an anesthesiologist now. She's come to the camp when she's 5 years old. She's grown up now. I mean, actually, her place in Salt Lake City. She's an anesthesiologist, carries on this kind of work. This is one of my patients, leukemia, relapsed twice, but he's cured. Unfortunately, died in a car accident about 4 years ago. So accidents still cause more death than cancer does. Okay. So there's some of the references. And I love my medical students. They graduate, they keep calling me, and so all of you can always call me anytime we want, we can talk. And I just want to remind you, I'm from Oxford and New Orleans. Every year we used to come to India. We kind of a pediatric meeting. This is in Bangalore. And Pradeep knows we bring our trip up there, give us a great time. So my group, 2019, we were in Manipal, Bangalore. We went to, maybe next time we'll come to Kolar. Okay. So all doctors, couple of these, Dr. Baliga.
Yes, sir, you are welcome to Kolar, sir. Welcome. We are waiting for you.
Will you give us some gold too?
I'll give you mine, not a gold.
Okay. Okay. This is like a group of about 15 of us came, spent almost a month teaching in Manipal, Bangalore, Cochin. Okay, so I'll stop there and take some questions. Okay, guys. Thank you very much, Pradeep, for inviting me. I had a great. I hope you learned something, but not too fast.
Sir,
okay.
My pleasure. I'm thankful to you for having joined me.
Okay, thank you very much. Any questions, anybody?
Any questions from the delegates? You can post in the chat box.
No questionable characters.
No, sir. I think I just want to know. Morning, I was just referring preventing cancer in children. Can we? What is the process and research?
Yeah, very good. Absolutely. So
identifying markers.
Yeah, actually, the most. I think you, Dr. Apaji, and you heard the doctor from Velu, excellent talks. So basically, the principle is this: at this point in time, we don't have any newborn screen or any screening for cancer in children. But most important is that when you're a pediatrician, getting good history, the family history of cancer, for example, there's, let's say that two of my siblings are leukemia, or there's somebody has got some multiple parents who got malignancy. It could be environment or genes. So most important is a history and a good physical exam and early diagnosis. In pediatric practice, for Wilms tumor. So my first paper in Manipal was on Wilms tumor. Dr. Madhavan Nambiar was the doctor. We had almost all of them were stage 3 and stage 4. And the prognosis was stage 1, this is 1968, 69. We had 80% survival. So stage 1, Wilms is remove it, one chemotherapy agent, but if it's stage 4, the prognosis goes down to 50, 60%. So most important for us, pediatrics, pathology, medicine, is early diagnosis. Non-Hodgkin's lymphoma, stage 1 is 98% survival. Stage Hodgkin's is, you heard 95% survival. So basically early diagnosis was important. Now, but in the future, a good history, good physical exam, we suspected screening. But in pediatrics, there's no screening for cancer, except for retinoblastoma. But the family say polyposis, retinoblastoma, neurofibromatosis, for example, can screen them more carefully. I told you about patients with Beckman-Wiedemann syndrome, aniridia. We screen them every 4 months with ultrasound. You pick up cancers, you can do organ sparing surgery. Okay? So right now it's mostly early diagnosis. A few conditions like retinoblastoma, xeroderma pigmentosa, familial polyposis, you can screen them for them more carefully. Okay? But I agree with you. Pediatric has a big burden, especially in India. They expect about 60 to 80,000 cancers per year. And as I said, it's very patchy in parts of the, like in Kerala, Karnataka, Madras, care is great. I don't know about the rest of the country and the world, but I know that there are many, many centers in Bangalore. Apache is a good example. Vellore, Madras, and Trivandrum, terrific centers to give as good work as anybody in the whole world. So I think you should be proud of who we are. And I always tell people, I did my MD pediatrics in India and came to America. I was better than most doctors, pediatrics in this whole country. I could board my own. So our training is great, but we just get together, work together, form groups and study. That's all. Okay. How is that?
Hello, sir. So there's a request from the organizers to please unmute the participants so they can ask questions.
Oh, please do that. I would love that.
Yeah.
Please do that.
Hello, sir.
Can you unmute? Yeah.
Hello, sir.
Yes.
Raj Warrior, sir. I'm Dr. Sampath, medical oncology practicing scholar. I'm very happy you give a very sky view on pediatric oncology, from causative to the etiological to the diagnosis, treatment, and everything you covered, and the prevention. Very thank you, sir. And I want to say very few things, comment on it. Compared to the medical oncology and adult medical and pediatric oncology, pediatric oncology has a good survival rate compared to the adult oncology. Yes. I think you agree. And then pediatric has a good tolerance to the chemotherapy. And most of these chemotherapy has a very rough chemotherapy, like vincristine, what you said, cyclophosphamide. They have a good tolerance compared to the adults. That is the one thing. And then high success rate in the stem cell transplantation. I think we have mentioned that one also. And then we have moved to the genetic markers treating in adult oncology. I guess you people also doing. But what I wanted to know is, your practice also 70 to 80% is sporadic cancers, right?
Yes.
Sporadic.
Yes. Most of them, yes.
Most of the time.
As we know it now, I'm pretty sure there'll be. But the main thing is almost all pediatric cancers we can form, like rhabdomyosarcoma, Ewing sarcoma. We all have now specific marker that we have found.
Specific markers. If you don't get any specific markers, do you dig? For example, in adult oncology, we look for the foundation one, and we'll see 250 genes. Do you have anything like in pediatrics?
Yes, as I told you, every patient with oncology today in our system across the United States, pediatric oncology, every patient with any cancer, whether it's for example, let's say it's some potential desmoid tumor, not many, but we still look for markers, find out. One is for research to find out if you have 10 desmoid tumors, find a specific genetic marker, we can say, oh, this marker is found in this. So every patient with cancer, just like you mentioned earlier, you mentioned about tissue repository, genetic. So every patient, we have the tissues banked in our pediatric oncology group, can go back for 10 years, get my lymphocytes from my patients, and every patient has got next gen sequencing is done to find out are there markers or not. It's used for diagnosis, it's for research, it's also prognostic, and hopefully for treatment in the future. But right now, so you ask about pediatric cancers.
Yes.
Leukemia, lymphoma, brain tumors are more common, and in children generally they're mostly hyperdeployed. They respond better to chemotherapy, unlike carcinomas, etc. More of them are sarcomas, lymphomas, leukemias. We never get carcinoma that are slow growing, don't respond to treatment. So that's why they respond better to treatment, because the type of tumor, usually embryonal, the sarcoma, the lymphomas, leukemias, they respond better to treatment and do better in general. That's why we think so. Okay, so.
And you said one more thing. Girls are doing good with leukemia. Do you have any to say why they?
Okay, please remember I said in the past. So I've been doing this for many years. So in the beginning of the in the 1970s, etc., our prognostic factors were age between 1 and 10 years of age, ALL, and that was sex female, and white cow. There's only 5, and CNS disease, only 5 markers there. But we think because in the olden days, our chemotherapy was standard for both. The concept was that the testicle, there was just like CNS blood-brain barrier. It probably was a testicular blood barrier, and drugs did not reach there enough quantities. So when you increase the doses, added new drugs, the prognosis almost. So one of my first papers in oncology was testicular leukemia in boys with cancer leukemia. When we did biopsy for them, we find many of them had residual leukemia in the testes. We stopped chemotherapy and came back. So we used to give them chemotherapy for 5 years. But right now, the drugs are so effective. They cross the blood-brain barrier very well, and they cross the testicular barrier very well. So prognosis at this point in time, in Western, our protocol, prognosis safe for boys and girls. There's an older finding. African Americans and boys did poorly compared to girls and Caucasians.
Sir, do you use imaging like PET CT scan like in adults for your staging?
Yeah, of course. Oh, yeah, of course, 100%. In fact, you heard the pathologist speak. I'm keeping on referring to him because I love Dr. Apaji and the pathology talk. They're supremely good. So, but every patient of ours, especially for lymphomas, we use PET scan as for staging. Somebody asked about a bone marrow. So please remember, the most important thing in cancer is to stage them appropriately. Because if you give them less treatment, you're going to come back. If you're going to put more treatment, they're going to get second cancer. So staging and pathological diagnosis, without pathology, without radiology, without molecular biology, I can't do anything at all. So every patient of ours gets this. We meet, just like tumor board, we meet everybody gets sequenced. But most important is PET scan is done through lymphomas. And some of the tumors, PET scan is very important for diagnosing, for staging, like Hodgkin disease. You give them chemotherapy, the tumor becomes small. Sometimes you got a small nubble of tumors, is it active or not? PET scan will help you because there can be lymph node coming back or tumor. So we had patients with cat scratch disease that look like lymphoma. So PET scan is part of our, especially lymphoma and many tumor studies, the standard part of protocol, PET CT. Yeah.
Good, sir. Good. Okay, CAR T cell therapy, how much it cost, especially because we are not using that much in India.
Yeah, I know, but it's very expensive. It started as in small places, but there are more companies. Everything is like, I remember when I first bought my transistor radio in Manipur, I could not afford it, but now it is given free as more people do that, more companies become cheaper. But right now,
becomes more
it costs
user.
about 300.
Yes.
It costs about almost $250,000. Very expensive, but
very,
again.
very expensive.
But at the same time, again, listen, I'm not a politician, but I want to complain about one thing. In India today, we are not a poor country. Please don't say we're a poor country. Okay, we are not a poor country.
We are not a poor country, sir.
We are better than America in economics and more things. But unfortunately, we spend only 3% of our money on medicine. So other things are all spent on
less than three.
Exactly. So I think we cannot say we're a poor country. We make vaccines, we make drugs. And I always fight with the pediatric colleague, why don't you give everybody pneumococcal vaccine? Well, you give on rich people. So I think the main thing is we have to use the money properly. Dr. Devishe, my medical student, he tells me about how he's going to develop a new CAR T therapy, much cheaper CAR T therapy. So we are very productive, we are very smart, we're smarter than most people in the whole world. But we don't put it to good use because we don't work as a team, we don't work together. So I think we should not stop complaining we are poor. We have enough money, so develop oncology, pediatric surgery. So we can't complain about not having money anymore at all. Okay, but
yes, sir. Yesterday, one article was there. India failed its youth because of the politics, and policy, politics, and one more policies, politics, and one more P. That's what you said is true.
I always tell people. I was in Kerala, and Kerala is a communist country, state. I'm scared to talk there, but I told one of them when they asked the question, if the communist minister did not drive in a Lexus, drove in a Maruti, can cure about 50 people with leukemia. So it's a question of money. Okay, so I think
very we are all very happy to listen to you, sir, and you give a very good, very sky view on this diagnosis. And one more good thing is, we are medical oncologists, adult medical oncologists, we never see you are a pediatric oncologist, you see as a kid, and you go and they will become engineers, policemen.
Yes, absolutely, absolutely.
They'll come back to you with they are also anesthetists. You said, no, those things, stories are very good and very hard.
I have many people who become.
We should also we should encourage this pediatric oncology. Anybody listening to this one, they'll be very thrilled to become a pediatric oncologist.
So, Dr. Sampath, I have a request for you guys, adult oncologists, because when my children get cured, they grow old. Unfortunately, nobody wants to follow them. So, I hope the adult oncologists will learn in a pediatric oncology can follow our patients.
Yes, sir.
Okay.
I agree with you. I agree with you, sir.
Okay, I'm sorry I was so tough, but basically, as I said, we the resource available, we can do much better.
I like it, sir. True, sir. Thank you.
Okay, any other questions? Anybody?
Please come to Kolar, sir, once you come back.
I'll definitely come. Pradeep is a good friend of mine. His son was my
Pradeep sir will definitely be
good next time.
Okay.
Any other question, anybody?
No more
Okay.
questions, sir. No more
Yeah,
questions.
please do. Please.
Yeah, thank you,
please
sir.
ask me.
Thank you.
What is the question? Okay, thank you very much.
Sir, no more questions, sir.
Thank you, Pradeep.
Sir, God bless you, sir. Thank you. Next time when
Thanks
you
a
come
lot.
to India, please visit us, sir.
Oh, we'll definitely come. The whole crew will come there, okay?
Yeah.
So,
Yeah.
thank you.
I may come in February, sir. I'll try to visit you.
Please come and see me. Absolutely, 100%.
Yeah.
Thank you.
So thank you. I think I'll leave it to the host to please close the event.
Sir, thank you, sir. The session was full of zeal and valuable information. Sir, I also thank the both chairpersons, Dr. Pradeep, sir, and Dr. Sampath Kumar, sir. I request Dr. Subhashish Das, sir, organizing secretary, to give the vote of thanks.
Good afternoon, everyone. On behalf of the organizing committee on the Department of Pathology at Institute of Oncology, would like to express my in absence to our founder, R.L. Jalapaji, and also to
Das, you are not audible.
I can't hear you.
Am I audible now, sir?
Now you're audible. You're looking somewhere and speaking. You're not audible.
Okay, sir. First and foremost, I, on my own behalf and on behalf of the Institute of Oncology and Department of Pathology, would wish to express my sincere thanks and gratitude in absentia to our founder chairman, Sri R.L. Jalapaji, and also to our secretaries, Nagaraj sir, and Director Finance, Rajendra sir. I would also like to express my heartfelt thanks to our Honorable Vice Chancellor sir, Dr. Pradeep ji, for his support, guidance, and encouragement. He was the first person to share this idea of virtual CME with us. I would also like to express my thanks to all the speakers, the chairpersons, and the participants for their enthusiastic participation. Last but not the least, I would also like to express my appreciation for all my department colleagues, HOD, and the postgraduates, along with the supporting staff, for their kind cooperation. Thank you, one and all.
Thank you, sir.
Thank you, everybody. Thank you.
Thank you, sir.
See you guys. Thanks a lot, Pradeep. Have a good day. See you.
Thank you, sir. Yes,
sir,
Amma.
I request all the delegates to switch on their videos, sir, for a picture.
Oh, they won't take a picture. Okay.
Screen.
Principal is here, but his screen is there.
I myself not attended complete CME.
Being a pathologist. I know. Shashidhar. Australia Shashidhar. Are you there? I think he's muted. Okay, I think please take your photo and be done with Amma. Thank you. Thank you, sir. Thank you. All the resource persons.
Enjoy.
Right.
Good meeting. Good meeting. Very good meeting.
Very good.
Thank you, sir. Thank you. Thank you.